सेक्रेटरी डॉक्टर सागर मोरे, IMA परभणी. आपण लवकरच कार्यक्रमास सुरुवात करत आहोत. कार्यक्रमाची सुरुवात आणि प्रास्ताविक थोडक्यात जे लाईव्ह जॉईन झालेले आहेत त्यांना मी कळवतो. आपण सुरुवात दीप प्रज्वलन आणि धन्वंतरी पूजनाने करत आहोत. त्यानंतर एक 10 ते 15 मिनिटात आपण आपल्या मेन सेशन्स म्हणजे लेक्चर्स, स्पीकर्सचे मत वगैरे त्याच्याकडे वळू. मी टाइम टू टाइम अपडेट करत राहतो. लाईव्ह चॅटमध्ये काय आपले काही क्वेश्चन आन्सर असतील तर ज्या सेशनमध्ये आपण चालू आहोत त्या सेशनबद्दल काही क्वेश्चन आन्सर असतील तर ड्युरिंग द चॅट आपण ते पोस्ट करू शकता. आम्ही तुमचे क्वेश्चन्स इथे स्पीकरपर्यंत पोहोचण्याचा प्रयत्न करू. आपण काल आणि परवा किंवा मागच्या आठवड्याभरात DG शील्ड ॲप्लिकेशनवर जे रजिस्ट्रेशन केलेले आहेत त्या रजिस्ट्रेशनवर सेपरेट काही आता ॲक्टिव्हिटी करण्याची गरज नाही आहे. आपण फक्त त्यांनी आलेल्या लिंकवर जॉईन होणे, ऑटोमॅटिकली तुमचा डिजिटल प्रेझेन्स त्यांच्यापर्यंत पोहोचला जातो आणि तुमची अटेंडन्स मार्क होते. त्यामुळं आपण दिवसभर या कार्यक्रमात आमच्यासोबत राहता आणि IMA परभणी आणि पॅथॉलॉजी अँड मायक्रोबायोलॉजी असोसिएशन परभणी यांच्या संयुक्त विद्यमाने हा जो आपण कार्यक्रम करत आहोत, रॅशनल अप्रोच टू डे टू डे challenges. It is a multidisciplinary program which will be covering topics from basic topic like anemia, approach to anemia, and ABC of CBC. It will be covered by Dr. Manoj Toshniwal sir, Dr. संदीप मोरे. त्यानंतर आपण बघणार आहोत शॉर्ट स्टेचर that will be presented by Dr. Amol Bukan sir. Lymph node swelling approach, general approach as well as diagnostic approach, Dr. Rupesh Gundawar sir. Thyroid swelling and thyroid function test, Dr. Amol Bukan sir. Artificial intelligence, AI in pathology by Dr. Chaitanya Khillare sir. Culture and sensitivity for various fluids that will be presently co-presented by Dr. Sunil Bhamre sir and Dr. Chaitanya Khillare sir. Cancer care and oncology यामध्ये changing paradigm in cancer care and precision oncology, Dr. श्रीपाद कौसळीकर सर. एक शॉर्ट हे असे टॉपिक्सची लिस्ट आहे. लवकरच आपण आपल्या कार्यक्रमाला सुरुवात करत आहोत. स्टे ऑनलाईन. थँक्यू. Hello. Yeah, good morning, everyone. I'm Dr. Sagar More. We'll be shortly starting with the inauguration ceremony over here by Deep Prajwalan and Dhanvantari Pujan. Right now, the audio was muted for some time. As we continue with the program, we'll start the audio visual soon. There must not be any problem with you. The audio was not started from our side. Please bear with us. Thank you.
Hey, I am going for a vacation where I'll be totally cut off from my business and I'll be chilling.
You might not know what SSL is, but hackers do, and they hate it. Which is
अनाउन्समेंट करा की सर्व मोबाईल
पीपीटी सर कुणाकडे पाठवा
ईमेल
A very good morning, ladies and gentlemen. I, Dr. Snehal Kade,
and I, Dr. Shreya Chandak,
are excited and feel blessed about the role bestowed upon us to conduct today's event. It gives us immense pleasure to welcome you all to this CME on Rational Approach to Day-to-Day Challenges, a multidisciplinary program conducted by IMA Parbhani with Pathologists and Microbiologists Association Parbhani.
It has been almost 2 years since we all have met like this. What could have been a better way than today's academic feast to enter not only the Indian New Year, but also the holy month of Ramadan? Let's make the CME mark the celebration of knowledge.
So without wasting any moment, let's start our program by inviting the dignitaries on the stage.
We accord a warm welcome to Dr. Anil Kane sir, President IMA Parbhani.
Dr. Sanjay Khillare sir, Secretary IMA Parbhani.
Dr. Madhusudan Magar sir, President Pathologists and Microbiologists Association Parbhani.
And today's esteemed speakers, Dr. Manoj Voshnewal sir,
Dr. Sandeep More sir,
Dr. Rupesh Gundawar sir,
Dr. Amol Bukan sir,
Dr. Sunil Bhamre sir,
Dr. Shripad Kosidikar sir,
and Dr. Chaitanya Khillare sir.
Light symbolizes victory over darkness and defeat of ignorance. It marks the beginning of auspicious moments and events. I request the dignitaries to light the lamp and to do the Dhanvantari Pujan, and I request the audience to rise for the same.
असतोमा सद्गमय तमसोमा ज्योतिर्गमय मृत्योर्मामृतं गमय ॐ शान्ति 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 असतोमा सद्गमय तमसोमा ज्योतिर्गमय मृत्योर्मामृतं गमय ॐ शान्ति 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 असतोमा सद्गमय तमसोमा ज्योतिर्गमय मृत्योर्मामृतं गमय ॐ शान्ति 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 असतोमा सद्गमय तमसोमा ज्योतिर्गमय मृत्योर्मामृतं गमय ॐ शान्ति शान्ति शान्ति
To welcome is to show honor. To welcome is to establish integrity. As we say, Atiti Devo Bhava, we must felicitate our honored guest. I request Dr. Naik sir to felicitate Dr. Manoj Tushniwal sir.
I request Dr. Rasar sir to welcome Dr. Sandeep More sir.
I request Dr. Rathod sir to felicitate Dr. Rupesh Gundawar sir.
I request Dr. Smita Magar madam to welcome Dr. Amol Bukkan sir. I request Dr. Smita Magar ma'am to welcome Dr. Sunil Bhamre sir.
I request Dr. Lakhamwa sir to welcome Dr. Shripad Kausadikar sir.
I request Dr. Vijay Bonde sir to welcome Dr. Chaitanya Khillare sir.
I request Dr. Vivek Kulkarni sir to felicitate Dr. Anil Kanil sir.
I request Dr. Bhosle sir to welcome Dr. Sanjay Khillare sir.
I request Dr. Sagar More sir to welcome Dr. Madhusudan Magar sir.
Sir, this is a token of appreciation since you have taken out your valuable time from your busy schedules and have come all the way to Parbhani to share your knowledge with us. Thank you so much.
We sincerely wish that this CME will be a great success, not only as an opportunity to share knowledge and experience, but also as a beginning of long and fruitful cooperation and friendship. I request Dr. Vijay Bonde sir to share a few words about today's CME. May I call upon Dr. Madhusudan sir to deliver the inaugural speech and oblige us with the words of encouragement.
Very good morning to all. It is a great honor to inaugurate today's CME, which is organized by Pathologist and Microbiologist Association of the Parbhani. I would like to welcome all our speakers who came from very long distances to deliver us lectures, and I welcome all delegates who are not in very good number, but yeah. The theme of today's conference is a rational approach to day-to-day challenges, which is a multidisciplinary program. Actually, attendance साठी आपण CBC, ABC of CBC वगैरे कार्यक्रम केले, परंतु इतक्या साऱ्यांना फोन करून सुद्धा आपली अटेंडन्स नेहमी सारखी पुअर आहे. ऑनलाईन खूप आहे. ओके, तर today's topic for our CME are ABC of CBC and anemia by Dr. Toshniwal sir and Dr. Sandeep More sir. Then we'll have Bukan sir's two CME lectures. One is on short stature and other is on thyroid function test interpretation. Then we'll have lymph node swelling clinico-pathological overview by Gundawar sir. Then we'll have artificial intelligence in pathology and recent advances in culture and sensitivity by Dr. Chaitanya Khillare sir. Then we'll have culture and sensitivity in different types of fluids by Dr. Bhamre sir. And lastly, changing paradigm in cancer care precision oncology by Dr. Kausadikar sir. We shall now continue with the further proceedings. Thank you very much.
We are glad to have Dr. Chidravar sir with us. He is our MMC observer. I would request Dr. Ankit Mantri sir to felicitate Dr. Chidravar sir.
Today's CME has been organized with an intent of having enthusiastic interactive learning sessions. Dr. Manoj Toshniwal sir and Dr. Sandeep More sir have graciously consented to be the first speakers of today. Let's invite our first speakers on the stage with a huge round of applause.
I request Dr. Vidya Chaudhary Madam and Dr. Rameshwar Naik Sir to moderate this session. Sir, can we have Dr. Vijay Bonde Sir to welcome our moderator?
Let me introduce you to our first speakers, Dr. Manoj Toshniwal sir and Dr. Sandeep More sir. Dr. Manoj Toshniwal sir has done his MBBS and MD internal medicine from GMC Aurangabad. He has done his DM in clinical hematology from KEM Hospital, Mumbai, and was a gold medalist. He has done his fellowship in leukemia and bone marrow transplant from British Columbia Cancer Agency, Canada, and fellowship in bone marrow transplant at Tata Memorial Center, Mumbai. Along with his multiple attachments at MGM and MIT Hospital, Aurangabad, he is working as the medical director at Jeevan Amrut Hematology Center, Aurangabad. He has been working as a hematologist in Marathwada since 2017 and has diagnosed and treated more than thousands of patients of leukemia and various other blood disorders. He has also started bone marrow transplant unit at MGM Medical College and Hospital, Aurangabad. To his credit, he has 6 national and international publications, 3 national and 3 international poster presentations, and 12 oral presentations in national conferences. Please give a huge round of applause for Dr. Manoj Toshniwal sir.
Dr. Sandeep More Sir has done his MBBS and DCH from MGM College, Aurangabad, followed by DNB at Nanavati Hospital, Mumbai. He has presented a paper at a national conference. He has been practices in Parbhani as a pediatrician. Please welcome our speakers.
Namaste everyone. Namaste sir. Today we have ABC of CBC and anemia. So I will concluding with the anemia one, and Toshniwal sir is looking for ABC and CBC. Good morning everyone. My name is Dr. Sandeep More. Now discussing with the anemia and its classification. Anemia is the decrease in the total number of erythrocytes in circulating blood form or in the quality and quantity of the hemoglobin. There are 2 types of classifications with the anemia we'll discuss, and effects of the anemia now in the decrease in the blood viscosity, hypoxia, increased cardiac output, and increase in workload of the heart. The symptoms of the anemia are various on the various organs. Classification of anemia. Classification on the basis of the cause and on the basis of the morphology of the erythrocytes. On the basis of the cause, blood loss, inadequate production of the normal blood cells, and excessive destruction of the RBCs. On the basis of morphology, it is normocytic, microcytic, and macrocytic. Normocytic normochromic anemia. The size and hemoglobin contents of the RBCs are normal. Number of RBCs are decreased. It includes aplastic anemia, blood loss anemia, hemolytic anemias. In aplastic anemia, there is total destruction or suppression of the function of the bone marrow. It is due to exposure of the drug, radiation, immune diseases, and etc. Microcytic hypochromic anemia. These are the due to abnormal small erythrocytes, abnormal reduced hemoglobin in the erythrocytes. It includes iron deficiency anemia, thalassemia, and anemia of the chronic diseases. It is a major cause, iron deficiency anemia. Most common type is iron deficient in the diet in the Indian territory, and GI failed to absorb the iron. Leads to impairment of hemoglobin synthesis and reduce RBC and hemoglobin production successively. The thalassemia is the most common, second most common in the pediatric age group, abnormal synthesis of alpha and beta chain in the hemoglobins. Two types, alpha thalassemia and beta thalassemia. Now, macrocytic normochromic anemias. These are the megaloblastic anemias. They are larger RBCs than the normal, caused due to vitamin deficiency, that is B12 and folate deficiencies. Then pernicious anemia, it is due to B12 deficiency due to malabsorption of the B12 from the gut. Absence of intrinsic factor is the common cause, and gastric intrinsic factor is the most risk. Gastrointestinal factor is secreted by the parietal cells of the ileum, and that is for the absorption of the B12 vitamin cell. Thank you. Now, next part will be concluded by the Dr. Toshniwal sir. Thank you very much, sir.
Hello. So very good morning as म्हणू तसं बाहेर ऊन आले तरी. So very good morning to all of you. मोरे सरांनी सुरुवात करून दिली, and I'll take the discussion further about complete blood count and new iron molecules. First of all, thank you everyone for coming here for this CME on this Sunday morning. Sunday म्हणजे बऱ्यापैकी परिवारासोबतचा दिवस, पण still we have decided that we'll come together, we will enjoy this feast together. Now we are here to discuss something scientific and have a great get together. Thank you for IMA and also Pathologist and Microbiologist Association, and thank you for arranging this such a nice venue. IMA hall Parbhani सारखा कदाचित कुठे नाही इतका चांगला IMA hall आहे. बऱ्यापैकी CME म्हटलं की तीन गोष्टींसाठी CME असते, आणि तिन्ही प्रकारे ही सक्सेसफुल CME असं वाटतं मला. First, we come here for sharing of knowledge. Overall program looks very nice, and we are sharing knowledge together. That is first thing. Second thing, MMC credit point तेही मिळतात. And third thing, we all are here to meet, to mingle, to discuss something good, to become friends. आणि आज मागच्या वेळेस जेव्हा कडतन सरांसोबत इथे CME केली त्यावेळेस 10-20 जणांची संख्या होती. आज त्यापेक्षा दुप्पट किंवा तिप्पट संख्या तर इथे आहे, आणि ऑनलाईन 100 पेक्षा जास्त सध्या व्ह्यूअर्स आहेत या गोष्टीला. दॅट मीन्स ओव्हरऑल लुक्स लाईक द CME इज गोइंग इन राईट डायरेक्शन फॉर द राईट पर्पज. आय एम नॉट समवन हु इज एक्सपर्ट अबाउट एनिथिंग. आपण सगळेच जण यात एक्सपर्ट आहोत, आणि आपण सगळ्या जणांच्या ओपीडी कदाचित यापेक्षा जास्त बिझी आहेतच. But I just know a little bit more about this complete blood count, and that is why I am standing on this side of discussion. आणि त्यामुळे या डिस्कशन मध्ये इफ एनी क्वेश्चन इज देअर इन बिटवीन ऑल्सो, प्लीज फील फ्री टू ड्रॉप इन ॲज वेल. मोस्ट इम्पॉर्टंट part as a doctor in our life is to find the cause, what is happening, why it is happening. माझे बॉस नेहमी म्हणताना म्हणायचे, anyone can treat, but to diagnose that patient, why that is happening, is the most important role of a clinician, of a doctor. And for there is these are various type of investigation which we all have. Maybe some blood related, maybe some radiological, maybe some clinical clues, and all this part come into the picture to find the cause. And today we are here to discuss about the complete blood count, which is the most commonly done blood parameter for almost every patient. But unfortunately, because of rush, because of the work pressure, because of the many other reasons, we just fail to read it completely. It says complete blood count. It is very simple investigation, but it gives us lot more information than what exactly that strip shows. And let's find today how we can read it completely. Now with day by day timing, we have got automated counting as well now. Very nice machines are available which give much more information than just CBC. Dr. Chaitanya will cover this automation in laboratory afterwards. But just to know, initially it was used to be just the Coulter principle, but now we have got flow cytometry based CBC machines as well, which give many more informative parameters on that. And just because we don't pay attention to that, we miss some diagnosis in that. These are sources of errors which we can have just because sample was not processed properly, inadequate mixing, tube was not good, lipemic sample, cold agglutination, even platelet clumping. So it has to be taken with clinical clue for sure. CBC is wrong, that doesn't mean that patient has that particular problem. 2 days back only I saw one patient, she was here for almost her third pregnancy, now planned for LSCS, and her platelet count was low to the extent that 8,000 was her platelet count. No bleeding, nothing. She is asymptomatic, full term now, 8,000. And now gynecologists have told her that she has to go for fitness from hematologist and then see. Initially physician, then physician referred it to me. Initial 2 LSCS were done for same reason, platelet count being low. Every time given 10 units of platelets, done with every precaution so that she doesn't bleed, except for doing peripheral smear examination. And peripheral smear was showing clumps of platelet. We did the citrate sampling, platelet count was more than 2 lakh. Now no need of LSCS, no need of it, nothing. So ultimately, just looking into the clinical picture was that missed, I would say. So sources of error one must has to keep in mind and then try to read that CBC completely. Initially, it was just 3-part Coulter, but now we have got 5-part, 6-part, even 7-part Coulters are there, which give us these are the main components which are covered in the CBC. Red blood cell indices, hematocrit, and hemoglobin. They are almost the one and the same. Many times I get call from my friends or colleagues. They are like, sir, एक patient है, report सांग दो, hemoglobin 10 है, hematocrit 30 है, RBC count 4.0. These are all one and the same. If hemoglobin is 10, then expected is that 3 times will be the hematocrit. RBC count will be around the same. पण मग त्यात बराचसा वेळ जातो आणि मेन lymphocyte count मिस झाला. MPV बघितल्याच गेले नाही. So we have to pay attention to the main things. These are the main things which are highlighted in the CBC. Less known facts which usually we miss are immature reticulocyte fraction, which is now available with these new machines. With this tropical fever, dengue fever, malaria fever, these parameters are very important. It gives us clue that whether marrow is regenerative or not. We can just see the immature platelet fraction or reticulocyte fraction, and we can say that yes, marrow is regenerative, marrow is hypocellular. We can just give at least एक ठोकता तरी त्यातून मिळतो. Retic count, reticulocyte percentage, mean platelet volume. For that, for one patient, mean platelet volume was 25. That means so large platelets were there. She was supposed to be having thrombocytopenia. Receiving steroids for no reason. Platelet count 30, 40, 50,000. Mean platelet volume 25. Manual platelet count more than 1.5 lakh. So बऱ्याचदा ह्या parameters वरून आपल्याला ते लक्षात येतं. So most important is to see the peripheral smear examination as well along with CBC. So whenever we are seeing some abnormality in the CBC, make sure that you ask that concerned pathologist or morphologist that please pay attention to the peripheral smear as well and give us clue whether there are some abnormal cells, whether platelets are really low, though RBCs are showing some clumping or what. One patient was there supposed to be megaloblastic anemia. 10 different ICUs, every time receiving Vitcofol, just because MCV was 121, 127, 129, bilirubin was on little higher side, and she lands up with hemoglobin of 1.9 even after 15 blood transfusion. That MCV high was because of the RBC clumping. It was autoimmune hemolytic anemia. Vitcofol initially, if it is not working, even after one blood transfusion contains enough vitamin B12 to replace that megaloblastic anemia picture. Giving vitamin B12 lands up with 1.9 hemoglobin, almost gasping. Given steroids, immediately she is better just because it is autoimmune hemolytic anemia. MCV, rather than paying attention, once to MCV is okay, you paid attention, but seeing that peripheral smear, whether some clumps are there or not, that was something which was missed. So these are important parameters in our what you call CBC, complete blood count. Hemoglobin is one of the very important parameter. One thing which I would like to highlight here for clinicians and even pathologists, whenever hemoglobin is low, many a times we say that hemoglobin 8-9 ठीक आहे ते असेलच, but we should not miss thalassemia minor. If RBC count is good and still hemoglobin is low, MCV is low, in those cases we can calculate the Menzer index. That is just a crude method to calculate Menzer index. If it is less than 13, one must ask for that young person to go for HB electrophoresis, so that we can just can't keep on treating them for iron deficiency for no reason, and also diagnose the thalassemia minor so that thalassemia major is not missed. MCV usually आपल्याकडे बऱ्याचदा फक्त MCV कमी आहे किंवा जास्त आहे असं न भेटता they are normocytic anemias as well, because just iron deficiency असं कधी होत नाही. If they are deficient, they are nutritionally deficient for everything, and they get dimorphic anemia, hemoglobin 8-9 and MCV is around 90, because some are microcytes, some are macrocytes. So if it is MCV normal, still it can be a nutritional anemia. If there is no excessive bleeding from anemia, we have to treat both with iron as well as vitamin B12 to those patients. MCH आणि MCSC हे बऱ्यापैकी आपल्याला काही मोजक्या गोष्टींसाठी, MCSC particularly for spirocytes it is very important. If MCHC is on higher side, more than 37, it can be because of hereditary spirocytosis. That can be the one thing which, even new cells are forming, MCSC is high. Even reticulocyte count is high, MCSC can also be high. Autoimmune hemolytic anemia, MCSC is on higher side because of spirocytes and newer RBCs. So MCSC त्यासाठी वापरले जातात. So by MCV, we can just differentiate between these anemic cases into two, three different types. Whenever it is microcytic, more likely it is because of nutritional deficiency unless otherwise proven, but one should not miss thalassemia minor and some rare form of like sideroblastic type of anemias. If it is macrocytic, vitamin B12 folate is very common in our country, but one should not miss MDS in old age cases and hemolysis in cases where there is jaundice associated with this, splenomegaly associated with. And if it is normocytic, it more likely anemia of chronic disease or dimorphic anemia, or even anemia because of some other illnesses. 2-4 दिवसापूर्वीची एक पेशंट होती, anemia, no KFT done. Finally KFT done, her creatinine was more than 8.9 काहीतरी creatinine होतं. Almost 6 months, and for anemia she is getting treated. बऱ्याचदा जर anemia prove होत नसेल बाकी काही कारणाने, one must have to think beyond those routine parameters. Retic count ही खूप handy test आहे, बऱ्याचदा आपण immediately करू शकतो. Many a times these 6-part Coulters are also giving us reticulocyte count reading as well. Even routine lab मध्ये बाजूलाच आपल्याला लगेच होऊ शकतं. If retic count is low, it can be because of hypoproliferation, that is nutritional deficiency आहे किंवा aplastic anemia आहे, chronic disease आहे याच्यामुळे. बरं चांगलं असेल तर then it can be because of the hemolytic anemia or even chronic blood loss is there. So retic count can be earlier side. बऱ्याचदा पण आपण ते मिस करून जातो, how to diagnose these cases. If MCV is less, and पहिले तर आपल्याकडे लोक CBCs करायला तयार नसतात, त्याच्यावर काही टेस्ट करायच्या म्हणजे मग अजून अडचणी जाऊन जातात. If MCV is less, you can straight away start treating them for iron असं बऱ्याचदा वाटतं, because iron deficiency is such a common illness in our country. त्याला illness म्हणून आहे तसं, त्याच्यावर काही असेल पण तरी सुद्धा it is still a illness I would say, because it is such a common thing. आपल्या इंडियन डेटात असं सांगतो फ्रॉम गव्हर्नमेंट दॅट ऑलमोस्ट 50% ऑफ इंडियन फिमेल इन प्रेग्नंट स्टेज दे आर एनिमिक, आणि एनिमिया इज द थर्ड स्टेज ऑफ आयर्न डिफिशियन्सी. फक्त आयर्न डिफिशियन्सी जर मोजलं तर कदाचित 90% वर असेल. त्यामुळे जर आपण MCV कमी आहे, एनिमिया आहे आणि जर आयर्न दिलं तर 90% ऑफ टाइम्स यू विल बी राईट, यू हॅव गिव्हन द राईट प्रिस्क्रिप्शन. बट स्टील टू डायग्नोज जर म्हटलं तर करायचं तर काय असावं, अर्लियर टेस्ट शुड बी सिरम फेरेटिन. इफ सिरम फेरेटिन इज लेस, there is no any other DD apart from some rare genetic congenital hypoferritinemia वगैरह तसलं काही. Otherwise, if MCV is less, it is iron deficiency. You can treat them as dimorphic anemia with both iron and vitamin B12 replacement. If MCV is less ferritin is normal and still you suspect that it is iron deficiency, then you have to go for iron studies. बऱ्याचदा चुकून सिरम आयर्नच केल्या जातं किंवा आयर्न स्टडीज करतो आपण, फेरिटिन केल्या जात नाही. आयर्न स्टडीज मध्ये सुद्धा इफ ट्रान्सफेरिन सॅच्युरेशन इज लेस दॅन 20, there is always a role of iron replacement for many illnesses. Then it can be for congestive cardiac failure, it can be for even thyroid disorder, it can be for rheumatological disorder, it can be for chronic liver disease, because overall functional iron deficiency is there. आणि त्यामुळे बऱ्याचदा ते हिमोग्लोबिन वाढत नाही. That is iron, functional iron deficiency leading to anemia of chronic disease. त्यामुळे तशा वेळेस बऱ्याचदा MCV जर कमी असेल तर आधी सुरुवातीला फेरिटिन फॉलोड बाय आयर्न स्टडीज. पण आयर्न स्टडीज मध्ये एक हे महत्वाचं आहे की वी शुड आस्क पेशंट टू कम इन फास्टिंग स्टेट. म्हणजे फास्टिंग फक्त शुगर साठीच लागतं असं काही गरजेचं नाही. फॉर आयर्न स्टडीज एज वेल वन मस्ट हॅव टू एम्प्टी स्टमक ऍटलीस्ट फॉर 2-3 hours and then we can interpret them rightly. So fasting iron studies is very important. बऱ्याचदा बाकी पॅरामीटर्स थोडेसे वाढलेले असतात, त्यासाठी पण बऱ्याचदा फोन येतो की सर न्यूट्रोफिल काउंट थोडा जास्त असतो, WBC काउंट अराउंड 13-14,000. what can it be? Many times it is because of some infection जर न्यूट्रोफिलिक प्रिडॉमिनन्स असेल तर. बट इफ CBC shows lymphocytic predominance, then something has to do with marrow, काहीतरी marrow failure असू शकतं, न्यूट्रोफिल काउंट कमी असेल तर, then it has to be paid more attention. If WBC count is more than 50,000, 50,000च्या वर असेल, less likely that it is because of some leukemoid reaction or infection related. It has to do something with the marrow, maybe myeloproliferative disorder or even leukemia like condition. अशा वेळेस आपण त्या गोष्टी मिस नको करायला. सो सीइंग दॅट डिफरन्शियल इज व्हेरी इम्पॉर्टंट. बऱ्याचदा पेशंट ट्रीट होत राहतो आणि eosinophil count is around 40-60,000. They have allergic tendency and absolute eosinophil count on higher side. You have to treat that particular condition to get that CBC in normal position. आणि प्लेटलेट तसा तर मग सगळ्या गावाचा जिव्हाळ्याचा विषय. प्लेटलेट काउंट कमी झाला म्हणजे एकदमच म्हणजे आभाळच फाटला असेल. आणि त्या प्लेटलेटकडे खरंच लक्ष देणं गरजेचं पडतं. त्यात एकतर पूर्ण लक्ष द्यावं किंवा कमी लक्ष द्यावं. परभणीची एक पेशंट आहे, सध्या ऍडमिट आहे माझ्याकडे, छाया नाव आहे तिचं. शी गॉट प्लेटलेट काउंट बिंग लो आणि प्लेटलेट काउंट वॉज अराउंड 30-40,000. थोडासा फिवर आला, ऍडमिटेड इन 1 ICU, देन नेक्स्ट अँड देन असं 2-3 ठिकाणी झालं. थोडंसं स्टेरॉइड मिळालं, प्लेटलेट काउंट गोज अप टू 90,000, 1 lakh पर्यंत जातं. रिलेटिव्ह पण लगेच सुट्टी मागायला लागतात, पुढचं काही एव्हल्युशन झालंच नाही. देन शी गॉट मायग्रेन आफ्टर 2-3 months, देन रेफर टू नांदेड. नांदेडमध्ये मायग्रेनसाठी काही गोष्टी सुरू झाल्या. देन नंतर मग काही दिवसात थोडं क्रिएटिन वाढून गेलं. मग परत नेफ्रोलॉजिस्ट वगैरे सगळ्या ओपिनियन चालू. ऑलरेडी थायरॉइड तर आहेच, त्यामुळे एंडोक्राइनॉलॉजिस्ट पण पाहतच होते. असं सगळं चालू राहिलं. अल्टिमेटली देन शी कम्स टू औरंगाबाद अँड देन रिलेटिव्ह एवढा मोठा फाईलचा गठ्ठा ठेवला समोर. म्हटलं एक हिमोग्राम करायला लागेल सर, एकदा स्लाइड बघायची. इतके CBCचे रिपोर्ट आहेत ना, ब्लड काढून ब्लड संपलं. 15 पॅक ब्लड लागल्या. 15 पॅक ब्लड लागले, ब्लिडिंगच होत नाही कुठेतरी, लागलेच आहेत. तुम्ही बघा, पेशंट बघा आधी. म्हणलं आधी CBC बघतो, मगच पेशंट बघतो. तो रूल म्हटलं आमच्याकडे. मग त्यांनी कसं तरी दिलं. रिलेटिव्ह वर लिटल बिट अंडरस्टँडिंग बाय द टाइम. म्हणजे दुसरा एक MRI तो आला आणि बघितलं तर पेरिफेरल स्मेअर वॉज शोइंग फ्यू शिस्टोसाइट्स, ऑलमोस्ट 7-8 शिस्टोसाइट्स होत्या. इट वॉज बिकॉज ऑफ TTP, थ्रोम्बोसाइटोपेनिक परप्युरा. बिकॉज ऑफ दॅट ओनली शी वॉज हॅव्हिंग anemia, autoimmune जे डिस्ट्रक्शन होत होतं ते, थ्रोम्बोसाइटोपेनिया फॉर दॅट मॅटर, मायग्रेन सुद्धा त्याच्यामुळेच. इव्हन जे किडनी फंक्शन वाढलं ते सुद्धा त्याच्यामुळेच. इव्हन जे तिला थायरॉइड आहे, इट हॅज ऑल्सो टू डू समथिंग विथ दिस TTP, कारण की ते ऑटोइम्युन टेंडन्सीज आहे ओव्हरऑल. सो इट वॉज TTP मिस्ड जस्ट बिकॉज पेरिफेरल स्मिअर वॉज नॉट सीन क्लीनली. आणि प्लेटेड काउंट 40-50 हजारच्या आसपास होता. ऍज युजल ते व्हायरल फिवर, थ्रोम्बोसाइटोपेनिया, थोडंफार डेक्झा दिला गेलं की लगेच ते थोडंसं वर येतं आणि असं होत गेलं. आणि त्यात ऑन टॉप ऑफ दॅट प्लेटलेट काउंट कमी असताना हिला तरी नाही मिळाले, पण बऱ्याचदा प्लेटलेट दिल्या जातात. If we give platelets to these patients, it increases the problem. It is like fuel in the fire, because migraine was because of these platelet clumps only. आणि मग अशा स्ट्रोक किंवा दुसरं काहीतरी होऊन जातं. मोर किडनी प्रॉब्लेम arises, more vascular problems arises. So seeing peripheral smear for every patient who has platelet count very low is very, 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 very important. बऱ्याचदा ओव्हर डायग्नोसिस होऊन किंवा अननेसेसरी ट्रीट होत असं किंवा अंडर डायग्नोसिस झालं. नाउ वी आर गिव्हिंग हर डेली plasma transfusion, and with only plasma transfusion today's hemoglobin is more than 9. Her platelet count is also more than 1 lakh. अजून 8-15 दिवसांनी असं कदाचित तिला प्लाझ्मा फेरेसिस लागलं असतं आणि अजूनही 8-10 दिवसांनी आलं असतं तर कदाचित मग कार्यक्रम संपला असतो. बिकॉज सच these diseases are very treatable, but if not treated at right time in right way, things get very complicated. सो प्लेटलेट काउंट त्याच्यामुळे आपल्यासाठी बऱ्यापैकी महत्वाचा ठरतो. सीइंग पेरिफेरल स्मिअर फॉर मॅक्रो थ्रोम्बोसाइट्स, इवन कन्फर्मिंग द प्लेटलेट काउंट, ईडीटी इंड्यूस प्लेटलेट क्लम्पिंग अँड सम अदर असोसिएटेड प्रॉब्लेम्स विथ दॅट. मॅलिग्नन्सी पण बऱ्याच, ही तरी रेअर केस झाली टीटीपी. मॅलिग्नन्सी सुद्धा बऱ्याचदा मिस होतं जस्ट बिकॉज प्लेटलेट वर सपोज टू बी सेकंडरी टू द एपीएमएल सारखे अॅक्यूट प्रोमायलोसाइटिक ल्युकेमिया. बिकॉज megaloblastic anemia is such a common thing in our country. Almost every other person has vitamin B12 deficiency. कारण की आपल्याकडे 7 पैकी 5 वार तर उपवासच करतात लोक, आणि त्यामुळे बऱ्याचदा ते मिस होऊन जातं. and then malignancy when becomes high grade, then it becomes troublesome. आपण त्याला थोडंसं पुढे क्लिनिशियनच्या दृष्टीने या स्टॉकला थोडं कव्हर करूयात, विच इज अ कॉमन प्रॉब्लेम. बऱ्याचदा डिस्कस होत नाही अशा प्रकारचा, की आपल्याकडे कसं ट्रीट करावा आयर्न डिफिशियन्सी अॅनिमियाला. बिकॉज आयर्न डिफिशियन्सी अॅनिमिया, as I have told, 90% of Indian population, Indian females have iron deficiency anemia, and even 50% of Indian adult males also have iron deficiency anemia. पण आपल्याला बऱ्याचदा ते लक्षात सुद्धा येत नाही. त्याला ट्रीट करण्यासाठी आपल्याला 2-3 गोष्टी आहेत, which are either diet modification, which is I think the best and most important way to treat the iron. तिथेच त्याचं मूळ आहे, त्यावर पेशंटची चर्चा व्हायलाच पाहिजे. देन कम्स द ओरल फॉर्म्युलेशन्स अँड IV फॉर्म्युलेशन्स. आपल्याकडे असणाऱ्या ओरल फॉर्म्युलेशनवर जस्ट क्विकली चर्चा करूयात. फेरस फ्युमेरेट हे बऱ्याच ओल्ड एज आहे, बऱ्याच दिवसापासूनच आहे, आणि हे बऱ्याच जण आपण वापरतो. स्वस्त आहे म्हणूनही आपल्याला वापरायला ते थोडं सोपं जातं. इट हॅज व्हेरी गुड रोल, पण बऱ्याचदा याला आपल्याला वन्स डेली देणं तेवढंच प्रिफरेबल असतं, कारण की मोर दॅन दॅट इट इज ऑफ नॉट दॅट युजफुल. इट इज क्वाईट डिफिकल्ट टू टॉलरेट ऑल्सो. बऱ्याचशे GI सिम्पटम्स त्याच्यामध्ये असतात. त्याच्यापेक्षा जास्त चांगलं मॉलिक्युल जर म्हटलं तर फेरस ॲस्कॉर्बेट प्लस फोलिक ऍसिड, ही जी कॉम्बिनेशन आहे ओरोफर XT. त्याच्यामध्ये अजून काही जणांचं झिंक ऍडेड सुद्धा आहे, बिकॉज झिंक अँड ॲस्कॉर्बेट बोथ ऑफ देम आर युजफुल इन इन्क्रीजिंग द आयर्न ऍब्सॉर्प्शन. ओव्हरऑल फेरस फ्युमॅरेट आणि फेरस ॲस्कॉर्बेट याच्यामध्ये जर म्हटलं तर स्टडीज सुद्धा आहेत विच शो सिग्निफिकंट इन्क्रीज इन आयर्न ऍब्सॉर्प्शन. पण बऱ्याचदा काय आयर्न मॉलिक्युलच आहे आणि हे स्वस्त आहे, पेशंट गरीबच आहे, या कारणाने आपण त्याला जी गोळी तो घेऊ शकत नाही अशी देतो. 10-15 दिवस घेऊन वेन दे फील मोर नॉशिएटेड, मोर लूज टूल्स, मोर ॲब्डोमिनल पेन, अँड दे डिस्कंटिन्यू द ट्रीटमेंट. तसं करण्यापेक्षा कदाचित आपल्याला थोडं बेटर मॉलिक्युल कडे गेलेलं बरं. इव्हन आता बरेचसे नवीन मॉलिक्युल सुद्धा आपल्या मार्केटमध्ये आले आहेत, ज्याचं आपल्याला कळत नाही युटिलायझेशन. आपल्याला असं वाटतं की एक आयर्न पिल जी आहे ती 1 रुपयालाच मिळते, दुसरी 8 रुपयाला. आता कसं कन्व्हिन्स करू पेशंटला? बट दीज हॅव बेटर ॲब्सॉर्प्शन, लेस साईड इफेक्ट्स. त्यातलं एक म्हणजे फेरस बिसग्लायसिनेट. हे एक वेगळ्या प्रकारचं आयर्न मॉलिक्युल आहे, दॅट इज कॉल्ड अ चिलेटेड आयर्न मॉलिक्युल. इट इज ऑलरेडी चिलेटेड, दॅट इज वाय बाकी ऍब्सॉर्प्शन सुद्धा जास्त होतं आणि साईड इफेक्ट सुद्धा याच्यामुळे कमी असतात. दॅट इज बिस्पर XT. अजून हे पण एक आलेलं आहे, दॅट इज ल्युपिहिम. बऱ्याचदा ते एक विचारलं जातं ल्युपिहिमचं कसं करावं. इट इज आय थिंक द बेस्ट आयर्न टाइप विच कॅन गेट ऍब्झॉर्ब, बिकॉज इट कंटेन्स द हिम आयर्न, बट इट कम्स फ्रॉम द what you call non-vegetarian source. त्यामुळे थोडीशी एक अडचण असू शकते. but it is usually comes in 12 milligram and dose is twice daily for anyone. बाकीचे जे iron molecules आहेत ते आपण once daily दिलेले बस. twice daily दिल्यानंतर it contains almost 90 to 100 milligram of iron and more than 160 milligram iron if you give in a day. by feedback metabolism ते absorption कमी करतं. त्यामुळे once daily is good enough, but for this molecule you can give it at least twice or thrice daily. हे काही नवीन सुद्धा आलेले जसे लायपोझोमोल, सुक्रोझोमल, बट हे बऱ्यापैकी आपल्या त्या बिसग्लायसिनेट किंवा ओरोफर XT सारखंच बऱ्यापैकी काम करतं. मे बी साईड इफेक्ट्स आर लेस वन्स डेली आणि GI साईड इफेक्ट नाही. जर GI साईड इफेक्ट जर असतील ओरोफर सारख्या टॅब्लेट्स पासून तर मे बी यू कॅन चूज दिस टाईप ऑफ प्रिपरेशन. सो टू समराईज, बऱ्यापैकी आपल्याकडे फ्युमॅरेट आहे, ॲस्कॉर्बेट आहे आणि त्याच्यासोबत फोलिक ऍसिड, झिंक असणारे प्रिपरेशन बेटर. नवीन मॉलिक्युल मध्ये बिसग्लायसिनेट आहे किंवा you call chilated iron or sucrosomal, हिम आयन, या प्रकारचे आयन मॉलिक्युल आपण वापरू शकतो. बऱ्याचदा हा एक प्रश्न येऊन जातो की सर मग IV आयन लावूनच टाकू का? दोज हू डोंट टॉलरेट ओरल आयन दे आर द कॅन्डिडेट्स फॉर IV आयन. अदरवाईज IV आयनचा असा काही वेगळा रोल नाही. त्याच्यामध्ये पण सहज मिळू शकते अशा आपल्याकडे 2-3 प्रिपरेशन आहे. ओरोफरियस आपण बऱ्याच वर्षामध्ये सुक्रोझोमल आयन सुक्रोज बऱ्याच दिवसापासून आपण वापरत आलो, पण याला ऑलमोस्ट अल्टरनेट डे आणि 100 मिलीग्राम करत करत 1000 मिलीग्राम पर्यंत त्याची रिक्वायरमेंट देणं म्हणजे जवळपास 8-10 इंजेक्शन त्याला देण्याची गरज पडते. मॅक्सिमम 200 आपण देऊ शकतो. Gilazo is one brand. There is isomaltoside, one injection dose. It increases hemoglobin to the good range. 1 ग्राम पर्यंत आपण याला सहज देऊ शकतो. आणि तिसरं आपलं फेरियम किंवा ओरोफोरी एफसीएम किंवा एनसीकाब नावाने तर ते सुद्धा आपण सहज देऊ शकतो. These are very handy preparation to treat iron deficiency anemia in right way. Maybe आपण त्याला डायग्नोज व्यवस्थित करणे आणि त्याला व्यवस्थित ट्रीट करणे हेच यामधून आपण सगळं घेऊ शकतो. टू समराइज, लेट्स रीड सीबीसी कम्प्लिटली हे आज आपण ठरवून टाकू. कारण की त्या सीबीसी मध्ये बऱ्याच गोष्टी आपल्याला मिळतात आणि व्हेनेवर देर इज अ डाऊट, make sure that you ask that concerned pathologist to see the smear and confirm those findings rather than randomly treating them. It guides us about further evaluation as well rather than randomly asking for many investigations. Yes, CBC can be a better way to judge. जर आयर्न डिफिशियन्सी असेल तर फास्टिंग स्टेट मध्येच आयर्न लेवल बघाव्या आणि सिरम फेरिटिन कॅन बी अ व्हेरी गुड जज टू डिसाइड वेदर समवन हॅज आयर्न डेफिशियन्सी और नॉट. ऑल आयर्न प्रिपरेशन्स आर मोर और लेस सेम. काही थोडेफार फायदे नुकसान आहेत आपण ते बघितले आता. देर आर न्यूअर मॉलिक्युल्स टू टीज आयर्न डेफिशियन्सी अॅनिमिया अँड वी कॅन मेक शुअर दॅट most of our patients get treated for that common illness. Almost 90% आपल्या ओपडीतल्या आलेल्या 100 पैकी 80 जणांना तर ते असणारच आहे. त्यामुळे आपण जर त्याच्याकडे अटेन्शन पे करू तर जमून जाईल काम. IV आयन इज सेफ. जर गरज असेल तर बिलकुल पेशंटला ते करायलाच पाहिजे. आणि सगळ्यात महत्वाचं म्हणजे आपण पेशंट सोबत त्याच्या डाएट, लाईफस्टाईल या सगळ्या गोष्टींची थोडी काउन्सिलिंग करणं महत्वाचं आहे. सो दिस इज ऑल फ्रॉम मी. थँक्यू सो मच.
I request Dr. Sagar More sir to felicitate Chaudhary madam. Thank you for the lucid presentation, Sandeep sir and Toshniwal sir. Sir, you have rightly emphasized the importance of peripheral smear examination and also explained the interpretation of all parameters of CBC report with detailed clinical correlation. You have also very well explained the rational selection of iron molecules. The topic is now open for discussion.
Hello.
Sir, thank you for your about the CBC count and all parameters that can be that have been you have tell us that in details. We should not afraid about the platelet count and we should see all details count of the CBC. And the now the topic is open for the discussion for the audience.
Yes, sir. माइक नाही जाणार.
विचारतील डायरेक्टली आवाज
Sorry to disturb. The most common cause of anemia, as he has rightly told, iron deficiency anemia, and more common is iron deficiency. याच्यामध्ये मला एकच सांगायचं आहे, we fail to advise the duration of treatment. पेशंट एक महिनाभर घेतो, बरा होतो, बंद करून टाकतो. Again he comes with anemia. So you should, I think, emphasize on the duration of the treatment of iron deficiency anemia. It is pretty longer. मी तर असं ऍडवाइज करतो, जितके ग्राम कमी आहे Suppose the patient hemoglobin is 6 gram, दर महिन्याला 1 ग्राम वाढतं. This is my observation. Give any preparation, it increases by 1 gram per month. 14 minus 6 8 महिने देऊन टाक. 14 minus 7 7 महिने देऊन टाक. Please advise us.
व्हेरी राईटली सेड सर. खूपच महत्वाचा पॉइंट आहे हा. बऱ्याचदा आपण त्यांना ऍडवाइस करतो अँड देन वी ऑल्सो फॉरगेट दॅट ही और शी हॅज टू कम फॉर फॉलोअप. इव्हन पेशंट्स आर ऑल्सो व्हेरी रिलक्टंट. एकदा थोडं बरं वाटायला लागलं की परत त्यांना असं एक वाटायला लागतं की दिस इज मनी मिंटिंग बिझनेस, डॉक्टर वॉन्ट टू एक्सप्लॉइट अस, दॅट इज वाय दे आर आस्किंग फॉर कमिंग फॉर फॉलोअप. अशी लोकांची मेंटॅलिटी आहे. पण सुरुवातीलाच काउन्सिलिंग मध्ये बिलकुल त्यांना क्लिअर केलंच पाहिजे, ऍटलीस्ट फॉर 6 months. आणि सरांनी जो फंडा सांगितला, आय थिंक दॅट इज व्हेरी राईट, दॅट ऍटलीस्ट फॉर 6 months दे हॅव टू टेक द आयर्न प्रिपरेशन. इनिशियल 3 months इट इज पिरियड फॉर मेकिंग नॉर्मलायझेशन ऑफ दॅट हिमोग्लोबिन, बट जस्ट मेकिंग नॉर्मल हिमोग्लोबिन इज नॉट द थिंग. त्याच्यावर आपले जे स्टोर्स आहेत ते रिप्लेस होण्यासाठी सुद्धा पुढे अजून 3 महिन्याचा पिरियड जातोच. आणि त्यामुळे त्यांना 6 महिन्यापर्यंत ओरल आयर्न कंटिन्यू करणं गरजेचं पडतं. अलॉंग विथ दॅट प्रायमरी कॉज काय आहे तो सुद्धा आपल्याला ट्रीट केलाच पाहिजे. बरं, तो बऱ्याचदा मिस होतो. बोलताना माझं थोडंसं राहून गेलं. एक पेशंट मी सुरुवातीला ज्यावेळी जॉईन केला औरंगाबादला, त्याच वेळेस ही केम फ्रॉम अकोला फॉर लो हिमोग्लोबिन सिन्स ऑलमोस्ट मोर दॅन 3-4 years. 3 वर्षापासून तो होतच त्याला. आणि दरवर्षी उन्हाळ्यात त्याचं रक्त कमी होत असल्याचं ऑब्झर्वेशन. ही टेक्स 3-4 units ऑफ ब्लड ट्रान्सफ्युजन. देन अगेन नेक्स्ट समर हिमोग्लोबिन विल बी लो. ही वॉज गॉट इव्हॅल्युएटेड फॉर एव्हरीथिंग. ऑलमोस्ट बोन मॅरो सुद्धा झालेला त्याचा त्या ठिकाणी. आणि परत आल्यानंतर तो म्हणे सर बघा आता काय करायचं याचं, दरवर्षी उन्हाळा की रक्त कमी व्हायला लागलं. मी अचंबित, अरे काय होतंय बाबा सगळ्या गोष्टी. बघितलं तर सगळ्या व्हॅल्यूज मध्ये एमसीव्ही वॉज लेस. म्हणून सर एकदा स्मिअर बघायला लागतं. आता काही ब्लड देत नाही, एवढे सगळे तपास आहे, ब्लड तपासायचं नाहीच म्हणे. काय जे याच्यात सांगा. म्हणजे ठीक आहे सर, ब्लड न तपासता आपण स्टूलची तपासणी करूयात. मग ठीक आहे. And stool for occult blood was positive. He had got necrotizing mass in the colon which was growing since 3 years आणि डायग्नोसिस झाल्याच्या 3 महिन्यात एक्सपायर झाले. याचं कारण, त्याचं कॉज काय आयर्न डिफिशियन्सी अॅनिमियाचं हेच कुठेतरी मिस झालं होतं. आयर्न डिफिशियन्सी मोस्ट लाईकली इट इज बिकॉज ऑफ डाएट फॉर शुअर इन इंडियन फिमेल्स. पण बऱ्याचदा बाकी त्याच्या बियॉन्ड सुद्धा जाऊन आपण बघितलं पाहिजे. वन मस्ट आस्क देम अबाउट मेन्सेस. One must ask them about any other bleeding. One must ask them about their bowel habits. One must ask them about diet habits. आणि त्या गोष्टींना करेक्ट करून along with anemia treatment of 6 months, one must have to pinpoint that particular cause and test that also. That is very important. Thank you, sir. अजून काही कोणाला प्रश्न? Yes, sir.
Sir, I just wanted to ask ki vitamin if we but in babies there are so many issues in vitamin B12 deficiency, like regression of milestone, they become very dull, they are anorexic. So we have found it just giving transfusion vitamin B12 that is not sufficient as of pediatric point of view.
Yes, sir. That is for sure. Thank you for pointing this out. It just the blood also contains vitamin B12, and if you give blood transfusion, अशा वेळेस मग मेगलोब्लास्टिक आहे म्हणून त्याला परत परत ब्लड लागते असं आपण त्याला नको म्हणायला. एवढंच त्यात मला पॉइंट आउट करायचं होतं. Vitamin B12 is very essential molecule in our body, and it presents with various manifestations, right from just darkness of skin पासून तर डायरेक्ट बेडरिडन होण्यापर्यंत. पेरिफेरल न्यूरोपॅथी इतकी सिव्हिअर असते त्याची. असं आय हॅव गॉट वन गायनेकोलॉजिस्ट रिसेंटली, माझा जवळचा मित्र, सिव्हिअर व्हिटॅमिन B12 डिफिशियन्सी टू द एक्सटेंट दॅट ही इज नॉट एबल टू वॉक. MRI करायला लागला. MRI मध्ये मायलो प्रॉलिफरेशन, मायलो फायब्रोसिस असं काही दिल्यानंतर रडतच पोहोचलाय दवाखान्यात एकदमच की सर हे मला मायलो फायब्रोसिस कसा काय झाला. ही हॅज गॉट व्हिटॅमिन B12 डिफिशियन्सी. जेवतच नव्हता दुपारी, ओटी मध्ये घुसला की. तेच कारण, दुसरं काही कारणच नव्हतं. बिझी इन न्यू हॉस्पिटल, बिझी इन प्रमोशन, बिझी इन एव्हरीथिंग, इन व्हिटॅमिन B12 झालं कमी सगळं मायलो फायब्रोसिस होण्यापर्यंत. व्हिटॅमिन B12 इज सच अ इम्पॉर्टंट मॉलिक्युल. त्यातल्या त्यात व्हिटॅमिन B12 लेवल बऱ्याचदा ते एक आपण बऱ्याचदा करण्याचा प्रयत्न करतो. ऍज आय हॅव ऑलरेडी टोल्ड, व्हिटॅमिन B12 इज इंट्रासेल्युलर बऱ्यापैकी. त्यामुळे काय होतं, आपण इथून सॅम्पल देतो आणि मग ते जातं त्या शिवाजी चौकात जिथं लॅब आहे त्या ठिकाणी चेक व्हायला. तेव्हापर्यंत थोडं हिमोलाइज होऊन जातं. 4 सेल जरी हिमोलाइज झाल्या तरी व्हिटॅमिन B12 लेवल नॉर्मल और मेनी टाइम्स वी सी मोर दॅन 2000 अशी काहीतरी व्हॅल्यू आलेली असते. आपल्याला वाटतं व्हॅल्यू तर नॉर्मल आहे, मग याला कशाचं व्हिटॅमिन B12 कमी आलं. इट इज बिकॉज ऑफ लिटल बिट ऑफ हिमोलायसिस. सो व्हिटॅमिन B12 लेवल हार्डली वी डू. थर्ड थिंग, व्हिटॅमिन B12 इज वॉटर सोल्युबल एनिवेज. आपण त्याला जास्त दिलं म्हणून टॉक्सिसिटी काही होत नाही. खूप तर खूप युरिन त्याची थोडीशी पिवळ्या रंगाची होईल, दॅट्स ऑल. व्हिटॅमिन B12 रिप्लेस करणं कधीही त्याच्यामुळे चांगलं आहे. बऱ्याचदा आपण आयडियल डोस इज जस्ट 1000 milligram of vitamin B12 weekly for 4 to 6 weeks. That replaces. But still आपल्याकडे जर वीकली म्हटलं तर 1-2 आठवडे घेऊन परत मामाच्या गावाला गेलो म्हणून विसरून जातो. त्याच्यापेक्षा बेटर अल्टरनेट डे कम्प्लीट 10 डोसेस, 2 व्हायल त्याच्या हातातच द्यायच्या, ह्या 2 बॉटल संपून 15 दिवसांनी परत येऊन भेटच म्हणायचं, तेव्हाच ते पूर्णपणे व्यवस्थित रिप्लेस होतं. इफ डाएट इज डिफिशियंट, कारण की व्हेजिटेरियन डाएट मध्ये व्हिटॅमिन B12 नाहीच आहे, अनलेस यू टेक मिल्क प्रोडक्ट, काही थोड्याफार प्रमाणात त्याच्यात आहे. त्यामुळे त्याच्याशी निगडीत काउन्सिलिंग सुद्धा त्यांची गरजेची आहे. व्हिटॅमिन B12 बऱ्याचदा ओल्ड एज मध्ये पण बरंच कमी होऊन जातं. याचं कारण व्हिटॅमिन B12 इज डिपेंडंट ऑन इंट्रिन्सिक फॅक्टर विच गेट्स सिक्रेटेड इन आवर गट. आणि विथ एज जसे आपले केस जातात तशी इकडे ब्रश बॉर्डर सुद्धा कमी होऊन जाते. आणि विथ एज इंट्रिन्सिक फॅक्टर रिप्लेसमेंट कमी व्हायला लागतं आपल्याकडे इन्व्हॉल्वमेंट. आणि त्यामुळे व्हिटॅमिन B12 डिफिशियन्सी ओल्ड एज मध्ये बऱ्यापैकी कॉमन मिळतं. 50च्या नंतर बऱ्याचशा लोकांना व्हिटॅमिन B12 डिफिशियन्सी असतं. त्यावेळेस सुद्धा आपण सहज त्यांना व्हिटॅमिन B12 द्यायला काही एक हरकत नाही. इज ऑल अबाउट व्हिटॅमिन B12. थँक्यू. येस. हा एक महत्वाचा प्रश्न आहे. व्हिटॅमिन B12 चे बरेचसे आता वेगळ्या प्रकारचे प्रिपरेशन नक्कीच आलेले आहेत. ओरल फॉर्म मध्ये तर आहेच आहे आधीपासूनच मिथाइल कोबालामाइन. त्याच्यानंतर इंजेक्टेबल फॉर्म मध्ये मिथाइल कोबालामाइन किंवा सायनोकोबालामाइन मिळून जातं. आणि नंतर आता ते नेझल प्रिपरेशन किंवा काही स्ट्रिप्स आल्यात जे आपण माउथ डिझॉल्विंग स्ट्रिप्स वगैरे, ह्या नवीन नवीन टेक्नॉलॉजीज आहेत विच आर कमिंग अस फॉर व्हॉट यू कॉल better ways or different ways to convince the patient that something new is given, but almost the same आहे सगळ्या गोष्टी. इव्हन ओरल सुद्धा तेवढंच चांगलं काम करतं, असं काही गरजेचं. आपण ओरल पिल जरी घेतल्या तरी त्याचं ऍब्सॉर्प्शन व्यवस्थित होतं, अनलेस देर इज सम माल ऍब्सॉर्प्शन सिंड्रोम वर समथिंग लाईक दॅट. फक्त त्याला वेळ जास्त जातो म्हणून आपण इंजेक्टेबल देणं त्याला प्रिफर करतो. नेझलच्या बऱ्याच चांगल्या स्टडीज आहेत, बट स्टील द वे आवर फार्मा इंडस्ट्री इज रन, आय एम स्टील नॉट कन्व्हिन्स्ड इनफ टू प्रिस्क्राईब those things right away to the patient. जर समजा आपण प्रोफायलॅक्टिक म्हणून एखाद्याला देतोय, जसं की आता खूप जास्त व्हिटॅमिन B12 कमी नाहीये, त्याला काही खूप जास्त प्रॉब्लेम नाहीत, अशा ठीक आहे एखाद्या नेझल स्प्रे किंवा ती जी स्ट्रीप आहे ती आपण एखाद्यास म्हणू शकतो. बट आय स्टील फील इंजेक्टेबल इज द बेस्ट वे, फॉलोड बाय द ओरल, फॉलोड बाय द these new different methods of vitamin B12. व्हिटॅमिन B12 मॉलिक्युल पण तसं पाहायला गेलं तर बऱ्यापैकी ते म्हणजे हे आहे काय डिफिकल्ट, कारण की मिथाइल कोबालामाइन इज वन थिंग, त्याचं कन्व्हर्जन सायनोकोबालामाइन आणि त्याचं कन्व्हर्जन ॲडेनोसिल कोबालामाइन मध्ये होतं. त्यामुळे मिथाइल कोबालामाइन आपण जे देतो ते तितकंसं जास्त काम करत नाही. बेस्ट प्रिपरेशन इज ॲडेनोसिल कोबालामाइन, बट इट इज व्हेरी डिफिकल्ट टू मॅन्युफॅक्चर, इट हॅज व्हेरी लेस शेल्फ लाईफ, आणि त्यामुळे मॅक्सिमम कंपन्या ते बनवतच नाही. इव्हन सायनोकोबालामाइन सुद्धा बेटर आहे, पण ते सुद्धा कमीच कंपन्यांकडे उपलब्ध आहे, कारण की त्याची सेल्फ लाईफ सुद्धा 1 वर्षापेक्षा कमी आहे. मिथाइल कोबालामाइनची सेल्फ लाईफ 2 वर्षाच्या जवळपास असल्यामुळे बाकी कंपन्या त्याला बऱ्यापैकी प्रिपेअर करतात. हे जे ॲडेनोसिल आणि सायनोकोबालामाइन जे आहेत ना ते चांगले आहेत बाय नेझल ऑर द लिंग्युअल ॲब्सॉर्प्शन, पण मग ते बनवायला अवघड असल्यामुळे मिथाइल कोबालामाइनच्या स्ट्रीप बनल्यात, मिथाइल कोबालामाइनच नेझल प्रिपरेशन यायला लागलं. इट इज स्टील नॉट दॅट गुड, दॅट इज वाय. थँक्यू.
सर एक क्वेश्चन असा आहे की विटकोफॉलचे इंजेक्शन दिल्यानंतर तुम्ही किती दिवसानंतर तुमची व्हिटॅमिन B12 लेवल्स करायला पाहिजे? असं पाहण्यात आलंय की व्हिटॅमिन B12 लो आहे आणि तुम्ही विटकोफॉलचे 5 इंजेक्शन दिल्यानंतर तुम्ही किती दिवसानंतर केल्यानंतर अबाउट 2000 अशी व्हॅल्यूज सापडलेल्या आहेत, तर किती दिवसानंतर करायला पाहिजे?
मी म्हणलं सर व्हिटॅमिन B12 हा बऱ्यापैकी इंट्रासेल्युलर मॉलिक्युल असल्यामुळे जर ती मोर दॅन 2000 जरी आली तर इट इज नॉट दॅट राईट पॅरामीटर ऍक्च्युअली टू जज की अरे आता वाढूनच गेलं तुझं किंवा याच्यावर नको घेऊ, टॉक्सिसिटी होऊन जाईल तुला, 2000 4000 झालं तर काय होईल, तसं काही नाहीये. व्हिटॅमिन B12 लेवल चेक करण्याची आवश्यकताच नाही असं मला वाटतं बऱ्याचदा. नॉट इव्हन फॉर डायग्नोसिस आय वुड से इन इंडियन कन्स्ट्रेंट. असंही त्याची काही टॉक्सिसिटी नाहीये, खूप काही महागही नाहीये, आणि त्या लेवल चेक करायला 1200 इंजेक्शन 60 रुपयाचं, त्याची तफावत खूप जास्त होऊन जाते, त्यामुळे पण बराच अवघड जातं.
सर ऑनलाईन डेलिगेटचे क्वेश्चन आहेत. युजफुलनेस ऑफ फेरेटिन मार्कर इन आयर्न डेफिशियन्सी पेशंट विथ हिस्ट्री ऑफ फीवर.
व्हेरी इम्पॉर्टंट क्वेश्चन. आपण डिस्कस करताना तसं केलं, मी म्हटलं ना फर्स्ट पॅरामीटर टू जज वेदर समवन हॅज आयर्न डेफिशियन्सी इज द क्लिनिकल जजमेंट ऑलरेडी कॉइलोनायकिया आहे, ऑलरेडी दिसतंय आयर्न डिफिशियन्सी सारखं पिक्चर, ऑलरेडी MCV इज व्हेरी लो, अशा वेळेस फिवर जरी असला आणि दिसतंय क्लिनिकली तर यस इट कॅन बी. पण माझे बॉस नेहमी म्हणायचे, वेन एव्हर यू आर इन डाऊट, लाईक वेन एव्हर पेशंट इज फेब्राईल, डोंट गिव्ह आयर्न, अँड वेन एव्हर इन्फेक्शन असेल तर त्यावेळेस आयर्न देऊ नये, बिकॉज whatever microbiological problem is there, it get enhanced because iron is very good molecule for your microorganisms as well. त्यामुळे त्या ठिकाणी देऊ नये. आणि विटॅमिन B12 सुद्धा बऱ्याचदा आपण अननेसरी दुसऱ्या काही कारणांसाठी देतो, ते सुद्धा दिल्या जाऊ नये, हे पण आहे. If malignancy is there, if doubt of malignancy is also there, you should not give vitamin B12, because vitamin B12 is needed for the malignant cells for their growth. Even methotrexate आपण देतो malignancy मध्ये ट्रीटमेंटला, it kills malignant cells by making them deficient of vitamin B12 and folic acid. And upon on top of that you will put vitamin B12. So whenever infection is there, don't give iron. Whenever malignancy is there, don't give vitamin B12. That should be the dictum. जर इन्फेक्शन असेल आणि अशा जर तुम्हाला आयर्न डिफिशियन्सी सस्पेक्टेड असेल तर क्लिनिकल जजमेंट इज फर्स्ट पॅरामीटर. सेकंड थिंग, फेरिटिन आहे, पण फेरिटिन इज ऍक्यूट फेज रिएक्टेड, इट कम्स मोर ओनली. अशा वेळेस फास्टिंग टेस्टमध्ये आयर्न लेवल चेक करणे, त्याच्यामध्ये आयर्न आणि TIBC, आणि जर ट्रान्सफेरिन सॅच्युरेशन इफ इट कम्स लेस दॅन 20, it is iron deficiency for sure. Maybe functional, maybe absolute iron deficiency, but it is iron deficiency for sure. Then there is role of iron for sure, no doubt about it. Yes, sir.
Online delegate Dr. Romesh Bhatt, he is asking at which HB value we need blood transfusion.
Actually, blood transfusion very important question to be asked or to be discussed. हिमोग्लोबिनच्या व्हॅल्यूवर त्याला ब्लड देणं कधीच ठरलं नाही पाहिजे. जस्ट बिकॉज हिमोग्लोबिन इज 6, आता तुला ब्लडच लागणार आहे, म्हणजे त्याचा कॉज काय आहे, त्याला सिम्पटम किती आहे, व्हॉट्स द प्लॅन. सो डिपेंडिंग अपॉन क्लिनिकल सिनेरियो वन हॅज टू डिसाइड. Treatment of anemia, first is the cause and then treating that cause. Last thing and the worst thing is the blood transfusion. Every motto should be there, every investigation, every evaluation should be to the direction that one should avoid the blood transfusion. Because blood transfusion itself comes with a number of other problems. If patient is clinically sick, if hemoglobin rises, early rise in hemoglobin is needed. If we are not finding the proper cause for anemia, if there is obvious bleeding which is in large amount which will take more time to replace or stop, in those cases only one has to transfuse. Otherwise, first find the cause, treat that properly, and hemoglobin will rise for sure.
Sir, last question from online delegate Dr. Prakash asking parameter of good prognosis of treatment of anemia patient.
I think compliance, I would say, कारण की ते सगळ्यात जास्त महत्त्वाचं आहे. Otherwise, finding the cause, if you find the cause, you treat that rightly. Many times people don't follow the compliance. जसं मोरे सरांनी सांगितलं ऑलरेडी की बऱ्याचदा 1 महिना थोडं बरं वाटायला लागलं लगेच सगळं बंद होतं. So right counseling, right diagnosis, right treatment, and right duration of that treatment, these are the parameters what you usually decide whether that anemia patient will get the benefit or not. Thank you.
Thank you, sir. This was a very nice illustrative lecture from Toshniwal sir. I do have one question that we know circulation, we know hematology, we know oncology. Please have some focus on what is meant by rheology.
महत्वाचा प्रश्न आहे, खूपच महत्वाचा प्रश्न आहे आणि डिफिकल्ट टू आन्सर असंही म्हणेल सर. थँक्यू फॉर आस्किंग दिस. बऱ्याचदा ह्या ज्या सेल्स आहेत यांची कशा प्रकारे आपल्या शरीरामध्ये पूर्ण व्हॉट यू कॉल सर्क्युलेशन होतं, त्याला कदाचित आपण रिओलॉजी असं म्हणू शकतो. या ज्या ब्लड सेल्स आहेत त्यांचं एक दुसऱ्यांशी काही नातं आहे. दे आर ऑल असोसिएटेड विथ इच अदर. If someone gets DVT, if someone gets thrombosis somewhere, if someone gets bleeding from somewhere, it has to do something with rheology rather than just platelet count, just coagulation defect, just other problems. कालच एक पेशंट आहे, त्याला he has got admitted for DVT initially, started on Clexane आणि मग वॉरफेरिन सुरू करायच्या आधीच काहीतरी डिफॉल्टेड, then again comes with huge thrombosis, pulmonary embolism now, and started on Clexane. वॉरफेरिन सुरू करायच्या आधीच लार्ज इक्युमोटिक लिजन्स ओव्हर द चेस्ट. INR is just 1.2. Now, whether to start warfarin or not, that was the question from the clinician. So rather than just INR or coagulation, platelet count was also normal. It has something to do with the rheology of that particular blood, because those blood cells are not behaving as normally as they should behave because of many other autoimmune problems going on in the body. बऱ्याचदा काही coagulation factor कमी असतात, बऱ्याचदा काही सेल्स कमी असतात, बऱ्याचदा त्यांचं एक दुसऱ्यांशी रिलेशन, मॉलिक्युलर मार्कर्स, these all come into the picture for particular disease. बऱ्यापैकी मॉलिक्युलर अनालिसिस, मॉलिक्युलर जजमेंट या गोष्टी आता चालूच आहे. And I think in decades to come, maybe not in years, but in decades to come, rheology will also be one of the part in discussion of every disease metabolism, I would say. Thank you, sir.
Yes, sir. Thank you, sir. It's rheology is a branch where viscosity of body is studied, and definitely all components of blood do have some viscosity, and that's why concentrated blood always leads to DVT-like things with precipitating factors. I think we are heading towards the end of this discussion. This was a nice concept of One Health, where a multidisciplinary approach from all the teams is being to discussed in this particular day. We do have a discussion on what was the CBC, and CBC is nothing but a bone marrow biopsy, or it is the mirror of bone marrow biopsy is a CBC. We have discussed IFR indexing, measure indexing, PWD significance of PWD values, PS values, and definitely we do, sir has highlighted the estimation of iron in fasting stage was is important one. So these are the some nice points to take from this particular discussion and topic. One more thing to add, drugs in infection. One of the drug not to be given in infection is iron, and second most important is the heparin. If you give heparin in infected state, I will have to look for infective endocarditis. So this was to add from my side. Thank you, sir, for this nice discussion. Dr. More sir has also illustrated focused on the causes and the pathogenesis of anemia. And Dr. Toshniwal sir, obviously he has touched all the paradigm of clinical aspects of what we call as anemia and all components of bone marrow. Thank you so much. Thank you, IMA and Pathologist Association to invite us as a moderator. And thank you for all. Thank you, sir.
Thank you, sir. That was a knowledge-packed session. I now request Dr. Vidya Chaudhary ma'am and Dr. Rameshwar Naik sir to felicitate our speakers. I request Dr. Anil Kane sir to present a token of appreciation to our moderators. Our next eminent scholar and honored guest is Dr. Amol Bukand sir, who is here to enlighten us on short stature and overview and approach. To moderate this session, I would like to invite Dr. Mahesh Kade sir and Dr. Madhav Rathod sir.
Dr. Amol Bukan sir has done his MBBS and MD medicine from GMC Aurangabad and DM endocrinology from KM Mumbai. He is currently the consultant endocrinologist at Hormone Clinic Aurangabad. He has 10 international and 2 national publications. Handing over the dais to you, sir.
Thank you, ma'am. So, good morning to all. Today we are discussing approach to short stature. The short stature is one of the most common problem, one of the most common disorder, which is why small children are referred to pediatrician or endocrinologist. So we can see towards these two legends, and first striking difference which comes to our mind is the height difference. So the bias towards the tall stature is so much in our public, in society, that the people with short stature, they feel low about their height. जरी आपण मूर्ती लहान कीर्ती महान असं जरी म्हणत असतो, तरी पण हाईटचा फार फरक पडतो पेशंटच्या व्यक्तिमत्वामध्ये. When a child is referred to you or referred to us for short stature, then two questions are need to be asked. These are: is the patient is short, or why she is short? So after this, we have to classify the patient, and we have to plan for all investigations. And next is management and long-term follow-up. पट्टी कशी काढायची? ठीक. So if she is short, for that we have to know the exact age of the patient. Like obstetricians need to know LMP for assessment of fetus. Sex is also important. Parents' height is also important. And if the patient has old health record, which has a height written on the prescriptions, so it is very invaluable. And lastly, we have to assess pubertal growth. So first is measurement of height, then measurement of parent's height, and these heights should be plotted on appropriate growth chart. And if old growth record is available, this record is also to be plotted on growth chart. And according to the old height record, we can calculate patient's growth velocity. So it is Herpenden stadiometer by which we measure the height. So for measurement of height, patient should be without footwear. Sometimes our receptionist or our assistant, they don't bother to remove the shoes of patients. So in that case, the height measure will be on a higher side. Then patient should be fully erect. The patient's heel, scapula, buttocks, and head should be touched on to the wall, and the lower border of eye socket and external auditory meatus should be in the horizontal plane. If patient is less than 2 years, then we have to measure the height in the box. The bottom should be firm, and the headboard should be fixed and movable with movable footboard. We can measure the height. The patient's leg should be perpendicular to the footboard, and a child should be relaxed. So supine length is routinely measured in children less than 2 years, and in children more than 2 years, standing length is measured. But between 2 to 3 years, it is a gray zone. So in 2 to 3 year old children, we should measure both supine and erect height. When we are measuring the height of the patient, the height should be measured in the triplicate, and the difference between these three heights should not be more than 0.3 centimeter. And for measurement of growth velocity, the growth record of at least 6 months should be available. 9 to 12 months data is more preferable for calculating height velocity. Next thing is parent's height. Genetic factors are most important factors that determine the height of any person. So to assess the height, to calculate child's expected final height, we have to calculate mid-parental height, and this is based on a formula. For boys, father's height plus mother's height plus 13 divided by 2. And for girls, father's height plus mother's height minus 13 divided by 2. Why this 13 has come? Because it is the mean difference between adult male and female. So target height will be 2 standard deviation on either side of mid-parental height. That is mid-parental height plus minus 8 centimeter. So the current child who was female child 8-year-old was presented in October 2011 at the age of 5 years. At presentation, her height was 83 centimeter, mother's height was 155, and father's height was 164. So according to this formula, the mid-parental height comes to 153, and target height range is from 145 to 161. And on examination, she was pre-pubertal. So now we have taken patient's height and parent's height. We need to plot them on growth charts. So there are many growth charts like CDC growth chart, WHO, IAP, the growth chart from Dr. Agrawal and Dr. Khadilkar. Recently, the Dr. Khadilkar's growth chart has approved by IAP, taken from 2015, that we use. And there are few growth charts, different growth charts for Turner syndrome patients, Down syndrome, and achondroplasia patients. So these are anthropometric parameters of our patient. Now we have shown mid-parental height, we have shown target height, and this is less than third centile. The height of this girl was less than third centile. So really she is short. Then what next? Is the child very much below the third centile or just below? Or if just below, within target range, then watch growth velocity for 6 months to 1 year. And if it is very much below third centile and target range, then we have to investigate that child. So we have got the old height records of the patient. At 3 years, she was 77, 3.5 years 79, and 4.5 years 85. So we have to calculate height velocity. So we have plotted these heights on growth chart. What about height velocity? The height velocity of any child that differs with age. The birth length is around 50 centimeter. In first year, the child grows by 25 centimeter. In second year, 12.5. In third year, around 7 to 8 centimeter. And later on, the height velocity is around 5 to 6 centimeter per year till puberty. And we can see there is pre-pubertal dip in height velocity, and exactly at that time only many patients come for a visit, because since last 1 year or 2 year my height is not increasing. So that is a main period when the parents brought their kids. So this is a typical growth velocity chart, and it's 25th centile, less than 25th centile. If patient's growth velocity is less than 25th centile, then it is abnormal. So we have calculated the growth velocity. It has come to 3 centimeter per year. So we have plotted growth velocity. We have plotted all height and weight values on the growth chart. So she is below 3rd centile, below MPH by 2 standard deviation. She has crossed centile over last 2 years, and growth velocity is less than 5 centimeter per year. And her height SDS is less than is minus 5.7. So how this short stature is defined? If height is below 3rd centile, that is height below 2 standard deviation for age and sex. If height is below 2 standard deviation of mid-parental height, if height curve crossing 2 centile lines, by annual growth velocity less than 3rd centile for the age, and height velocity below 25th centile in short child suggests abnormal growth. And if height SDS standard deviation score is below 3 SDS, so these children are called short. So now we have confirmed that this child is short for population, short for her genetic potential. Hence, this child needs evaluation for etiology. So any person's growth mostly depends upon genetic factors, but these can be modified by environment, dietary factors, and some hormonal factors like growth hormone, thyroid hormone, and gonadotropins are responsible for height. In this infancy, childhood, puberty model, it has found that the nutrition affects the growth mostly in infancy. The hormonal causes like thyroxine, growth hormone disorders, these affect the growth of mostly childhood patients, and sex steroids are responsible for pubertal growth. So coming to the common causes, malnutrition is important cause of short stature, particularly in underprivileged areas. Short stature can be due to familial short stature or idiopathic. It can be due to constitutional delay in growth and puberty. Most common cause of short stature is chronic systemic diseases like chronic anemia, renal failure, liver disease, and cardiac disease. Some important systemic diseases like celiac disease and renal tubular acidosis are also important causes of short stature. Growth failure may be only manifestation of these disorders, so these disorders should not be missed. Now, small for gestational age babies, patients having rickets or skeletal dysplasia are also prone to short stature. And another important cause is psychosocial deprivation, also called as hyperphagic short stature, is also important and very rare cause. Coming to endocrine causes, most important cause is hypothyroidism, then growth hormone deficiency, Cushing's syndrome, or long-term steroid therapy. So when we investigate the patient for short stature, we need to know the detailed history, the onset of short stature. We have to compare the height with peers and siblings. Most of the time, the patient parents come with children. Their concern is the child is not growing as compared to their classmates or as compared to any children in their relative of same age. Then we have to ask for a pubertal development or menarche. And if patient has any weight gain or weight loss or not gaining weight, failure to thrive. The past history is also important. We have to ask questions and we have to retrieve the history for cardiac, renal diseases. We have to ask symptoms of malabsorption. If patient has polyuria, nocturia, if patient has any deformity, history of meningitis, CNS infection, or patient has visual disturbance or symptoms of raised ICT, any history of intracranial surgery or childhood malignancy and chemotherapy, and history of irradiation. And of course, history of chronic steroid intake, sometimes taken as a steroid in Ayurvedic Balkadu. Antenatal history is also important. Birth history, some cases of IGF, mostly IGF-1 deficiency or resistance or prenatal infection lead to small for gestational age. Birth weight, birth length, any neonatal complications, history of hypoglycemia, jaundice, NICU stay should be asked, and history of puffy hands and feet, suggestive of Turner syndrome. For family history, consanguinity is also important. Family history of short stature is also important, and I will show one case capsule of familial growth hormone deficiency. Height of parents, siblings, and age at which parents and siblings reach their puberty. It is also important point, especially those patients who have constitutional delay. Their parents typically have delayed puberty. And psychological assessment of parents and child. So in examination, height, weight, upper segment, lower segment ratio for to look for disproportionate short stature like skeletal dysplasia, rickets, and sometimes hypothyroidism. For sexual maturity rating, Tanner staging is done for both sexes. General examination to look for any signs of systemic diseases, any dysmorphic feature should be looked for, and in endocrine's perspective, micropenis, hypothyroidism, signs and undescended testes. These are symptoms of combined pituitary hormone deficiency. We have to look for CNS abnormality. So current child birth history was normal. Younger child, brother has outgrown the patient who is now 2.5-year-old. No significant past family history, and weight gain was also slower than peers. So this is all data of that patient. Now, when we know the patient has short stature, we have to classify this patient. We have to look for dysmorphic features, upper segment, lower segment ratio to classify them between proportionate and disproportionate short stature, and we have to see the bone age. Short stature can be a normal variant, which is due to familial short stature. Parents are short, therefore the child is short. Or another normal variant is constitutional delay in growth and puberty. In pathological short stature, it can be divided into dysmorphic, proportionate, and disproportionate short stature. In dysmorphic short stature, Turner syndrome, Down syndrome, Noonan syndromes come. In disproportionate short stature, rickets, skeletal dysplasia, and severe hypothyroidism can also present. In proportionate short stature, if weight of the patient is increased, then the patient can have growth hormone deficiency, hypothyroidism, glucocorticoid excess, Prader-Willi syndrome, craniopharyngioma, or pseudohypoparathyroidism. And if patient's weight is on a normal side or lower side, then the patient may have renal cardiac liver disease, celiac disease, renal tubular acidosis, or other systemic diseases. So in investigation, these are first tier investigations where LFT, RFT, hemogram, ESR, calcium profile containing calcium, phosphorus, vitamin D, bone age, thyroid function test, VBG should be done. Sometimes if history is suggestive of celiac disease, even if not suggesting of celiac disease, we have to do transglutaminase antibodies. We have to remember that patients who have IgA deficiency, they can have normal tissue transglutaminase antibodies. So these IgA TTG antibodies should be combined with serum total IgA level. And karyotype, especially if height of the child is girl is less than 140 centimeter with stigmata of Turner syndrome. Next level of investigations, if these all investigations are normal, then we have to do IGF-1 or IGF-BP3. This is a binding protein, especially done in less than 5 years of age. Growth hormone and other dynamic stimulation testing. Mostly we do clonidine stimulation test for growth hormone assessment. And random growth hormone is useless parameter for diagnosis of growth hormone. It mostly comes on lower side. And neuroimaging if features suggestive of growth hormone deficiency or combined pituitary hormone deficiency. So bone age, for bone age, there are multiple methods are done. It is important, it suggests skeletal maturity. And if bone age is delayed more than 2 standard deviation, that is 2 years, it is significant. In infants less than 1 year, that delay can be as less as 6 months. It gives the idea of potential adult height prediction and potential of growth. And usually bone age corresponds to sexual maturity. So there are multiple methods of bone age assessment, but what we need to know is that it is very simple to calculate the bone age depending upon number of carpals the patient have, but it is very inaccurate method of bone age estimation. Either we use Tanner Whitehouse or Greeley-Pyle method. So if height age is less than bone age, with bone age is equal to chronological age and growth velocity is normal, differentials are familial short stature, skeletal dysplasia, IUGR, or small for gestational age baby, or genetic syndromes like Turner, Noonan's, or Russell-Silver syndrome. If height age is equal to bone age and height age are less than chronological age, and growth velocity is normal, then it is due to constitutional delay or systemic diseases like renal tubular acidosis or celiac disease, or due to malnutrition. And if bone age is delayed or it is lower or equal to height age but less than chronological age, then it can be caused by hypothyroid, and growth velocity is subnormal. Then it can be caused by hypothyroidism, growth hormone deficiency, Cushing syndrome, or severe systemic disease. So till now we have done anthropometry of the patient, bone age determination, significance. So when patient comes to us as a short stature, then we have, this is the flow chart by which we go to the etiology of the short stature with history examination, anthropometry, and growth chart plotting. If there is no short stature, then we have to monitor growth velocity 6 monthly and monitor for pubertal development. If there is short stature and there are some clues from the history and examination, then we have to do the bone age. If there are some clues, then we have to do appropriate confirmatory tests and treat the etiology like renal disease, liver disease, cardiac disease, chronic anemia mostly. And if there is no clue for from history or examination, then we have to do bone age. And if bone age, the height age is less than bone age, and bone age corresponds to chronological age, then it is familial or genetic short stature due to Turner, Noonan's or Russell Viper, or skeletal dysplasia. We have to do karyotype. For bone age, if less than height age and height age itself less than chronological age, then we have to do all parameter for systemic illnesses. And if these all investigations come normal and a patient have acidosis, then if pH is less than 5.5, then it is proximal tubular acidosis. And if pH is more than 5.5, then it is distal renal tubular acidosis. And if all these investigations are normal, then we have to go for growth hormone stimulation test. So these are the reports of growth hormone stimulation test, which should be less than more than 7, and it has come very low. So this patient has growth hormone deficiency, and when we did MRI, it was suggestive of anterior pituitary hypoplasia. Another axis cortisol was also tested, but it was normal. So thyroid cortisol normal, only growth hormone deficiency. So that case was isolated growth hormone deficiency. So management in short stature is treating the underlying cause or systemic disease if evident. We have to treat anemia, vitamin D deficiency, and we have to do deworming if necessary. We have to improve the diet. For celiac disease, gluten-free diet, calcium, vitamin D, iron supplementation required. In renal tubular acidosis, alkali and if required, potassium supplement, and hypothyroidism, thyroxine. In GHD, growth hormone injections are there, and these patients are to be followed regularly. So that patient who was started on growth hormone, she has gained 19 centimeter in 1.5 years. So another variant of growth is a constitutional delay in puberty. These patients at birth, these patients are normal. Up to 2 years, these are normal. They follow the curve. But after 2 years, they cross centile on lower side. And they grow parallelly to the third centile. And during puberty, the pubertal delay, there is pubertal delay, and after sometimes they grow to normal mid-parental height. So these two common causes, familial and constitutional, familial short stature and constitutional delay. These are normal variants. In familial, bone age and chronological age are same. In constitutional delay, bone age is delayed. In both, growth velocity is normal, and they attain appropriate target height. So this chart, this suggests this familial short stature and constitutional short stature, their height plotted over a period of time. And this is this dark one is pathological short stature. And after treatment, it has grown. So when a child comes with obesity and short stature, these are differentials.
Hello?
Growth hormone deficiency.
Hello, excuse me, sir. You have 10 minutes left.
Okay. Growth hormone deficiency, hypothyroidism, glucocorticoid excess, Prader-Willi, craniopharyngioma, or pseudo-hypoparathyroidism. If there is deceleration in a thin child, then we have to see for any systemic illnesses or psychological deprivation. And for dysmorphic features, karyotype, geneticist referral, skeletal dysplasia radiography survey is also needed. So take home message is 3% of all children have length and height below third centile. Most of these children have no disease or growth disorder and will demonstrate this by having normal growth velocity on continued observation, and failure of physical growth, an important sign of disease. Accurate serial measurement of height and height velocity is important, and differential diagnosis of short child is wide and treatment effective only before epiphyses are fused. So I will go through some case capsules. First, we will see normal variant. This is a patient who has come to us at 10 years of age with stature history of from 6 years. Everything is normal. All investigations are normal. Her bone age was corresponding to chronological age, and which was more than height age. So that patient was familial short stature. In familial short stature, bone age corresponds to chronological age, but it is more than height age. This boy, 14-year-old male, who has everything normal, but bone age was 10 year. For 14-year-old boy, bone age was 10 year. And SMR was pre-pubertal, means the patient has not entered puberty, means there was pubertal delay. All investigations were normal. And this patient has constitutional delay in growth and puberty. We can observe the patient. If parents are more apprehensive about the height, then we can kickstart the growth by giving testosterone injection monthly for 3 months. And after injection, the growth, this child growth has grown to mid-parental height. So confirming the diagnosis of constitutional delay. So variation of growth is normal. In constitutional delay, mostly male predominant, but it may be due to referral bias, and familial history is positive in 80% of cases. So in pathological short stature, this 7-year-old female, which has presented with rickets and short stature. Her urine, she has a bicarbonate value of 9.3, which is low, and her urine pH was 7, which was more than 5.5. So this patient has distal RTA, and X-ray suggests of rickets. And this is improvement after treatment. So another 16-year-old female with poor development of secondary sexual character along with short stature, and she has primary amenorrhea. SMR was prepubertal, and on investigation, her antimicrosomal antibodies were positive, and IGF-1 was low. She had anemia, low calcium, low vitamin D, and she had signs of vitamin D deficiency, pseudo-fractures everywhere. Her IgA tissue transglutaminase antibodies came positive. On scopy and biopsy, villus atrophy was found. And the case is celiac disease, and treatment is gluten-free diet with nutritional supplement. After follow-up, she has gained weight and she has gained height also. So key message is impaired linear growth may be first and only manifestation. Gluten withdrawal result in rapid catch-up growth, and low IGF-1 and IGF-BP3 returns to normal during treatment. So IGF-1, IGF-BP3 or growth hormone stimulation test should not be done in initial level, because any systemic illness can decrease growth hormone or IGF-1. So coming to endocrine causes, this is short girl of 9 years with bone age 36 months, and she was found to have elevated TSH more than 100. The bone age is very severely depressed in patients with hypothyroidism. So she was a case of autoimmune thyroid disease and hypothyroidism. Another patient, short stature, 12-year-old female, coming with short stature, and she had a short neck, shield chest, cubitus valgus, these folds you can see. And when we have done the screening and karyotyping, she was found to have 45 XO. So short stature in girl, Turner syndrome should be ruled out after ruling out other systemic illnesses. Now, this patient with short stature and delayed secondary sexual characteristic came with headache and bitemporal hemianopia. He was prepubertal. Height was at 5th centile. Thyroid function test suggestive of low total T3, low total T4, and normal TSS, suggestive of central hypothyroidism. Cortisol was also no, IGF-1 also no. And when MRI was done, it was suggestive of supracellular mass. He was a case of craniopharyngioma. Coming to idiopathic growth hormone deficiency, this is the family I was talking about. That boy has come for investigation of short stature, but when we saw the parents were also showing signs of growth hormone deficiency. So all investigations were done where growth hormone was low on stimulation test, cortisol and thyroid was normal in that child. And after growth hormone therapy, the height increased. So he was a case of isolated growth hormone deficiency. Father's genomic study was done, and he was homozygous for GHRHR deletion. Mother was homozygous for GH1 mutation, and son was compound heterozygous for GHRHR deletion and GH1 mutation. Last slide. The 3-year-old male came with short stature, thyroid, cortisol was normal, but GHD phases. Bone age was 15 months for 3 years. The peak GH was also low, and you can see the hypoplasia of anterior pituitary, and there is absence of pituitary stalk. On annual follow, the patient was found to have low T4 and low cortisol. So that patient developed cortisol and thyroid deficiency later on. The patient was combined pituitary hormone deficiency. So key message is absence of bone age delay rules out growth hormone deficiency. Before stimulation test, other hormonal deficiency stage should be corrected, and done. And GHD having pituitary abnormality on MRI likely to the abnormalities like absent pituitary stalk or ectopic posterior pituitary, they are likely to develop combined pituitary hormone deficiency later on. This is a 5-year-old male child, came with short stature, small for gestational age with birth weight of 1.8 kg. He has triangular faces, and he has asymmetry of body and a clinodactyly and a limb length disparity, and he was found to have Russell-Silver syndrome. Another syndromic causes, like this guy was having Noonan syndrome. This fat guy was having Prader-Willi syndrome, and he was pseudo hypoparathyroidism. So thank you.
Thank you, sir, for clearing our concepts about short stature. Now we can have some questions on this topic.
Yes, sir. Yes, sir. Yes. Yes, we should observe the patient. Yes, sir. We should observe the patient.
Usually, small for gestational age babies catch up with the growth within 2 years.
2 years.
Yes.
Around 10% only they fall below third centile. Yes, height is around. Then we can give the option of growth hormone therapy to the parents. Yes. What? Yes, sir. What should be? For growth. Turner syndrome is also indication for growth hormone therapy. The Turner syndrome patients, this is an indication of growth hormone therapy. Then we can give growth hormone to optimize the height of the patient.
Thank you, Dr. Bukkan sir, for a very elaborative talk on short stature. As short stature is a symptom of many diseases and it is multifactorial. It may be nutritional, emotional, battered babies get short, malnutrition, systemic diseases. So the time allotted to you was maybe not sufficient to discuss all of it, and it is not possible. For a practicing pediatrician, taking proper height, recording weight, and documenting it on the growth chart. And if it is less than third centile, and if there is recent drop up to 25th centile, then that should alarm you to investigate further. At the same time, you should also calculate the mid-parental height. There are various factors to be considered, like genetics. If there is any dysmorphism, is there any obesity or the other signs and symptoms of systemic diseases like RTA, chronic renal failure, and juvenile diabetes mellitus. The discussion was very informative, and this should sensitize us to use growth charts and documenting proper height and weight and documenting it. Thank you.
One unit cost around 180 rupees. So usually patient required 2 units. It depends upon the weight. 2 to 4 units, up to 5 units they require daily. And it is not covered under any Jeevan Dayi Yojana. If patient has combined pituitary hormone deficiency, that comes under Jeevan Dayi Yojana. And these patients can benefit. Thanks. Yes, sir. You should have this chart for growth bone age calculation. There are some softwares or apps available on mobile. Like Tanner Whitehouse or Grulich and Pyle method. We use Grulich and Pyle method, and the charts are available. So we have to compare like PC form appearance. This chart should be with you in your OPD, and we have to compare the just it's a comparison of patient X-ray with this charts. So very easy. Ideal age for treatment, growth hormone therapy. Maximum. By the age of 17 to 18, there is epiphyseal fusion. After that, there is no growth in the patient. But we cannot give growth hormone. If patient is 15 years, now 3 years are remaining, we can achieve 5 centimeters, 7 centimeters. It is not like that. Before puberty, we can give growth hormone therapy, but after puberty, there will be maturation of epiphyseal centers, and we will have a very less time or very less prospects of height increase.
Okay, thank you.
I now request Dr. Mahesh Kade sir and Dr. Madhav Rathod sir to felicitate our speaker. I request Dr. B.M. More sir to present a token of thanks to our moderators.
It's a great pleasure for me to now call upon the stage our dynamic speaker, Dr. Rupesh Gundawar sir, for next talk. He's going to update us on clinical-pathological overview of lymph node swelling. To moderate this session, I'll invite Dr. P.M. Sarve sir, Dr. Ganesh Chavan sir, and Dr. Rajgopal Kalani sir.
I'll now introduce Dr. Rupesh Gundawar sir. He has done his MD pathology from Topiwala National Medical College and Nair Hospital, Mumbai. He is the coordinator of Krishna Surgical Pathology LLP Latur, which is the only exclusive surgical pathology lab in the region of Marathwada. And he's practicing as a consultant surgical pathologist at Vivekanand Hospital, Latur. He has special interest in IHC and running the first in-house IHC lab in Marathwada region since 4 years. Just to fulfill his passion, he started a small online teaching platform under the name of HistoLearn, purely with the intention of creating interest about histopathology and IHC in the PG pursuing students. And now they also have many practicing pathologists following their group and the webinar activities. Over to you, sir.
Thank you for the introduction. I thank organizers and Dr. Vijay to giving me opportunity to stand here as a speaker. लॉकडाऊनच्या काळात काम सगळ्यांकडेच कमी होतं, त्याच्यामुळे बसल्या बसल्या सगळे ऑनलाईन CME ची ऍक्टिव्हिटी करतच होते. पण दिस इज लाईक माय फर्स्ट फिजिकल CME, सो आय एम थँकफुल फॉर गिविंग मी दिस opportunity. As I was told here, we have a mixed population, more the clinicians and less the pathologists. But being pathologist, my PPT will be having more of the pictures and less of the theory. So I think you have to bear. You may think what he is showing, what is the disease of my use, but this way I think you all will come to know what your pathologist see before he arrives at diagnosis. So, and this would be just short revision to a basic subject of your second MBBS. So I hope I won't bore you much. So I start with my lecture, that is approach to lymph node pathology, which, when, and why about different investigation. I want to I will try to impress upon you what all investigations, if done at correct time, how good and helpful diagnosis it can give you and help in your disease management of your patient. So just to start, we all know lymphoid system is represented by thymus, lymph node, and spleen, and the lymph node are secondary lymphoid organs widely distributed throughout the body, important for immune regulation. Just a small histology. This way, this is like when we say pointer इथे असं दिसतंय. हाय का पॉइंटरचा ऑप्शन, एक मिनिट. Okay. This is just to see what findings we look for to say lymph node something as a normal or something as a pathological. So here just a capsule of lymph node where the afferent and efferent lymph tactics you can see, and then we compartmentalize lymph node in different region like cortex having the follicles, paracortex between the cortex and medulla and sinusoids. So the cortex is populated by B cells, and they show the lymphoid follicles which can be primary, and if activated by some response, then secondary follicles having the active germinal centers where you can see the phagocytosing activity. They are lined by thin mantle zone and then the interfollicular marginal zone. These zones are important for us because the specific diseases will involve the specific zones. Like if other follicles are involved, we think of some B cell lymphoma. If paracortex is involved, we will think of it can be some T cell lymphoma, and likewise. So if we have to divide the pathology of lymph nodes, we can divide it as a reactive, it can be infective, some lymphoma, then we have to classify it as a non-Hodgkin, B cell or T cell. Metastatic pathologies, this is one of the most common organ in the body, lymph node, where the most of the secondaries will get deposit from some organ carcinomas, and some miscellaneous disease can be classified as others. So how we investigate the lymph node pathology? The first and very cost-effective treatment will be FNACs. It is a day care investigation where you can give the diagnosis in a single day. True cut or image guided biopsy when nodes are not easily accessible. If they are abdominal nodes, then true cut or image guided biopsy can help us to evaluate that lymph node. But if possible, we always advise to go for excisional biopsy, and if not, at least incisional biopsy, because excisional biopsy give you the full lymph node picture. And sometimes what happens, if lymph node is accessible and you go for some true cut biopsy, and if the disease like metastasis is focal, some early metastasis will be seen only near the capsule. And if you sample lymph node through true cut biopsy from the center of the lymph node, then metastasis will get missed. So in that way, whenever any lymph node is accessible for excision, don't hesitate, excise it. Then if it is a lymphoma, then we will do immunophenotyping. Immunophenotyping maybe like flow cytometry if it is peripheral blood, and immunohistochemistry if you have tissue to evaluate. If there is some infective pathology suspected, morphological studies like culture, PCR, and molecular test for molecular classification of the neoplasms. So yes, approach to lymph node pathology is always the multi-parameter approach. As I said, many times it is not targeted biopsy, no diagnosis can be offered. So we always encourage to go for the largest node. Many times what happens, there is multiple lymphadenopathy. So you should go for the largest node rather than the simplest node. If there is clinical suspicion of lymphoma, do not waste time in FNACs, directly go for excision of that lymph node, because the same tissue, if it is needed, we can go for immunohistochemistry and further testing. When infectious cause is suspected, you have to consider microbiological investigations. And for all this, when I'm saying histopathology, incision biopsy, external biopsy, the first and foremost thing that is needed, like a proper fixation. Always send your tissue in 10% formalin. So what is 10% formalin? Whatever commercial formalin you get from the market, you have to dilute it 10 times. Suppose you are making 1 liter of formalin, 100 ml will be your commercial formalin, and 900 ml will be your tap water. No distilled water is required. Just open the tap and fill it to the 10 times dilution. So this is 10% formalin, which is very, very essential part for this next histopathological evaluation. So whenever we need some tissue, we also need the patient information, because for us, patient is visible only through their tissue. So for that tissue to get evaluated, we also need the same clinical history that you seek for when patient comes to you, like clinical presentations, age, sex, site and distribution of nodes. If any imaging study has been done, that will tell us whether it is a generalized lymphadenopathy or a localized lymphadenopathy. Other lab investigations, if they are done, CBC or any other things, and any other significant medical history or presence of any immunosuppressing conditions. So pathology is also a clinician. So whatever information you have gathered from patient, you have to forward same information to the pathologist if you want a correct diagnosis from him. So here I actually wanted to tell you the importance of various types of investigation. For that, I thought the case-based approach would be good, where I can tell you which investigation helped me, and I can actually stop on that investigation, and I could curtail the further costlier investigation. Cases, I will be showing micro photographs, which I cannot just omit because I am pathologist, but I will try. You will get the amount of information. Some technical glitch, but I will show you here the findings. So actually, I wanted to show you this cluster on higher power, but I will show you here. This cluster is actually of the histiocytes, and this was showing the very good phagocytosis of intact lymphocytes, which we know it as a M peripolysis. So this was a pathognomic finding for me to diagnose this as a Rosai-Dorfman disease. Rosai-Dorfman disease, we also know it as a sinus histiocytosis with massive lymphadenopathy. It is a benign disorder of histiocytes characterized histologically by M peripolysis, that is intracellular engulfment of lymphocytes. Etiology is unknown, but it is very well known for the spontaneous regression in most of the cases. The common site involved is like cervical lymphadenopathy. It can be extranodal disease like sinus, orbit, or ear, but still you can get a spontaneous regression. So the simple FNAC technique could give you a diagnosis, and you could I could actually avoid the advice of any excision or something else, because there was previous suspicion of lymphoma. So this is a FNAC, a cost-effective test giving you a right diagnosis. Another case is of a 60-year male presented with axillary and cervical lymphadenopathy. There were multiple discrete nodes in posterior triangle. FNAC was done from the cervical node. We could get a very good yield of the aspirate. सगळ्याला त्याच्यात ॲनिमेशन केलेले पण एक पण दिसत नाही. ऑनलाईन घेतले का हे? आता कुठे घेतलाय? हम्म. ते दिसत नाही का? पेंटर दिसत नाहीये का? नाही, काढून लावायचं का? किंवा इथं माझं ऑफिस चालू करू का, लॉग इन करून? ते अजून सोपं जाईल. हा, त्याच्यामुळे म्हणलं ऑनलाईन माझ्या याच्यातून चालू केलं तर पटकन नाही ना, डायरेक्ट दिसणार ते. ऑनलाईन डायरेक्ट दिसणार.
पुढच्या सगळ्यांच्या याला येईल, कारण की
ठीक आहे, चलो होऊन जाईल. एक ते 1.5 मिनिटात होऊन जाईल. Just sorry for technical glitch. It's about to get solved. हे आधीच असेल.
हे आलं आपल्याला PowerPoint. त्याच्यावर आपले स्लाइड सिलेक्ट करू. स्लाइड नंबर अंदाजे
मला बघून कळेल. अजून थोडा वेळ लागेल.
करतो मी
जॉईन. स्लाइड शो करू.
मीटिंग पण
ओके.
क्लोज झाली त्याच्यामुळे.
Recording in progress.
स्लाइड शो तर येत आहे आता. असंच घ्यायचंय, वरचं तसंच राहील.
एक्झिट करतायत.
Okay, sorry for technical interruption. So this was I was talking about a case of 60-year male with axillary and cervical lymphadenopathy whose FNAC was done. So this was the FNAC pictures. Very cellular aspirate showing some aggregates of some atypical cell, and you can see they are forming some lumina or what to say ducts or glands as if they are giving some honeycomb like impression. This is a very important clue for us. You can just see here honeycombing of the cell clusters. So this is definitely, this is some metastatic pathology, some glandular thing, means some carcinoma. So, and these are the cells showing some peculiar finding that we always seek for. So with this finding, I just ask patient again for some detailed clinical history. When poking for more history, he gave symptoms of urinary retention and lower back pain. So with those findings and with those clinical findings and these microscopic findings, I called to the doctor and asked him to go for USG for prostate and serum PSA. And to my expectation, patient was having prostatomegaly and his serum PSA was raised. So this FNAC was actually the nodal mets of prostatic adenocarcinoma, which patient was not knowing of because he gave more importance to his cervical lymphadenopathy than his urinary retention. So when CT scan was done, he was also having the sclerotic vertebral mets. So with the simple FNAC technique and proper history, we could actually avoid at least one of his investigation, that is TURP, which was an invasive procedure with all the FNAC findings, his other findings of USG, serum PSA. This diagnosis could be given without touching his prostate, and then the further treatment was started. So this is the FNAC, how beautifully it can give you the required diagnosis. Next case is again a case of 24-year male presented with cervical lymphadenopathy for 1 month, partly reduced with medicine. On examination, those were non-tender, discrete but firm nodes, and few nodes were also seen in USG in axillary region. So FNAC was done from cervical node, and it is again a cellular aspirate, but here it was more with the neutrophils. When we get lymph node FNAC, we expect the lymphocytes, but here there were plenty of neutrophils. In the last case, when I was showing you about the emperipolysis, the same macrophages you can see here, which are phagocytizing the neutrophils. And then again, a collection of histiocytes. So this finding for us is actually suppurative granulomatous lymphadenopathy. So when something granulomatous lymphadenopathy is written in the report, generally it is considered as a okay, TB असू शकते. बघू आता याला AKT देता येतं का. But still we suggested for histopathology, and this was a histopathological picture. You see here it is a necrosis, okay, a serpiginous necrosis filled all with the neutrophils. Again, one more finding, see the serpiginous finding, and these are mantled by the epithelioid histiocytes, what we see in the granuloma, okay. And the other findings, giant cells were seen, epithelioid histiocytes mixed with the lymphocytes, and that they are centering upon the neutrophilic abscess. So yes, this was a suppurative granulomatous lymphadenopathy, but diagnosis here was not TB. It is a diagnosis cat scratch disease. It is a very self-limiting disease caused by Bartonella henseli. Cat scratch or bite introduces bacteria in the inoculation site, and then they are carried to the lymph node, and then regional lymphadenopathy like axillary, cervical, and epitrochlear lymph nodes can be seen enlarged. Benign and self-limited disease which lasts for 6 to 12 weeks. Hadn't the biopsy done and it was labeled falsely as a TB, that in that duration of disease would be for 6 months or 1 year, where you give the AKT to patient. So again, so suppurative granulomatous lymphadenopathy can be seen in many bacteriological diseases. which lymph node is involved, that will give you the clue which can be the etiologic agent. Like in this axillary, so it was a cat scratch disease. Same you can see in the inguinal region, it will be lymphogranuloma venereum due to chlamydia. Seen if mesenteric, it can be due to yersiniosis. It is again a great mimicker of abdominal tuberculosis. But if that is biopsied, if mesenteric node is biopsied and you get the picture of suppurative lymphadenopathy, it is actually yersiniosis, because treatment again will change. In breast and even other side, the same can be seen. Okay, the next case is of a female present with axillary and cervical lymphadenopathy. Again, the FNEC elsewhere was done. It was granulomatous lymphadenopathy. And they actually planned to go for AKT. Mind here, the patient was husband's wife, doctor's wife. No any, so before starting AKT, they just consulted a surgeon. And yes, you know, surgeon is always have tendency to excise first rather than looking the patient. So he was of the opinion की काढून बघूया त्याच्यात काय दिसतं, टीबी जरी कोणी म्हटलं जरी असेल तरी. So we need his axillary nodes for histopathology. So someone when suspected granulomatous lymphadenitis, here you can see the collection of some pink cells within the lymphocytes. They are almost disturbing the normal architecture. पुन्हा झालं का? पुन्हा ठीक आहे. ओके, हां हां. So these are the pink histiocytes or epithelial histiocytes that we are looking for, and these histiocytes were actually encroaching upon these follicles, and they are forming so you see these pink cells with lot of cytoplasm. They are encroaching and disturbing the architecture of follicles. So this was a finding for me, and called to that doctor, husband of that patient, asked only one question, घरी मांजर आहे का? He said, हो, घरी मांजर आहे. Okay. So this was a toxoplasma lymphadenopathy caused because of the cat. You know, toxoplasma lymphadenopathy is caused by a protozoa, that is Toxoplasma gondii, which definitely host cat. And human beings are actually intermediate hosts. They are infected through ingestion of oocytes and contaminated soil. In a immunocompetent patient, the clinical syndrome will be just toxoplasma lymphadenopathy. But if patient is immune deficient, he may have systemic toxoplasmosis even when CNS can be involved. And it is known to get spread by transplacental way and causing fetal toxoplasmosis. So from these three cases, what I want to tell you, granulomatous or necrotic lymphadenopathy is not always the same. Okay, and yes, it is not always TB. It can be TB, it can be fungus, can be sarcoidosis, can be toxoplasma like the previous case. And necrotizing lymphadenopathy can be suppurative lymphadenopathy, like I show the example of cat scratch disease. So when a granulomatous lymphadenopathy and then he developed bilateral submandibular glands and cervical lymphadenopathy. FNEC was done, that time it was reactive lymphadenitis, but lymph nodes were there, they persisted. So when detailed investigation was done, his LFT was deranged with elevated WBC count, thrombocytopenia and high ESR. So for some reason, because LFT was deranged, पुन्हा एकदा. Okay, as LFT was deranged. Hello, alter ego. So LFT was deranged. That patient was referred to a gastroenterologist. So for some unknown reason, that gastroenterologist felt that I should do PET scan of that patient. So when PET scan was done, patient was showing increased uptake in cervical, mediastinal, abdominal, and inguinal nodes, and also with splenomegaly and increased uptake in liver, also in pancreas. So that after PET scan, they suggested to rule out the possibility of SLE, brucella, sarcoidosis. So ANA test done negative, brucella done negative, serum AC negative. So after all this, they just thought कि चलो अभी histopath भी कर लेते हैं, सब कुछ तो कर लिया. So inguinal node was excised and it was sent for histopathology. So on histopathological examination, as I showed you, these are a normal component like cortex showing the follicles, then the paracortex, and these are the sinusoids. So there was just some expansion of the paracortical region. That was a first finding for us. And the paracortical region was very cellular and it was showing many vessels, very prominent vessels. Generally, the vessels are not prominent if lymph node is normal. So this was one finding for us. See here, the prominent vessel between two follicles. And then there's a paracortical zone. Surprisingly, it was showing increased number of plasma cells. You know, plasma cells are actually the most mature B cells, which are generally seen in the peripheral blood more than the lymphocyte. When seen in the lymphocyte, there is something pathological. So plasma cells were increased in number, and there again a vascular proliferation, which was very prominent. So overall, no any findings of lymphoma per se, only somewhat architecture disturbed with increased plasma cells. So this was a simple case of casemal lymphadenopathy. Casemal lymphadenopathy is plasma cell variant of casemal lymphadenopathy. Again, benign disease, I won't say the self-limiting, but benign disease can be classified as a hyaline vascular plasma cell variant. Some evidence suggests immune dysfunction as a cause for this casemal lymphadenopathy, and it can be associated with some diseases like myasthenia gravis, Poems syndrome. It will show lab abnormalities like raised interleukin, LDH, hypergabaglobulin, and cytopenia. So Poems syndrome, many times Castleman disease can be a component of Poems syndrome that we can rule out. Actually, this patient fitted in Poems syndrome. He was having polyneuropathy. When his serum electrophoresis was done, there was increase in monoclonal proteins. He was having Castleman disease that lymph node showed us. And again, the PET scan showed splenomegaly, pancreatic uptake, that was endocrine dysfunction, and even hepatomegaly. So this patient was actually Poems syndrome. A simple lymph node pathology, if would have been done as a first step approach, could have given the diagnosis of Poems syndrome at the earliest. Okay, so this was all about the even benign cases or non-neoplastic cases of lymph node, which we can diagnose. So next case is of a 3-year female. She presented with abdominal pain. So USG abdomen was done. It showed multiple abdominal lymphadenopathy involving para-aortic, mesenteric, and portocaval region. As there were abdominal lymph nodes, excision was not possible or not practical. So image-guided biopsy was performed. The patient was not showing any palpable neck or in axillary lymph nodes. So these are the core needle biopsies of the abdominal nodes, very cellular. Whoever pathologist here can definitely say, this is looking like a starry sky pattern. Lots of these pale cytoplasm, these are the macrophages, which are hyperfunctioning for their phagocytosis role. And overall, it is giving a starry sky pattern, star in a heavy sky. So when this pattern is seen, we always thought of a Burkitt lymphoma. patient was pediatric patient with such a pattern. So Burkitt lymphoma was suspected. Burkitt lymphoma is an emergency condition which need to be conveyed at the earliest, because even if it is highly proliferating disease, uh, if treatment started early, it give very promising results. So, but again, immunohistochemistry needed for the diagnosis, because in lymphoma there are a lot of morphologic mimics. IHC will tell you which type of lymphoma it is. So we did IHC. So these are just IHC findings. CD20 positivity tells us that this is a B cell neoplasm. CMYC and Ki67, that is proliferation index of this lymphoma, was almost 100%. So these three findings tells us yes, it is a Burkitt lymphoma. I was very happy with this diagnosis, because just in 4 days, along with histopathology and immunohistochemistry, we could give this diagnosis, and patient is actually doing very, very fine, because this diagnosis with chemotherapy, actually that disease get curated. Burkitt lymphoma, if given treatment at the earliest, it gives very promising findings. The same case next is a 17-year female presented with weight loss, anorexia, backache, and recent dry cough. He was having some palpable cervical lymph nodes. The USG neck chest done, there was necrotic mediastinal lymphadenopathy. So initially TB was suspected. But then, so for supraclavicular node was excised, histopathology was done, and also sent for TB PCR, because imaging it was suspected to be lymphoma. I think Dr. Manoj sir will remember this case. It was a very nice case, very in emergency were diagnosed. On Friday, we received this biopsy. Saturday, Manoj sir called, "Are मी आलो इथे बघ आजच्या तुला काय सांगता येते का?" And Saturday, I gave him diagnosis. This is again you see very cellular lymph node. Again, you can just identify the starry sky pattern that as I was showing in the previous case. So yes, again, because of this high proliferation and starry sky pattern, we gave diagnosis of high-grade lymphoma, query Burkitt, query plastic. Patient convinced for immunohistochemistry. So we applied the immunohistochemistry. So these are the findings. Last case, I showed you CD3 negative here, CD3 is positive, CD20 is negative. This tells us, oh, this is a T cell lymphoma must be. TDT is again positive, and Ki67 is again almost 100%. So these two findings tells us that this is a blastic lymphoma. Why I'm showing this case? Because just only because of starry sky pattern, not all starry sky pattern are Burkitt lymphoma. So that Burkitt lymphoma and this T cell lymphoblastic lymphoma, both are getting different treatment. So I think in 4 or 5 days we get this diagnosis, and patient can have at earliest treatment. So this is some beauty of immunohistochemistry. So whenever lymphoma is suspected, submit that case always for histopathology, and then immunohistochemistry for sure. So in older classification, like FAP classification, we used to classify blastic lymphoma only on morphological basis as L1, L2, and L3. L3 is actually correspond to the leukemic phase of Burkitt lymphoma, but they are now classified under mature B cell neoplasm and not the blastic lymphoma anymore. So for blastic lymphoma or any type of lymphoma, immunophenotyping, that is flow cytometer, IHC, then genetic alteration, both are essential in classification. So all blastoma need to be immunophenotyped along with cytogenetic and molecular studies. Immunophenotyping will give you the treatment guideline. Then cytogenetic and molecular studies will help you to prognosticate patient. And if by chance first line treatment get failed, you can plan the second or third line treatment. So what actually immunohistochemistry is? I was using this word very frequently in some previous cases. It is simply an antigen antibody reaction. Like what we do in blood cross matching, that is also antigen antibody reaction. This is also the same. Here antigen is a protein of interest in the concerned tissue, and antibodies are commercially available. So this IHC helps demonstrate visualization of the protein in tissue and the exact position and distribution of protein of interest. The antigen is localized by the antibodies that we use, that we are available commercially, and then their reaction is visualized with some fluorescent particle, and then we report it as whether it is a positive, negative, and if positive, in what way. So that way we give our diagnosis. So IHC, what is required? Nothing. For histopathology, you submit the tissue, a paraffin block of that tissue is made. The same paraffin block you have to submit for immunohistochemistry. This is a very long procedure in immunohistochemistry. What we actually do, this is multi-panel approach. Many times, first we decide whether it is a carcinoma, lymphoma, something like that. If carcinoma, which can be the probable organs, and when that is decide, then we go for the second panel, which is organ specific. That gives us which organ it can be. Like when it is any metastatic disease, which organ it can be, we decide that by third panel. And in some complex cases, we have to go for fourth and fifth panel. So this is the reason why this immunohistochemistry needs 2, 3, or at least 5 days, and you cannot get result by the evening, because this is a long procedure where the all permutation and combination of the possibilities has to be considered. So as I was telling you, for all lymphoma cases, you need to go for immunohistochemistry. Why? See this case. This is a case of 22-year male presented with cough and breathlessness. His HRCT chest was done, and it showed necrotic mediastinal lymphadenopathy and necrotic lesion in lung with pleural effusion. And again, because of necrotic lymphadenopathy, TB impression was offered by the imaging studies. So the physician started with AKT. TB मिल गया, AKT चालू करते हैं. Pleural effusion was drain, उसका ADA वगैरह वगैरह कर लिया. Everything was normal, but still चलो AKT start करते हैं. On AKT, patient actually worsened. His pleural effusion, then he also had pericardial effusion. So after 1 month, there was no any significant improvement. So they just admitted patient, drained the pleural fluid, drained the pericardial fluid, and sent him back. After some day, he again came with pericardial effusion that turned into cardiac tamponade. That was again drained, but at the same time, he was not improving with the AKT, and he again developed cervical lymph nodes. So that time they thought, अभी हाथ को लगने वाला lymph node आ गया है, इसका देखते हैं करके, इसको TB PCR को भेज देंगे, TB का कहीं तो evidence मिल जाएगा, देखते हैं. So they sent it for TB PCR, and luckily for histopath also. So on histopathology, yes, it was a necrotic lymph node. You can see the necrotic foci. This is necrosis, and then it is lined by some epithelioid cells. And another finding is there were a lot of eosinophils in this patient. We were somewhat confusing to decide whether this is some changes induced by the AKT treatment or this is the disease itself. And it showed sheets of these histiocytes like looking cells, pale cytoplasm, small nucleoli.
5 minutes left, sir. Excuse me.
And then surrounded by lot of eosinophils. So on histopathology, we thought it can be eosinophilic rich neoplasm, that is Langerhans cell histiocytosis, which might have missed. But as patient was given wrong treatment of AKT, we advised for IHC. So Langerhans histiocytosis, just in a brief, it is a we have histiocytes who have two broad functions, that is antigen processing and antigen presentation. So antigen presentation is done by follicular dendritic cells, interdigitating dendritic cells, and Langerhans cells. These Langerhans cells have characteristic cytoplasmic feature. They express CD1A and Langerine. And if electron microscopy done, we can see the characteristic Birbeck granules. So for this case, I applied CD1A. I was bit pretty sure this will turn out to be Langerhans cell histiocytosis, but to my surprise, CD1A was negative. There I was totally packed. आता काय करू? हा तर पेशंट टाटाला जातो म्हणत होता, पण मी याला थांबवून घेतलं, माझ्याकडे डायग्नोसिस नाही आता. So in such findings, we again turn out to histopathology. We again get our slides back and review it. This time I could see some large cells. These are those histiocytes that I was saying, but intermittently some large and multinucleate cells were seen. This was a clue for me. So I applied a CD30 marker. It came brilliantly positive. And this actually was a case of Hodgkin lymphoma, classic Hodgkin lymphoma, missed because lymph node was not sampled. Physician thought mediastinal lymph node को कहाँ हाथ लगाओ, उसको फिर से pleural में pneumothorax बैठ जाएगा, देखते हैं AKT देखे. But had that mediastinal lymph node been sampled at that time, this disease wouldn't have progressed as a general lymphadenopathy. Actually, this patient succumbed after few days of lymph node biopsy. But just a message: whenever there is pleural effusion and you also see some necrotic mediastinal lymph nodes, do not take it as a AKT. Most of the times it will turn out to be lymphoma. Mediastinal lymph nodes with pleural effusion plus pericardial effusion, you have to think first as a lymphoma. And now in a present scenario, always put lymphoma or any neoplastic suspicion on the top rather than infectious, I would say. And just the last case, I would just borrow some 2 or 3 minutes because this is a very beautiful case that I encountered. Beautiful for me, but bad for the patient. Patient presented with cervical lymphadenopathy. No any other symptoms, no any other findings. So neck node were dissected. Some 6 nodes were dissected and the nodes were cystic. Some cavitatory spaces were there. So this was the cystic nodes. Some gland like large cyst were seen and some malignant cells were seen in the periphery. Again, the same finding, the large cyst, which was giving cystic appearance to the node, and then some malignancy. Here it was sure, okay, this is some metastasis. The same findings, high-grade cells, and then the cystic spaces. Here are the lymphatic emboli. This lymphatic emboli again says me, yes, this is metastasis. Came here by lymphogenous spread. These cysts were, these are the lining cells. We say it as a mucin cells. So something as a mucinous cyst or a glandular cyst, those were. So as there is no any other finding, nodes were in the cervix. So I thought it can be metastasis of mucoepidermal carcinoma, the tumor of salivary gland, as it was in the submandibular region. So I just offered that diagnosis, but I again asked for the IHC. So on IHC, I will just utter the marker. You may not know. This is CK7. Some of the component of positive. See, this brown is the positivity. Some component of tumor was positive and some is negative, which is not brown is negative. Then those cystic glands, those get stained for this CK20. CK20 tells us that this is some GI-like differentiation, gastrointestinal differentiation. So some tumor which was positive both for CK7, CK20, but partly. So that is some hint for me. One question I asked to surgeon, have you touched his testicles? He said, नाही रे बाबा, मला नेक मध्ये दिसलं, मी तिथंच पाहिलं, दुसरं काही मी केलं नाही. So I asked him, just examine his testicles. And I applied one marker, that is SAL4. SAL4 is a germ cell marker of testis. So this was actually a metastasis of germ cell tumor of testis presenting as a cervical node. But job is not done there. Germ cell tumor, there are many types. Which germ cell tumor it is? So we applied the second panel as a combination. In second panel, we give the definitive type of tumor. So some part was positive for CD30, some part was positive for Lipican-3, and some for OCT3/4. So this tells us that this is a mixed type of tumor. It is not a pure tumor. So diagnosis was nodal mets of non-seminomatous germ cell tumor. It was having component of embryonal carcinoma, choriocarcinoma, and teratoma. And to my surprise, when testis was received, it was showing all types of components. See, this was the embryonal carcinoma. The cysts are noted. These are the teratoma. And this necrosis, this was a choriocarcinoma. So this is just a beauty of immunohistochemistry, which give you the definitive diagnosis. Initially, no one thought disease is coming so much lower down to so much up. But after IHC, they get a line of further management. Then his PET scan was done. PET scan showed this enlarged testis and lot of abdominal lymph nodes. So this was a stage 4 disease. So just to tell you the beauty of immunohistochemistry. So in summary, I would say FNEC is always the most cost-effective test which can diagnose and decide at least next step approach. As I said, every granuloma or every necrotic node is not always the TB. Whenever lymphoma is suspected, do biopsy. Whenever possible, do excision of intact node. And in such cases, IHC is always the must. Thank you. So I am open for easy questions.
From audience?
Any questions?
Moderators.
So TB quantiferon test, I think you are actually quantiferon test is not diagnostic test. With that test positive, you actually cannot diagnose this as a TB. Quantiferon test just tells you ki that person is infected with TB. It may not be disease every time. Actually, this quantiferon test was invented as usual in the USA, where they look for whether patient is coming from endemic region, has he got infected with TB. So quantiferon test, I think generally it is more of the use when you travel by air rather than you diagnose something. For TB, for definitive diagnosis, histopathology, and if whenever possible, PCR or culture test is the gold standard for diagnosis. With quantiferon, I don't think you can start directly with AKT.
It's possible, FNAC is possible to detect the immunohistochemistry. Yeah, total lymph
It
node
is
biopsy.
known as immunocytochemistry than immunohistochemistry, but problem many times the way immunohistochemistry validated for the results, immunocytochemistry is not that validated, because what happens in FNAC na, whatever aspirate you get, you make smears of everything na, because you don't know beforehand that this will turn out to be lymphoma or some carcinoma. For immunohistochemistry, you have to reverse staining it. जो जे स्टेन केलेले त्याला पुन्हा डिस्टेन करावं लागतं आणि मग IHC करावं लागतं. So this is very tedious procedure. Whatever results you get, they are difficult to interpret. And again, then you have to suggest go for biopsy and do histopathology. So it is like a double expenditure to patients. So for that, we don't do immunocytochemistry. It is more like an academic interest than the practical interest.
You can do immunohistochemistry on core biopsy.
Yes, sir. Core biopsy also. Because for even soft tissue neoplasm also, you cannot expect to excise, send to me, and then I will do. Many a times core biopsy give you excellent results. Sometimes, okay, 100% is never in the any investigation, but 90 to 95% even lymphoma or any other tumor you can diagnose on core biopsies.
Can immunohistochemistry help in diagnosing unknown primary?
Yes, sir. That case I showed in the last, now that was an unknown primary.
In the neck.
Yes, in the neck. And after immunohistochemistry, it was revealed that patient actually has a testicular tumor, and then it was evaluated accordingly. So for carcinoma of unknown primary, IHC is the only approach.
Rupesh, would you, just an extension of this same discussion, would you like to say that whenever we are expecting a solid neoplasm, whether it is a metastasis from the neoplasm, or would you like to say that if we should avoid FNAC and try to get a core biopsy at least?
Yes, sir. Because see, FNAC is like a first approach. Patient तुमच्या OPD ला येतो, काय करायचं बाबा, एकदा FNAC बघून मग पुढच्या पुढे ठरवू. But on clinical examination, if you are suspecting कि ये कुछ neoplastic turn होगा, why to waste that day in FNAC? Patient in your OPD, just convince him to go for biopsy, because after FNAC also naturally most of the pathologists will tell I do histopathology for confirmatory diagnosis. So why to waste that day?
So one step approach could easily be a
Right,
core biopsy.
right.
Secondly, just like in the case of prostate carcinoma that you discussed, the PSA was only threefold raised. For a prostate carcinoma to be metastatic, usually you would expect PSA at least more than 100 or so. So in that case, FNAC
that
would have
actually
not been appropriate.
after some channel TURP was done just to relieve that urinary retention, and then the prostate was received by us. It was grade group 5. So grade group 5 means poorly differentiated. So poorly differentiated are known to be less secretor than the well differentiated. So I think that way PSA was only threefold, not the fourfold.
But biopsy was anyways probably the solution for this patient also.
See, I think in that diagnosis for sure.
Yes.
Obviously, for proper documentation purpose, you have to have prostate biopsy. But at least with that, I told them ki go for prostate biopsy, nothing else.
The reason I'm saying this is quite a few times what happens is FNAC is easily done. So FNAC is done most of the times it is inconclusive in periphery. So that takes the time from the patient. So that makes a delay in treatment. So probably,
but
at least in a case,
you can just say this as a, this was like an exotic case where actually we could give the diagnosis. It can be prostate.
Absolutely.
But obviously, wherever disease is, if you get tissue from that site only, obviously it is always the most proper approach.
Thank you.
Thank you.
Sir, we do sonography for many children for abdominal pain, and almost all reports are there. There are mesenteric lymphadenoma.
It depends upon size now. Means see, patient always have some abdominal insult. Even we say na, like hypertrophic Peyer's patches. Those are hypertrophic because of some insult. So whenever there is some insult, lymph node will become reactive and they will be slightly more incised. But it depends whether you are getting only mesenteric lymph node, that in only one location around the cecum or the ileum or the appendix, or you are getting generalized abdominal lymphadenopathy. If something is generalized, means every organ has its own lymph node to get drained, right? But at the same time, if you are getting 3 or more stations of the lymphadenopathy, like mesenteric, para-aortic, retrocaval, porta-aortic, when such more than one station is involved, you have to suspect this is something else.
I think we should thank pathologist and radiologist that they tell us, they remind us, please correlate clinically and see the patient. Please go and see the patient, take the history.
But I can guarantee you, I can correlate your clinical finding with my microscopy.
Yes, yes, it was fantastic.
Sir, one question from online delegate, Dr. Amardeep Patel is asking, what's the difference between HPV finding in cat scratch disease and TB granuloma?
TB granuloma, we generically name it as a necrotizing granuloma, where if you remember it properly, when we define something as a necrosis, we define as a coagulative necrosis, liquefied necrosis, or suppurative necrosis. So generally, in TB, it is a liquefied necrosis. With necrosis, you generally see either karyoexis or no any cellularity. And that necrosis is then rimmed by the epithelial histiocytes, which has a fibrous capsule around. In cat scratch disease, these are the suppurative lymphadenopathy. Whatever pictures I showed, I was sure there is no any focus of necrosis. It was focus of only suppuration. So the granulomatous reaction that happened around the suppuration and not the necrosis. So that is some difference between necrotizing lymphadenopathy, that is TB, and this is like a non-necrotizing lymphadenopathy, that is suppurative lymphadenopathy.
एक केस होती जस्ट रिसेंटली, त्याचं एक्सप्रेशन थोडंसं विचारायचं होतं. वन ऑलमोस्ट 45-year-old लेडी, सिम्टमॅटिक फॉर नेझल ब्लॉकेज, सीन बाय ENT सर्जन, पॉलिपोसिस होतं, बायोप्सी केली अँड बायोप्सी रिपोर्ट केम आउट टू बी सस्पिशियस ऑफ लिम्फोमा.
ओके.
पोलीस प्लॅन वगैरे लगेच त्या कन्सर्न फिजिशियनने त्यांना
एज किती सर?
45 अराउंड.
फिमेल. ओके.
फिमेल. आणि लगेच मग ते आता कॅन्सर सारखंच दिसतंय. ISC वॉज ऍडवाइज्ड ISC, बट मग आता कॅन्सर आहे म्हणजे पहिले पैशांचं जुळवाजुळव लगेच पोलीस प्लॅन साठी अप्लाय करणं, रडणं दंड सगळं झालं. दे कम टू माय क्लिनिक, लिम्फोमा आहे सर, पोलीस प्लॅन मध्ये ट्रीटमेंट करून टाका. म्हटलं लिम्फोमा याला आपल्याला हा नाही, त्याला बघावं लागेल आहे की नाही, आहे तर कुठला प्रकार काय. Then we did routine blood work. Everything was completely normal. Clinically also no lymph node, nothing is there on clinical examination. Hemoglobin normal, platelet normal, no lymphadenopathy, LDH normal, weight normal, no B symptoms. Clinically doesn't look like lymphoma. Then I had to convince them that better we get it ISC done first. जर असेल त्याच्यात लिम्फोमा असेल म्हणजे आता दिलं नाही आणि असेल तर मग त्यावर असू शकतं, नसेल काही सांगता येत नाही. आणि परत मग जेव्हा ISC चा रिपोर्ट येतो, इट वॉज रिपोर्टेड ॲज फिक्सेशन इश्यूज वर देअर, बट स्टील ISC डझंट शो एनी मॅलिग्नन्सी. इवन ऑन मॉर्फोलॉजिकल असेसमेंट, नो एव्हिडन्स ऑफ एनी मॅलिग्नन्सी. If clinically suspicious, please repeat the biopsy. फिक्सेशन इश्यू मुळे झाले असेल का, मॅलिग्नन्सी नसेलच का, अगोदर काही मिस झालं असेल, और what can be the explanation for this?
सर हे डिफरन्शियल डायग्नोसिस आहे. एक एक गोष्ट रूल आउट करावी लागते. इट ऑल्सो डिपेंड्स की बाबा ते कसं, म्हणजे ऑब्विसली मी तो टिश्यू नाही पाहिलेला, सो आय कांट से. मेनी टाइम्स हॅपन्स की वेन देर इज अ फिक्सेशन इश्यू, like I can just suspect it was a polyp, right? So patient might have some nasal twang. पेशंटला काही नेझल ट्रँग वगैरे असं काही होतं का?
Clinically we were not suspecting malignancy for sure.
One thing can be there, it can be a lymphoepithelial carcinoma, that we what's a non-keratogenic squamous cell carcinoma. The variant of that is a lymphoepithelial carcinoma in which so much of the lymphocytes are seen, so the actual malignant cells, that is actually squamous cell, get masked. म्हणजे ते असे दिसतात की ते सगळं एकच आहे. So that one thing can be possibility. Whoever has done that IHC might have missed that finding, or because of fixation issue, whichever marker were used, those were like wishy-washy, means not giving any exact diagnosis. Anything can
How
happen.
to avoid those fixation issues? Was there anything to be done from our side? काही late झालं, असं झालं, काही झालं?
Fixation issue has to be avoided by the person who is doing biopsy, right? Whoever has done biopsy, he has to make a habit that tissue has submerged in formalin right when biopsy is done. Many times what happens, surgeon biopsy करतात, technician ला देतात, technician काय करतात, पाणी टाकतात, त्यांना सांगितलेलं असतं फॉर्मॅलिन टाकायचं रे म्हणून, मग ते काय करतात, वरून 4-3 थेंब टाकतात फक्त फॉर्मॅलिनचे, म्हणजे जर कोणी उघडून पाहिलं तर त्याला फक्त वास येईल, हा फॉर्मॅलिन टाकले, पण ऍक्च्युअली त्याच्यामध्ये पाणी एवढं जास्त असतं त्या फॉर्मॅलिनचा काही उपयोग होत नाही. So this you have to teach your assistant ki baba why formalin is important, and this is very very important when it is a case of lymphoma. Without fixation nothing will give you, because there is no shame to admit, because of that fixation issue one non-Hodgkin lymphoma I diagnosed as a Hodgkin lymphoma only because of that fixation issue, because some markers were there which I interpreted as a Hodgkin lymphoma, and that was a mistake on my part because I just ignored the fixation part. So this will happen whenever fixation is not proper.
And is there any necessity that we should take that lymph node sample in two different, like one is formalin, one in normal saline as well?
Yes, if you are suspecting it is infectious, it can be infectious cause, do that at your place, or at least what habit we have made with our consultant. तुम्हाला असं काही वाटतंय का, कॉल करा, आम्हाला सांगा, लगेच ते आमच्याकडे पाठवा. वी विल सी दॅट नोड, वी विल ग्रॉस दॅट नोड. आम्हाला जर वाटलं इन्फेक्टिव्ह आहे, आम्ही त्यातलं लगेच बाजूला ठेवू. तुम्ही लिम्फ नोड जसा काढलाय तसा पटकन पाठवा, आमच्याकडे येऊ दे, मग आम्ही बघू त्याला सलाईन मध्ये ठेवायचं, PCR ला पाठवायचं का फॉर्मॅलिन मध्ये घेऊन हिस्टोपॅथ करायचं. सो दॅट इज अ राईट अप्रोच. टेक युअर लोकल पॅथॉलॉजिस्ट इन युअर लूप, आस्क हिम काय करू, ही विल गिव्ह यू द डिरेक्शन्स.
Apart from formalin, are there any other fluids in which we can give the better tissue preservation?
No, sir. Formalin is very tried and tested fixative. Do not try any other fixative. Only thing I think for bone marrow or testis, bones fixative is suggested other than formalin if it is possible. But for any other histopathological test you have to do, formalin is the only solution.
Is there a percentage of that?
10% formalin is needed. 10% means, as I said again, I will tell you 10% formalin. How to make it? Whatever commercially you get. See, I think whoever has OT, they have formalin with them, right? Either in a tablet form or either in a liquid form. That is a commercial formalin, which is a concentrated formalin. Treat it as a 100%. Even if it is shown 40%, treat it as a 100%. And you have to make 10% dilution of it. 100 ml of this formalin, 900 ml of your water, tap water. Distilled water is not required. Tap water will do the purpose. So this is a 10% formalin, 1:9 proportion. Use it. So if you are purchasing a 1 liter of formalin bottle, you will have a 10 liter of formalin to use.
Thank you so much.
Thank you.
Hello. Yes,
How, sir?
As doctors, we should be suspicious, but we should not be pathological, because there is one entry, that is physiology. Pediatrics, from 6 to 11 years, all the lymph nodes are at maximum size. In the age 6 to 11 years, the lymph nodes are at their maximum size because there is seeding all over the body. So those are normal lymph nodes, they need no treatment.
Right.
Have you ever reported biopsy as normal lymph node? Please narrate.
As you say, normal lymph node असं मी नाही रिपोर्ट केला, because as you said 6 ते 11 वयामध्ये lymph node वाढलेले असतात. वाढलेले का असतात? अननोन इन्सल्ट्स बॉडीला pediatric एज मध्ये काही ना काय झालेलं असतं, इन्फेक्टिव्ह और रिएक्टिव्ह, समथिंग लाईक दॅट. In our teaching, what our senior tell to us, getting a normal lymph node is very difficult. काहीतरी इन्सल्ट त्या lymph node ला झाल्यानंतर, अँटीजन प्रेझेंटेशन झाल्यानंतर, they will show you the secondary follicles. So most of the time it is reactive lymph node. बेबी किंवा pediatric एज मध्ये तेच होतं. पेशंटचे आई वडील फार असे कॉन्शियस असतात, लिम्फ नोड काहीतरी अवदानाच्या गाठी आल्या, काहीतरी बॅक ट्रीटमेंट देऊन टाका की, मग 7 दिवसाची ट्रीटमेंट दिली जाते, साहेब काही कमीच झालं नाही, काय करू, मग आता काय करायचं बाबा, FNAC ला जा, FNAC नॉर्मल असेल तर सांगता येते. बट मेनी टाइम्स इवन वी सजेस्ट दोज पेशंट, सी लिम्फ नोड आर नॉट बिग. बऱ्याच वेळेस काय होतं, काहीतरी झालेलं असतं, इन्फेक्शन दूर होतं, पण लिम्फ नोड सबसाइड व्हायला थोडासा वेळ लागतो, 2 आठवडे लागतील, 3 आठवडे लागतील. यू जस्ट हॅव टू ऑब्झर्व if there is any recent increase in size, if there is erythematous skin or pus discharging from the lymph node, then come to us, we will examine it. Otherwise you can just observe. Thank you very much.
Thank you. Nice presentation.
Snell, madam.
Now that was a knowledgeable feast. Thank you so much, sir, for highlighting the importance of providing detailed history from the clinicians to pathologists and elaborating the topic so well. I now request Dr. Ganesh Chavan, sir, Dr. Sarve, sir, Dr. Rajgopal Kalani, sir, to felicitate the speaker. Can we please have Dr. Madhusudan Magar, sir, to present the token of thanks to our moderators.
I'm sure all of us are having one most productive day of interesting and stimulating discussions. I once again take privilege of welcoming Dr. Amol Bukan, sir. This time he will be discussing thyroid function test interpretation and clinical overview. To moderate this session, I invite Dr. G.M. Chandak, sir, and Dr. Swapnil Khadikar, sir.
Good afternoon, everyone. I have noted few points for introduction. Just I will tell for benefit of all of us. Thyroid disorders are quite a few times ignored and under investigated thing. In this session, Dr. Bukan, well-known endocrinologist from Marathwada region, is going to talk on thyroid function tests and clinical overview. This is a subject of day-to-day significance in clinical practice of nearly all branches of IMA. Just to narrate few, in females, thyroid disorders can be seen as etiology for infertility for menstrual disorders, and the growth retardation and related features in pediatric age group. It can be one of contributing factors in cardiovascular diseases. Also, dermatology, ophthalmology, ENT, neurology, cardiology people come across thyroid disorder cases in their own purview. So it can be contributing factor to these things. So in short, thyroid diseases can affect pediatric to geriatric age group individuals. Typical case of hypo or hyperfunction are many times they can be easily diagnosed. However, problem lies in detecting subclinical cases. Picking up them in early stage is quite important so that treatment can be initiated soon and further complications, sometimes of serious nature, can be avoided. There is one saying, justice delayed is justice denied. Similarly, diagnosis delayed is like treatment denied. So colleagues, routine use of various thyroid function tests will help us to diagnose and treat this disease at proper stage so that further complications can be avoided.
with these views in brief, I request Dr. Bukkan to go for his talk. Thank you.
Thank you very much, sir. Now, this topic, this presentation will be shorter than previous presentation. So, as sir has said, thyroid disorders are very common, and in most of the cases, the interpretation of any thyroid function test is straightforward. In some cases, there will be confusion by virtue of discordant results between clinical features and laboratory values, or there may be incongruous, there may be different results in different parameters like TSH, T3 and T4. In many such cases, reassessment of clinical context provides explanation for the discrepant thyroid function test. The failure to recognize these potential pitfalls can lead to misdiagnosis and inappropriate investigations, over investigation and inappropriate treatment. So before going to the interpretation of thyroid function test, we need to know the physiology of hypothalamus pituitary thyroid axis. So from hypothalamus, depending upon the neighboring areas of brain and environment, these signals, hypothalamus signals to pituitary to produce TSH through TRH. Then pituitary thyrotropes produce TSH, and they acts on TSH receptors of thyroid, and that produces thyroid hormone T3 and T4. The inside thyroid gland, there is uptake of iodine, there is iodination, coupling, oxidation of these iodide molecules, and with that the thyroid hormones are formed. These hormones are released through monocarboxylase transporters into the circulation. Into the circulation, these thyroid hormones doesn't go freely. Most of the thyroid hormones are bound, around 90% of thyroid hormones are bound to transport proteins. Which are these transport proteins? Most important is thyroxine binding globulin, which has very high affinity for these thyroid hormones. Another important transport protein is albumin, which is abundant in the plasma, but it has low affinity. And next, small molecule transthyretin also transports thyroxine. Then from blood, the thyroid hormones reaches to the tissues. At liver, again, uptake of these thyroid hormones are managed by monocarboxylase transporter protein 8. And after uptake, these hormones are either metabolized, like type 1 deiodinase. This convert T4 to T3. Type 2 deiodinase, which is present at pituitary and hypothalamus. This also convert T4 to T3. And it is important for reflex regulation of thyroid hormone TSH production. And type 3 deiodinase that metabolizes, destroys thyroid hormones, like it converts T4 to reverse T3 and T3 to T2, and these hormones are inactivated. So in from hypothalamus to tissue, whatever these molecules are involved in thyroid transport metabolism, any defect in these molecules or any abnormality at various stages can lead to thyroid function disturbance. So as we can see, there is positive and negative feedback mechanism. Now coming to the screening of thyroid function, thyroid disorder, most common screening test and most sensitive and most specific screening test for thyroid disorder is TSH. Because of cost constraint, usually TSH is initial test of choice. It is most sensitive barometer of thyroid function. There is log linear relationship between thyroid hormones and TSH. Small 2 to 3 fold increase or decrease in free T4 causes 100-fold decrease and increase of TSH. So such is the change that happens due to thyroid hormone to TSH. But if we screen the patient for thyroid disorders by TSH, we may be misled in certain thyroid disorders, like in central hypothyroidism, where is TSH deficiency. TSH is not formed because of hypothalamus or pituitary dysfunction due to many causes. So in that case, only TSH will not be sufficient. In non-thyroidal illness, see, thyroid can have effect on other body organs. As such, opposite can occur. Means any disorder of the body, any disease of the body can have effect on thyroid hormones or thyroid. So in that case, the values of thyroid function test may get disturbed. Patients, mostly the hyperthyroidism patients who are on treatment with anti-thyroid drugs, many a times only TSH is done, and TSH is not increased. TSH remains suppressed, and clinicians add anti-thyroid drug dosage. They increase dose every time. Patient becomes clinically hypothyroid, but TSH doesn't increase. So in treatment of thyroid, in recent treatment of thyrotoxicosis, TSH can remain suppressed even when thyroid hormone levels have returned normal to reference range. See, the half-life of TSH is very small, around 1 hour. That T3 is around 1 day and T4 is around 1 week. So even TSH has small half-life. The effect of high T4 that occurs at pituitary or hypothalamus, that effect is prolonged for many weeks or months. So because of that, TSH is not get secreted, it remains suppressed in case of patients with thyrotoxicosis which are put on anti-thyroid drugs. So another two rare entities, resistance to thyroid hormone or TSH secreting pituitary adenoma. In these two rare cases, only TSH measurement is not sufficient. In both of the cases, the biochemical picture is the same. T4, T3 are normal, increase, sorry, T3, T4 are increased, and TSH is either normal or TSH is also slightly increased. So we expect that if T3, T4 are increased, TSH should be suppressed, but that doesn't occur in these two conditions, that is resistance to thyroid hormone and TSH secreting pituitary adenoma. So we know this algorithm when for diagnosis of overt hypothyroidism, overt hyperthyroidism, or subclinical hyper or hypothyroidism. When thyroid hormones are normal and TSH is increased, it is subclinical hypothyroidism, and thyroid hormones are normal and TSH is suppressed, then it is subclinical hyperthyroidism. And if both TSH is increased and T4 is low, it is overt hypothyroidism. And if T4 is increased and TSH is suppressed, it is overt hyperthyroidism. So we are going to see different patterns of thyroid function test. Like normal thyroid function test is normal free T3, normal free T4, and normal TSH. But what happens when free T3 and free T4 are increased and TSH is suppressed, or free T3, free T4 are decreased and TSH is increased? So previous one is hyperthyroidism or thyrotoxicosis. It can be caused by Graves' disease, toxic multinodular goiter, toxic adenoma. It can be due to thyroiditis, post-viral, subacute, riddles thyroiditis. It can be due to drugs like amiodarone or excess iodine intake. It can be found in pregnancy, especially in first trimester, and it can occur due to congenital hyperthyroidism, where free T3, free T4 are increased and TSH is suppressed. Now, the cause of hypothyroidism, where T3, T4 suppressed, TSH is increased, it's autoimmune thyroid disease, Hashimoto thyroiditis. It can be due to post-radiation therapy or thyroidectomy. It can be due to drugs like amiodarone, lithium, tyrosine kinase inhibitors or antithyroid drugs. And it can be due to iodine deficiency and excess. Both can cause hypothyroidism. Neck irradiation, Riddle's thyroiditis, thyroid infiltration by tumor, amyloid or Langerhans cell histiocytosis, and also can cause hypothyroidism, and congenital hypothyroidism. So this is a simple, common in day-to-day practice. Now, if free T4 and free T3 are normal and TSH is decreased, so it is subclinical. The picture is subclinical hyperthyroidism or subclinical thyrotoxicosis. And if free T3, free T4 are normal and TSH increase, it is subclinical hypothyroidism. So what are the causes of subclinical hyperthyroidism? It can be due to Graves' disease. It can present as subclinical hyperthyroidism, or recent treatment for hyperthyroidism, where TSH remains suppressed and T3, T4 remains normal, becomes normal. Steroid intake, or patients who are in ICU receiving dopamine can have normal free T3, free T4 and TSH suppressed. Or there can be a assay interference, and non-thyroidal illnesses can cause this picture. A picture like subclinical hypothyroidism can occur due to poor compliance with thyroxine. A patient of hypothyroidism receiving thyroxine can have normal T3, T4 and slightly elevated TSH. It can be due to malabsorption, can be due to drugs like amiodarone, lithium. It can be due to assay interference, non-thyroidal illness in the recovery phase, and TSH resistance. Now coming to the picture, like FT3, FT4 are low and TSH is normal or decreased. So that can occur into non-thyroidal illness. Or hypopituitarism means central hypothyroidism, defect in pituitary or hypothalamus, can lead to low T3, low T4, low TSH or normal TSH. And there can be assay interference or recently treated Graves' disease. If a patient requiring 20 milligram of carbimazole has received 40 milligram of carbimazole, in that case, free T3, free T4 will remain, become low, and TSH may remain suppressed or may become normal. So another picture is increase free T3, increase free T4, and normal TSH or increase TSH. That can occur due to assay interference, familial dysalbuminic hyperthyroxanemia, thyroxine replacement therapy. Now, some patients of hypothyroidism who are non-compliant, but when their visit come, then they take 3 to 4 tablets before coming to the clinic or going to the lab. At that time, what happens? TSH remains elevated or becomes slightly normal, but free T3, free T4, because they have recently ingested multiple tablets to show that I am compliant to the doctor. So in that case, free T3, T4 can become can remain elevated, and TSH remain elevated or become normal. Another cause is drugs like heparin or amiodarone can cause this picture. Non-thyroidal illness, again neonatal period, TSH secreting pituitary adenoma, resistance to thyroid hormone, and disorders of thyroid hormone transport or metabolism. So these are preclinical things we have discussed. The pitfall in measurement of thyroid function tests that can occur at pre-laboratory level, laboratory level, or post-laboratory level. So in pre-laboratory level, sometimes we don't pay attention to the clinical context, like a neonate whose cord blood is taken and TSH comes around 30, 35, and the patient, the baby is referred for congenital hypothyroidism. But we don't pay attention to the reference value of cord blood. So, or a patient comes with, the parents come with a report of 10, 12, 15 TSH, and it is done in first week after birth. So age of the patient is also important. A patient of 80, 85-year-old comes with a report of normal T3, T4 and slightly elevated TSH like 6, 7. That is also normal for the age, but we interpret it as a subclinical hypothyroidism. But patient is euthyroid because TSH, as age increases, TSH is bound to increase. So again, the history of pregnancy is also important because many changes in thyroid hormones, thyroid hormone binding globulin, plasma volume, etc. can occur during pregnancy, and that can changes the thyroid function reports. Some confounding medications, like I said, amiodarone, or patient is on lithium, or patient is on anti-thyroid drugs, or patient is receiving thyroxine therapy. Whatever patient is getting, or patient is in ICU, patient is in CCU, cardiac care unit, receiving heparin, that history is also important. Or patient is having AMI, or patient is having malaria or malarial fever, or any other illness for which patient is admitted. So these illnesses themselves can alter thyroid function. So this clinical history is very much important for interpretation of thyroid function test. So coming to laboratory, it is important to recognize the limitations of commonly used T3, T4, TSH assays. Apart from pathologists or biochemists, other clinicians don't know the limitations of the multiple methods. Which method the machine is used. So there can be assay interference in different machines, different platforms, and different platforms can be sensitive or insensitive to these kind of interferences, like interference due to biotin, which is very common in Roche, or interference due to heterophile antibodies, anti-animal antibodies, anti-iodothyronine antibodies, or if a patient has familial dysalbumic hyperthyroxanemia. And post-laboratory, that goes to the clinicians. If there is limited experience dealing with these rarer genetic or acquired hypothalamic pituitary thyroid axis disorders, like resistance to thyroid hormone, I have seen only one case. Disorder of thyroid hormone transport, these are common. Disorder of thyroid hormone metabolism, common. TSH secreting pituitary adenoma. Up till now, I have seen only 2 cases. So we'll go to case capsules. 61-year-old male, which was who was admitted in ICU, non-diabetic for 5 years, who has developed acute inferior wall MI, and for with all routine tests, his thyroid function tests were also done. TSH 0.2, which is suppressed, and free T4 was also on lower side, 0.3. So we need to know that unless necessary, there is no need to order thyroid function tests in admitted patients, ICU admitted patient. it is relatively common finding following any acute or chronic illness. There is absence of intrinsic abnormality of hypothalamo pituitary thyroid function. Rather than it is considered a secondary adaptive change to save the energy. We have to avoid testing unless strongly suspected in ill or hospitalized individual. TSH less than 0.1 is found only in 7% of patients. Pre-illness thyroid function test is invaluable to interpretation of this thyroid function test done in patients who are admitted. And in these patients, thyroid hormone replacement is not needed, and follow-up testing after 4 to 8 weeks is necessary. What happens in sick euthyroid syndrome? There is decreased D1 activity. So T4 to T3 conversion at liver is suppressed. Decreased D2 activity means T4 to T3 conversion at pituitary and hypothalamus level is suppressed. And augmented D3 activity means inactivation of thyroid hormone is increasing reverse T3 production. So with this, there is decrease in serum T3, decrease in serum T4, and increase in reverse T3. Total T3 and total T4 are more affected than free T3, free T4 in these non-thyroidal illnesses. As we can see, what happens in when patient is hospitalized with severity, sick, sicker, and sickest. We can see sick patient, there are slight changes, but when the severity of sickness goes, then the derangement is very severe with rise in reverse T3 and decrease in T3, T4, and TSH. So we have seen non-thyroidal illness have come into every thyroid function test scenario previously. So low T4, this is also same. Severe the illness, lower the T4. Now coming to interferences with thyroid function immunoassays. The immunoassay is currently a method of choice for measurement of thyroid function test because they can be easily automated. The turnaround time is low and cost is also low. Immunoassays are vulnerable to different types of interference that can result into erroneous clinical decisions. So these are major types of interferences in thyroid function test. I will not go deeply. Macro TSH interference. Macro TSH means big TSH. Why big? Because there are TSH antibodies which are bound to TSH, and this molecule becomes very large. And in thyroid function test, it looks like normal T3, normal T4, and TSH can be increased weight high to 700. Biotin also can cause interference, especially those assays who use streptavidin biotin complexes for immobilization. Anti-streptavidin antibodies, these are antibacterial. These are antibodies found in some bacteria. These have strong affinity to biotin, which is used in some assays like assays of company called Roche and some of the Siemens platform. Anti-rudonium antibody specifically to Roche machine, and thyroid hormone autoantibodies and heterophilic antibodies. These can interfere with thyroid function test. So with biotin, what happens? We will see later with case capsule. Because of these interferences, around 50% of patients, they have negative clinical consequences. Like they can be started on thyroxine or anti-thyroid drugs, or they may be evaluated further by thyroid scan. So it is very important to consider these interferences. So coming to biotin interference, a 63-year-old woman with secondary progressive multiple sclerosis. She was referred to endocrinologist due to markedly elevated thyroid function test. T4 more than upper range, T3, free T3 also increased, and TSH is suppressed. So straightforward diagnosis is hyperthyroidism. and this patient should be put on anti-thyroid drug. But it is wrong. Biotin is used in multiple sclerosis patients, and the medication she was receiving is around 100 times than daily requirement. It is 300 milligram of biotin per day. So thyroid function tests were normal 6 months prior to starting this biotin, and currently she don't have any clinical features of thyrotoxicosis. So we have to look patient also for clinical signs of thyrotoxicosis or hypothyroidism, not only see the report. So her B12 levels were also more than 400 picomole per liter in absence of any supplement. So the biotin ingested in high doses can cause assay interference for thyroid function test B12. It can cause assay interference with troponin I, progesterone, estrogen, LH, whatever platform using streptavidin biotin. So biotin is water soluble. It washes out of body quickly. Even single day can make a big difference in test results. Interference can occur by multiple mechanisms depending on the assay format. Mechanism to remove biotin will minimize the impact of this assay interference. So we can give washout period, means no biotin supplementation for around 24 hours, and then repeat the test. This is also this is simple, we can do. Or streptavidin agarose column, or non-biotinated assays like platform diazorin platform, or Abbott architect platform doesn't use biotin. So or simple they have biotin beads with which the sample can be incubated. So that can also remove biotin interference. So this is some slightly complex slide. So we can see the interference of ingested biotin on free T3, free T4 level after ingestion. So within 2 to 3 hours, the free T3, free T4 levels increase, double, triple. And after this also occurs with thyroglobulin. So in that patient, biotin was stopped for 24 hours, and repeat thyroid functions and B12 values were conducted using different platform immunoassay, and these tests came normal. And patient sample was also tested for heterophilic antibodies, and these were also absent. So upon biotin re-challenge, free T4 also increased. Coming to next case, 24-year-old female with Hashimoto disease. There was wide fluctuation in her TSH level, 76 to 276. Multiple escalations of her thyroid hormone doses were done, lead to hospitalization for tachycardia. Then she was found to have human anti-mouse antibodies, and thyroxine replacement was reduced. In that case, that antibodies can cause TSH elevation. So the TSH cannot be used for monitoring of hypothyroid patient. So thyroid hormone replacement was reduced to weight-based dose, that is 1.6 microgram per kg per day, and free T3, T4 levels were used for subsequent dose adjustment. Now, these heterophilic antibodies interference can be avoided by gel filtration chromatography, or PEG precipitation test, or serial dilution when the values will fluctuate in case of these heterophilic antibodies.
Sir, 5 minutes left.
Yes. So heterophilic antibody interference, the incidence of interferences due to heterophilic antibodies is around 0.5 to 6%, and depending upon the assay and analyte considered, these heterophilic antibodies like anti-human mouse antibodies can lead to falsely elevated TSH. This occurs in specific sandwich immunoassay, leading to expensive investigations and unnecessary treatment. How to neutralize the effect of these antibodies? We have to repeat the test with different assay, or HAMA or heterophile blocking reagents are there, or serial dilution, as I have said. With serial dilution, we have to see whether the values are parallel then if there are fluctuations, then that are due to heterophilic antibodies, or using non-specific antibody blocking tubes, or some commercial kit detect human anti-mouse antibody positive patient sample. Another interference can occur due to drugs like lithium. This decreases TSH release. Amiodarone is iodine rich, that can cause hypo or hyperthyroidism. Some antidepressant that can increase TSH. Estrogen increase thyroxine binding globulin, and sometimes some assays can give fastly lower free T4 level in case of very high TBG. And this TBG increase also occurs during pregnancy when free T3, free T4 levels are normal, but total T3, total T4 levels are elevated. So we have to keep in mind during pregnancy, we should do free T3, free T4 rather than total T3 and total T4. And androgens and steroids, that they decrease TBG, and sometimes in some assays that can be reflected into slightly increase in free T4. Another patient, 74-year-old female with hypertension and amlodipine on amlodipine, who had a history of fall, fracture of right neck femur. Post-op, the patient developed atrial fibrillation, was given heparin. Patient was euthyroid clinically, and there was no goiter. And TSH done was normal, but T4, free T4 done was elevated. So the causes can be drug effect, or it can be due to non-thyroidal illness, or radiographic contrast agent might have been received, which have led to thyrotoxicosis, or subclinical hypothyroidism given treatment, or TSS secreting pituitary adenoma. These are differentiates. But patient was, we had a history, patient was receiving heparin. So heparin can cause erroneously increase free T3, free T4 in presence of normal TSH. And that occurs because heparin causes increasing free fatty acids. These free fatty acids, they emit free T4 with binding protein in the assays. So this displays free T4 reflected into increased free T4 in the reports. So when the lady being followed up serially for thyroid longitudinal study, the free T3, T4 hormones came to normal. Another patient, 69-year-old lady with TSH of 5.4, slightly elevated, and raised free T3, free T4. Her anti-TP was positive, and ECG atrial fibrillation. So diagnosis, she was not on heparin. Diagnosis differential can be TSH secreting pituitary tumor or resistance to thyroid hormone. So raise T3, T4 and normal or slightly elevated TSH. In TSH secreting pituitary adenoma, the patient can have pressure symptoms like visual field defects or headache. The patient can have elevated alpha subunit TSH ratio. The patient's MRI will be abnormal, suggestive of pituitary adenoma, and sex hormone binding globulin, which is a thyroid hormone marker, which is regulated by thyroid. It is raised in TSH secreting pituitary adenoma, while resistance to thyroid hormone, the normal alpha subunit TSH ratio, normal pituitary MRI, normal SHBG, and so it is familial affected first degree relatives. So that gives a clue to the diagnosis. In resistance to thyroid hormone, there is goiter, palpitation, and resting tachycardia. Pituitary, there is resistance at pituitary and hypothalamus, but a normal response at periphery. So there will be a tachycardia or other symptoms of thyrotoxicosis at periphery. Clinically, patient is a hypothyroid or euthyroid or hypothyroid. That depends upon the receptor, which receptor. There are alpha receptor, alpha 1, alpha 2, beta receptor, which receptor has a defect can lead to differential clinical manifestations. Mainly it is thyroid receptor beta gene. So lastly, when there is a discordant thyroid function test, discordance between clinical features and thyroid function test or within thyroid function test, we have to reevaluate clinical history. Age should be considered. We should know the changes in pregnancy, like TSH can be suppressed in first trimester, total T3, total T4 can be increased. We need to know whether patient is on thyroxine therapy, even in on thyroxine therapy, whether patient is compliant or not, whether there are confounding dietary factors or medications like calcium, iron that decrease the absorption. Malabsorption syndromes like celiac disease can cause subclinical hypothyroidism. There can be thyroid hormone metabolism, altered thyroid hormone metabolism, non-compliance, and other factors. Confounding medications like amiodarone, furosemide, heparin, they displaces free T4 from thyroid binding proteins. History of corticosteroid, heparin, dopamine can also should be also considered. The patients having non-thyroid illness, they may have thyroid function alteration that need to be kept in the mind. And when thyroid status is reassessed, we can then diagnose these patients as hypothyroid, euthyroid, or hyperthyroid. Next step is decide which thyroid function test is most likely to be discordant. Exclude thyroid hormone or TSH assay interferences. Consider specialist laboratory inputs and investigate for rare genetic or acquired disorders of HPT function. Consider referral to specialist center. So, thank you very much.
Hello. Sir, there is one question from online delegate. Dr. Aditya Shukla asking, for patients on thyroid medications, what is the recommendation? To take medication in early morning and come to lab for test of TFT, TSH, or not to take? Many patients say they have been advised not to take thyroid medicine prior to test by their referring doctors. Kindly opine.
Yes, there is no need to withhold thyroxine before testing, and that doesn't change the treatment. As we have seen, TSH reflection of this thyroid replacement to TSH, that takes time. So even 1 day's non-compliance or 1 day's not taking tablet doesn't make anything. We monitor TSH, not T4. So therefore, if patient doesn't take tablet in the morning or take tablet in the morning, there will be no changes in the TSH. So both ways we can do.
Yeah, thank you, Dr. Buchan. You have nicely covered almost all aspects of this illness. Of course, we are also going to ask questions. We are not finishing the session. It's a very wide topic, difficult to cover in short time. We can have questions from audience also. Yes.
Just taking privilege of having endocrinologist on the dais. I'm anesthesiologist.
Yes.
Sir, many times we are getting nowadays patients of 70 above posted for some non-cardiac surgeries with cardiac ailments. They are already started on amiodarone and things like beta blocker. We get patients with bradycardia like 50 and less than 50 also. So will you suggest to get EFTs done for all these patients?
Severe bradycardia doesn't occur in overt hypothyroidism unless it is very severe. So hypothyroidism is not a cause of severe bradycardia, common cause. Another thing is the patients who are put on amiodarone, we should monitor thyroid function test regularly, 6 monthly or 1 yearly. The amiodarone is such a molecule which can have 3 different kinds of thyroid dysfunction. One most common is hypothyroidism. It is very it has very high iodine content. So that high iodine content can cause hypothyroidism, like Hashimoto thyroiditis. Second thing, it can cause thyrotoxicosis. I am saying thyrotoxicosis because it has 2 types of thyrotoxicosis that amiodarone can cause. One is destructive thyroiditis. Amiodarone can cause destruction of thyroid, leading to release of thyroid hormones and suppressed TSH, where anti-thyroid drugs doesn't means they are not advised, they doesn't work. And another thing is the patients who have goiter or previous thyroid disease, they can develop hyperthyroidism, like in Graves' disease or thyrotoxicosis with multinodular goiter. These 3 kinds of thyroid dysfunctions can be caused by amiodarone. So thyroid function tests need to be monitored in these patients.
If such patient is already on amiodarone plus beta blocker, are these patients on table in operation theater are resistant to some treatment like atropine, or shall we go ahead with some other treatment or
No.
get ready?
There will be no difference in treatment of these patients.
So they will be
the patient should be kept euthyroid before surgery.
Before surgery. For emergency surgeries.
Yes,
if the
yes,
patient is
then-
already on the table and
then
patient
with,
is ready, will
with-
it respond to atropine or not, or something else? Shall
Yes,
be done?
that just a routine patient, you can manage it like routine patient. So
Okay.
no special precaution to be taken.
Okay, sir. Thank you.
One more question from audience.
Good afternoon, sir. Thank you for the nice session. During session, you just mentioned the different values for the different machines, actually, or interference due to biotin on the Roche itself. Clinician doesn't know on which machine you are doing the values. So how to go about it? I mean, the patient will not do the thyroid at the same lab.
Yes.
I might have the Roche machine, somebody might have myglumi, somebody might have ELFA. Then how to report it?
No,
I mean,
we should.
that is one question. And one more question is during last few years, we find the increased hypothyroidism cases. Actually, are they actually increasing or we are diagnosing? That is one question. And second thing, I have seen many patients of diabetes mellitus who gradually land into the hypothyroidism. So is there any relation between the 2 endocrine disorders? Thank you.
Any pathologist or biochemist who is running lab, they should mention the assay method in the report. And biotin interference is a common, but not that much common. Means if there is no discrepancy between clinical features and thyroid function test, then no need to worry. And many a times I see the reports that machine or it is not mentioned. So it should be mentioned which method they are using and which machine they are using. Because even if chemiluminescence, Roche also uses chemiluminescence. It is electrochemiluminescence, but or same. Abbott chemiluminescence. Everyone uses chemiluminescence, but they have different platforms. And for diabetes, type 1 diabetes is autoimmune disorder, and hypothyroidism or hyperthyroidism is more common in type 1 diabetes than general population. But as far as type 2 diabetes is concerned, there is no increase or decrease incidence of thyroid disorders in these patients, because these patients are more screened, more lab is done for these patients. We might be picking more patients.
So one more thing is about the reference ranges. Actually, the way you mentioned, it is different for the pediatric age group than the pregnant women and then the old age patients. So are we supposed to mention all the ranges on the report? Will you suggest?
Yes, sir, that will be very beneficial if you mention all the ranges.
Can we have
Because
a
some
reference?
clinicians, they get confused. And for the same normal value, especially that reference occurs, is mostly pediatricians or parents themselves come with high TSH value, which was done as a screening. And especially if done in single means small labs, even though they have their instrument, but usually they report only adult range. So adult, pediatric, old age and pregnancy reference ranges should be mentioned on that report.
Thank you, sir.
Yes.
Thank you, sir. Sir, yeah, Prashnala Dharunas, I want some clear messages because there is some variation in the cutoff value. So for the diagnosis of congenital hypothyroidism, what is the TSH cutoff value? On which day the venous sample should we take? And is there any role of radionuclide thyroid imaging in all cases of congenital hypothyroidism?
At which day? First 2 days, no. After 2 days, you can do. And for reference range, I follow this reference range given by Nielsen. Nielsen pediatric book that is given on the back side. And what was your last question?
Radionuclide thyroid scan.
It has a rule for patients of congenital hypothyroidism. Only hypothyroidism that needs thyroid scan, because many times even hypothyroid patients are subjected to thyroid scan and the clinician get confused. So in congenital hypothyroidism, why there is need of thyroid scan? If that gives you diagnosis whether the gland is hypoplastic, then or whether especially it is useful whether the gland is ectopic. The ectopic thyroid are picked on this thyroid scan, but most of the time USG is also sufficient if thyroid scan is not available.
Sir, one more question, last question from audience. What is the correct time for checking thyroid function test in neonates at birth, day 3 or any other?
Day 3 or later.
Day 3 or later. Okay, thank you, sir. Thank you so much.
Cord blood, don't use
Yes,
cord blood.
yes.
Sir, we are using iodized salt from the birth. Do you find any increase in the hypothyroid function test from the birth and diabetes mellitus?
For diabetes mellitus, I don't know, and maybe not. But for thyroid disorders in general, autoimmune hypothyroid disorders or Graves' disease has increased after iodinization. Initially, it was iodine deficiency. Now, iodine supplementation means normal iodine intake has increased chances of autoimmune thyroid disorders.
Because we are getting the iodine from the water also.
No,
So
sir,
why to
that is not sufficient.
why to take
We
the
need
iodized
to-
salt from birth?
Hmm?
Why to take the iodized salt from the birth?
The
Because
iodine-
we have found that nowadays we have hypothyroidism and increased diabetes in Indian population.
Diabetes, that is different etiology, but hypothyroidism, it is increased after iodinization. But iodine is not only iodinization of salt is very important, and our water or our soil doesn't contain enough iodine that can go into our food cycle.
Do you find that hypothyroidism has increased the level of infertility?
Overt hypothyroidism can cause infertility, but for subclinical, no data. Subclinical can cause miscarriages. but infertility, no.
And the childhood obesity, what do you comment on that?
No, sir. The weight increase by hypothyroidism is very small. It is means false conception. Concept of general public is that obesity, hypothyroidism is cause of obesity. In adults, 3 to 5 kilogram increase in weight. That is only caused by hypothyroidism. All other is due to lifestyle changes.
Okay, thank you, sir.
Regarding this time of taking sample, usually we advise sample in the morning, okay? But nowadays, many people go for morning walk, exercise, and it is said that exercise may cause transient rise in T3, T4. So is it that we should advise that before giving sample, don't exercise on that day or
No,
give
sir.
it prior to that? What do you say?
There are no such guidelines, and that will not cause any problem.
Okay, exercise, it is mentioned, does cause some rise in thyroid hormones?
Yes, yes, that will cause a rise in thyroid hormone.
Yeah. So then sample, if we take
Yes,
sample,
as we check our blood pressure, we keep patient for 15 minutes
okay,
and then check.
that,
like that.
okay, it's a transient, so there is no much problem.
Yes.
Okay. Another, just one question. Patients of hypothyroidism, many are having sometimes diabetes, hypertension, coronary artery disease, and they are on statins and fenofibrates. So thyroid disease already have got some myopathy, some muscle involvement. So is it that high doses may cause myoglobinuria, renal failure? What do you say about this, or any experience you have got?
High
What
doses
caution? Statins and fenofibrates.
In patient of hypothyroidism.
And already patients have got other comorbidities like diabetes, hypertension, CAD.
Myopathy.
They are taking it for that, statins.
Yes, sir. Myopathy is a known side effect of high dose statins. That is found, and if patient has hypothyroid, untreated hypothyroidism or untreated vitamin D deficiency,
okay,
these are prone to myopathy.
Okay.
Okay, but when thyroid function test or vitamin D is treated, then there will be no problem.
We can carry on with routine doses.
Yes.
Okay. Any questions? I think it's a very wide topic. You have covered it nicely. I think just I will sum up the take-home messages you gave. I think only TSH is, I think, what I gathered from your talk, only suggesting TSH is not enough. That can be cost saving, but may not be of benefit for patient. I think that is one. Secondly, as you said, that sick euthyroid syndrome, that is very important. Before interpreting thyroid function tests, we should look whether patient is having these illnesses, and we should interpret it cautiously. Another message I think you gave is in pregnancy, physiological variations you should realize, and accordingly you should interpret. Another important point just I wanted to from you is that suppose patient is going for conception, okay, patient is having hypo or hyperthyroidism, better to correct it in advance and then advise for planning pregnancy. That is one. Or detect the subclinical hypothyroidism first, then go for conception, I think.
Yes.
Okay. Another is in first trimester or maybe in pregnancy, placental transfer of thyroxine is less. So baby may develop hypothyroidism. Just in literature, it is mentioned that you can give amniotic fluid, hormones via amniotic fluid, or you can test amniotic fluid enzyme levels or cord blood levels. And another issue is if patient is on antithyroid drugs, that can cause hypothyroidism in fetus as placental transfer is good. So what just can you add some tell about these things? We are not aware about these amniotic fluid.
No, that is not indicated. In
Okay.
first half pregnancy, the fetus is dependent on
Are
mother's
these
thyroid.
procedures available?
No,
They are
no.
okay. Just
And also not indicated.
okay.
The patient fetus is dependent on mother's thyroid for first half, and later it is independent.
Okay.
And as far as anti-thyroid drugs are concerned, that can cause fetal hypothyroidism.
Okay.
So the dose needs to be monitored if patient is hyperthyroidism and having baby.
Okay. And PTU should be, I think
For
they should
first
be
trimester.
switched. So that is good, I think, and as they have advised in CQ thyroid syndrome, so pathologists mention that clinically correlate. I think that is for our benefit. That point is cleared. And another issue Kulkarni raised. So better to stick to one pathologist. Is it that? Chal, thank you.
Thank you so much, sir, for such a knowledge booster session. I request Dr. G.M. Chandak, sir, and Dr. Swapnil Karikar, sir, to felicitate the speaker. May I call upon the stage Dr. Lakhanwar, sir, to present a token of thanks to our moderators. After overloading our brains with so much of knowledge, it's now time to cater to our hunger cramps. Please enjoy the lunch. Bon appetit.
We will meet after the lunch with renewed energy. Welcome back. I hope after recharging from the delicious feast, everyone is ready to resume our intellectual feast. I would now like to invite the eminent scholar, Dr. Shripad Kausadikar sir, to throw some light upon the changing paradigm in the cancer care with focus on precision oncology. We are pleased to have you here, sir.
To moderate this session, I invite Dr. Karne sir, Dr. Bhosle sir. Dr. Shripad Kausadikar sir has done his MBBS from GMC Aurangabad, MD Medicine from Shri MP Shah Medical College Jamnagar, and DM Oncology from GCRI Ahmedabad, Gujarat. To his credit, he has 5 national and international publications, along with 1 oral and 1 poster presentation. He has also been a co-investigator in clinical trials. He has been awarded a certificate in Cancer Biology Finishing School. He is also the life member of Indian Society of Medical and Pediatric Oncology and the member of European Society of Medical Oncologists. I will now hand over the mic to you, sir.
Thank you very much. And I hope all of us have come back with renewed energy after lunch. So at the outset, I would like to thank IMA Parbhani and Pathologist Association Parbhani to have me here and provide an opportunity to interact with my own people, our own people, since I'm from Parbhani itself. So thank you very much. So after having various wonderful lectures with different specialties, I would like to take you through some change in cancer care that is occurring at a very dynamic pace, I would say, amongst all disciplines, and take you through what changes have occurred in day-to-day practice in cancer. So this paradigm has changed, and what we are going to discuss, that's a day-to-day practice for cancer now. So in coming 20 or 30 minutes, we'd see what is precision oncology, what was the need for precision oncology. I would discuss lung cancer as a prototype of precision oncology, few of the advances and novel treatments that have come up and have changed the outlook of cancer outcomes that I would like to discuss. We have now understood that cancer is a systemic disease and it's not a local disease, which we usually previously thought. And role of systemic therapies has been extremely important in cancer. What are the challenges that are unique in Indian scenarios in cancer care, and what is value-based medicine? So what we know that medical progress has occurred in various disciplines, from superstition to symptoms, with various signs and a few of the investigations, and then now gene expression. This all is occurring at a very fast pace, especially in oncology. Various disciplines in oncology, like in surgery, we have robotic surgery now. Like in investigations, we have PET scans, which are over and above the previous CT scans, and which can tell us about the metabolic activity of the disease. Similarly, we have in radiation, more precise radiation like proton therapies. But the most exciting and most dynamic and most helping change that is occurring, I feel, in oncology is in medical oncology, where we have wonderful novel innovations which tell us how and from what basic changes or molecular level changes that are occurring in the cancer, and that has changed therapy to a great extent. So these 3 Time magazine covers, I feel, in last 20 years have noticed what change that is occurring in cancer. And the first one is incidentally they are from last 20 years, and they've spanned over last 20 years, but the progress has occurred. Each decade has provided us with some important clues, and the progress has occurred at an extremely rapid pace and in a very helping and very interesting manner in last 20 years. We are seeing the changes in last 20 years. So amongst these, the first one that we are seeing is a magic bullet that had occurred in 2002 when we first came to that imatinib was introduced, and it was the description of Time magazine was this little pill has uncanny precision and a wonderful precision to treat cancer. So it is treating the exact the molecular abnormality that is occurring in CML, and it has almost converted cancer into a disease which was supposed to be an incurable or a disease which was supposed to be a death sentence into a chronic disease, just like diabetes and hypertension. Second one is this lady is known for her powerful iconic beauty when she first underwent a bilateral mastectomy to prevent cancer. When she came to know that she was a victim of a germline mutation, which was supposed to, put her to a lifetime risk of breast cancer, which almost was around 85%. So this was a terrifying risk that we came to know. So the germline mutation told that this is the probability of breast cancer, and she underwent a surgery, and she almost virtually eliminated that risk. Similarly, apart from the surgery, there are other ways like chemo prevention and extremely good screening, which can prevent the most common cancer in women, that is breast cancer. And the third one is immunotherapy, where we have seen that this is the newest one, and this occurred in 2017, where we have seen that this disease in later stages, even in stage 4 cancers or in metastatic cancers, those patients who respond to immunotherapy, interestingly, they respond for a very longer duration of time. So these three changes, I feel, were the extremely important changes that have occurred in last 20 years. Obviously, the burden is increasing. We know the numbers are increasing. There is almost an epidemic of cancer, and it is occurring at a very fast pace. So in women, there are breast, cervix, and ovarian cancers. They lead the number most. And in men, the lip and oral cavity, lung cancers, and stomach cancers lead the most. The change is not only occurring at metros, or it's not anywhere else, but it is right here. This is an article from 2020. It says it was a unique article, like this kind of Indian data was presented first, and this was the data from last 5 years, which said that the annual percentage change, that is increase in occurrence of breast cancers amongst various hospital-based registries and public-based registries, Aurangabad region topped the most in breast cancer. The reason I understand was, apart from increase in incidence, there was increase in detection also, which was probably a good thing. Aurangabad region also topped, almost was a second in cancer cervix. So these are the more common cancers, and we are seeing extremely high burden of cancer. So what else is good is that we are now gradually understanding cancer better, and which will help us to treat cancer patients better. So what was the need for precision oncology? The need was that previously we used to treat all these cancers with cytotoxics. Cytotoxics are the drugs which kill rapidly dividing cells. But cancer is a bunch of rapidly dividing cells, so cytotoxic cells would kill that rapidly dividing cells, but it would not do anything to the cause of cancer or the basic molecular mechanism that was abnormal in the cancer. So the response rates, as we can see, were lower in those cytotoxic agents, and when the biomarker was introduced, the response rate increased largely. So this was a very good outcome that we could see with precision oncology. The basic etiology of cancer that we know is it starts from a DNA damage with various carcinogens and impaired DNA repair pathways. So somatic mutation is the foundation of carcinogenesis, and genetic alterations that occur and they're expected to drive cancer evolution are called driver mutations. So they could be of two types: oncogene activation or tumor suppression gene inactivation.
So how exactly does cancer occur, and what is the molecular pathway? That was the topic of research in recent years. So anywhere around 1960s, we came to know the EGFR pathway, but we didn't exactly know how did it cause cancer and how can we inhibit it, or how can we inhibit the pathway. So EGFR is a transmembrane receptor. This is an example, and there are various other oncogenes that are activated and pathways that are activated. So EGFR gene is an example. It's a transmembrane protein. When it binds to a ligand, there is phosphorylation and there is downstream pathways which are activated, and eventually they go on act on the transcription factors and cause cell survival, cell proliferation, and inhibition of apoptosis, which eventually causes cancer. So from a disease which was supposed to be a local or regional disease, we went on to classify it according to location, like breast cancer, ovarian cancer, and colon cancer. Then we went on to classify it according to the histology. Like in breast cancer, it was adenocarcinoma. Like in lung cancer, it was small cell lung cancer or a non-small cell lung cancer. Within non-small cell lung cancer, whether it was adenocarcinoma or it was squamous cell carcinoma. But now we have gone past that, and we now know that molecular profiling of each cancer is possible, and the treatment is available according to that. So to bring you to that, I would like to just share a case of Mr. Aryan, who was 70. This is a patient from Parbhani itself. 70 years gentleman who is a non-smoker, hypertension, history of PTCA2, LAD, and then presented to orthopedic surgeon for a disabling back pain since 2 months. So naturally, the orthopedic surgeon investigated for the persisting back pain and deteriorating performance status of the patient. Easily found lytic lesions, vertebral lytic lesions on X-ray. Then went on to do an MRI, which suggested that these are probably the metastatic lesions. And then chest X-ray was done, which suggested that there was right lung mass, and there was on clinical examination was a supraclavicular node with lytic lesion in vertebrae. So naturally, we think about what investigation do we do, where do we do biopsy from, whether we do FNAC or whether we do biopsy, and what is liquid biopsy, which site, whether it's lung mass itself or supraclavicular node, and then chemotherapy. So like in almost 5 years ago, we would given a prognosis of 6 months or at the most 12 months to such a patient. So whereas now with a better classification and better molecular profiling of drugs, that for example, just as we discussed, a lung neoplasm, which could be a benign or malignant, could be a small cell or a non-small cell. Amongst non-small cell could be an adenocarcinoma or squamous cell carcinoma, which as my friend Dr. Rupesh has discussed, the IHC can differentiate between the two. And then we do a molecular testing, which is a day-to-day practice, and we see if EGFR mutation is positive or ALK fusion is positive, and also we can do next generation sequencing. We'll see what it is. So how do we do this? So we can do this by various techniques, and as Dr. Rupesh has pointed out in his talk, that IHC is extremely helpful in diagnosis. Apart from that, it is also helpful in finding biomarkers for therapy. So a fluorescent in situ hybridization or an IHC or RT-PCR or next generation sequencing, which is a massive parallel sequencing, which can almost sequence the whole tumor, can help us in finding biomarkers and treating the patient. Apart from that, there are few cases where we can't find the or biopsy a tumor, where we can just take a blood from the patient. There are few situations, but there we can take blood from the patient. We can find circulating tumor cells and diagnose them according to the sequencing of the circulating tumor cells. So these biomarker testing, the change in paradigm is that we directly do not treat these patients with cytotoxics. And what we do is we test them for biomarkers, and they are mandatory. Various international bodies like ASCO and NCCN they provide guidelines and they have level 1 evidence for testing these biomarkers before starting therapy. So from chemotherapy, we have moved on to precision. The chemotherapy examples like cisplatin, pemetrexate, and paclitaxel, they do have a place, but only after testing of biomarkers. So precision medicine, previously the chemotherapy was like a carpet bombing, where along with healthy cells, along with the cancer cells, healthy cells were also attacked, and we had a lot of adverse effects. But precision medicine is like a troop of snipers, or like a surgical strike, where exactly the cancer cells would be killed and the normal cells would be spared. So the efficacy of cancer treatment and safety of cancer treatment, both of them have improved a lot. So now we have various driver mutations, and we have matched therapy for them. So EGFR mutation, ALK rearrangement, ROS1 rearrangement. If they are not positive, we have other markers like PDL1, and we treat them according to these markers. So why it is so important is the fact that these markers, they are not rare. So especially in Asian male, especially Asian non-smoker and female population, these markers are present, like EGFR or ALK are present up to the extent of 50%. So your biomarker testing would change treatment in 50% of the patients, which is a huge number. And what it is going to do is, if we treat them with biomarkers, with precision therapy, their outcome, like their response rate, like their progression-free survival, like their overall survival, all of them are going to be extremely different and good than that of a chemotherapy. So what happened to this patient? So apart from doing biopsy, which turned out to be adenocarcinoma, we did next generation sequencing of this patient, which suggested that there was exon 19 mutation. So this patient, who had come with performance status 4, which means that he was a bedridden patient, he was in pain all through, even when he was bedridden. And after starting with therapy, his PET scan showed a wonderful response. So this large tumor went on to become this one, almost a 50% reduction in size, and his performance status improved from being bedridden to next visit he came walking. So that was the difference. So we can provide a very good quality of life and also a progression-free survival. So this is an EGFR TKI, which is an oral drug. So we're going to give an oral drug to a patient of metastatic lung cancer, which can make the survival. This is a huge difference in survival. And this is also with the standard EGFR TKI, and this is 3rd generation. So we have this molecule available right now also. So the progression-free survival of this patient could be anywhere around 2 years, and the overall survival beyond 2 or 3 years. Similarly, another patient with the ALK mutation and who had not undergone initially with this mutation testing was given a prognosis and survival of anywhere around 6 to 8 months. With ALK fusion, the survival could change anywhere up to 5 years. So 3 to 5 years, this is a huge difference. There is a huge difference in quality of life, and over and above that, we can avoid the adverse effect of the chemotherapy. So apart from this, there are a few other novel treatment modalities. Thanks to these 2 gentlemen who received Nobel Prize in 2019 for their thought that what if we can teach immune system to fight cancer. So usually what happens is cancer cells, they evade our immune system with the help of some ligands that we have shown here. Is like example is a PDL1 ligand. They express it, they engage the T cells, and here the T cells, the immune T cells, they are suppressed. So what they have found is, they have found a molecule to engage this ligand itself, so that the T cells would be active and there would be immune system acting against the cancer. So if we see current trials, the maximum number of trials are going for these immunotherapy agents and precision therapy agent. So these agents are going in, they're coming in very good numbers, and they're helping patients with very good effect. So overall survival changes with immunotherapy. So variety of cancers, checkpoint inhibitors that we have just discussed, they are approved. We also have biomarkers for these checkpoint inhibitors, so which immunotherapy drug, if whether the immunotherapy drug is going to respond, going to help the patient, whether the patient is going to respond to cancer, we have biomarkers for that, like MSI, PDL1, and total mutational burden. So these are done on biopsy specimens. Increasing number of FDA approvals for drugs, like if we see consistently these many number of drugs, new drugs are getting approved, and many of them are further in the pipeline. So if we see lung as a prototype from 1970s to 2020s, 50 years, that there's a huge change. So here it was a local disease where surgery or radiation was only done. Then cytotoxic chemotherapy and combination chemotherapy was introduced. Around 2000, we had targeted therapy, but availability of targeted therapy has increased in the last decade only. And beyond that, now we have specific markers and specific tests like next generation sequencing, which almost gives a map of genetic map of a tumor and tells us what therapy we can offer to the patient. So what it has done is it has changed outcomes. So we can sequence treatment one after the other and give patient a wonderful quality of life and very good survival also. There are other novel treatments that we had just mentioned. So this was a patient, 74 years male, with no family history, lower urinary tract symptoms from 3 months, back pain, hip pain since 1 month. He was also more than 50% time in the bed. Performance status was not so good. For lower urinary tract symptoms, he was investigated, and prostatomegaly was found. PSA was more than 1,000. So we knew that this is a metastatic prostate cancer. So what investigation further we do? So we did a biopsy that was possible, just like Rupesh had told us. Biopsy from a metastatic site was done. IHC was also done. And then patient, we already know that these tumors, they are extremely hormone dependent or androgen dependent. So we have been offering them a surgical orchiectomy or to deprive these tumors of androgens, or we have been offering them GnRH antagonist to deprive these tumors from androgens. But over and above that, so because of these agents, we can delay chemotherapy. We have sequencing agents that we have 1, 2, 3, 4 agents. So we can delay the chemotherapy, we can delay the downfall of the quality of life, and we can also improve the survival. So we have recently, since last 4 or 5 years, we have various androgen receptor inhibitors available. So over and above the androgen deprivation therapy that we give, these are the tablets which can further reduce the androgen production in intratumoral androgen production. Few of them, like synthesis inhibitors, and few of them would decrease the effect of these androgens on tumor cells, which usually cause the tumor cells to proliferate. So it has also, this graph can clearly state that the median survival is anywhere around 5 years in a metastatic prostate cancer, with the response rate of chemotherapy previously used to be 20 to 30%. By which I mean that amongst the 10 patients, 2 or 3 patients would respond to these therapies and would have reduction in symptoms. Whereas with these hormonal treatments, which have very less adverse effects, the response rate has gone on up to 80 to 90%, which is a wonderful thing. So PSA after 2 months was from more than 1,000 to 4, and most importantly, clinically, the patient's performance status improved. Patient currently can go to his shop, can carry out whole of his work, and every month comes for a follow-up. The gallium PET scan that we have is specific for prostate-specific antigen, and we can see the difference between the two. These all dark dots which were there, they've gone on to become very faint. So usually the course of the prostate cancer, we use various agents along the line, and what we do is we delay the onset of chemotherapy and increase the survival of the patient. Another patient I would like to present is a female, 38 years, with a right breast lump noticed a month ago. Mammogram showed a speculated mass almost 3.5 centimeters with microcalcifications and BIRAT score 4. We knew that we need to do a biopsy with this suspicious mass. The biopsy suggested invasive ductal carcinoma. So the reason for putting in this case is we need to understand the change in paradigm is that every cancer, even if I call a cancer a breast cancer, for example, it's a heterogeneous disease. It's not a same disease in 10 patients. So every patient has a different disease, and how we define that is by doing IHC is one method, and there are a few other markers. So it's a routine practice to do a hormone receptor status, ER, PR, and HER2 status on breast cancer patients, where the survival is different from in all patients. So if we see hormone positive patients, the survival is excellent. So 2/3 of the patients would be hormone receptor positive and HER2 negative. Then there could be patients who are hormone receptor positive and HER2 positive, the survival is different. And there are few patients who are triple negative, that is hormone receptor negative and HER2 negative, the survival is different. Even if the HER2 positive tumors, they are also aggressive cancers, but with new HER2 targeted therapies, the survival has almost is reaching hormone receptor positive cancer. So the survival has improved because of HER2 receptor therapies. So if we do IHC marking and HER2 on a breast cancer, if I find a HER2 positive breast cancer, I would give that patient adjuvant treatment of 1 year of HER2 directed therapy along with the chemotherapy. So what it has done is it has increased the survival excellently. This is a relative the relative difference in survival has increased by about 50%, which is a huge thing. And this in case of loco-regional disease is a limited treatment. This is not a continuous treatment that patient has to take on for years together. Another important paradigm change is that we have now understood that cancer is a systemic disease. It's not only a local disease. It's not only a lump. It's a systemic disease, and it needs to be treated systemically. There are various trials that show that incorporation of systemic treatments into cancer therapies have improved survival by a lot, and hence the systemic therapies are used at various points of care. Like a neoadjuvant therapy is used before surgery to reduce the size of the lesion, to convert a modified radical mastectomy, that is removing the complete breast, to a breast conserving surgery. We can use this neoadjuvant treatment to downstage the tumor and use the concurrent treatment along with radiation to improve the outcomes of the radiation. Adjuvant therapy is used after completion of surgery, where we want to eradicate the micrometastatic disease that is there in the blood. There are definitely palliative therapies, metronomic therapies, where we use drugs at a regular or tablets at a regular intervals, and the targeted therapy that we discussed, hormonal therapy that we discussed, and immunotherapy that we discussed. These are part of systemic treatment of various cancers. So as we have understood that this is a systemic disease, in the sequence of treatment, there is incorporation of systemic treatment like HER2 positive disease. Even if it is an early breast cancer, we prefer giving neoadjuvant therapy, by which means we can reduce the size, we can convert from a modified radical mastectomy to BCS, we can reduce the systemic spread with a systemic treatment by treating the micrometastatic disease that is there, which is not which we cannot see on the imaging. Similarly, in locally advanced breast cancers, especially triple negative that we have just discussed, there has been a role of NSCT, and we escalate and de-escalate treatment according to the pathological complete response. So if we see the specimen of this after the surgery, we can decide whether there was a complete response or not a response, and escalate or de-escalate treatment accordingly. So even in the metastatic setting, the hormone positive tumors, hormone positive and HER2 negative tumors, we have CDK4/6 inhibitors. They are cell cycle inhibitors, so they improve the survival. That's like this treatment of hormonal treatment and the targeted treatment. It has taken the median overall survival of a metastatic hormone positive breast cancer to 63 months. So this is all different from and also almost devoid of adverse effects. So various drugs have occurred and are in the pipeline since last few years. Sequencing of treatment is also a key. So when medical oncologist sequences various treatments for a particular disease, there are oncological principles. Like in colon, what we see is we want to expose the patient to each and every drug one after the other, so that he can get the benefit of each drug, and we can sequence according to the patient's comorbidities, according to the patient's disease status, and more drugs he gets exposed to, we can improve his survival. So what it has done is ovarian cancer used to be a cancer where you would give a survival of 1.5 or 2 years usually. So with new adjuvant therapies, surgery and adjuvant therapies and new therapies that have been occurring with evolving data in various cancers and similarly in ovarian cancers, the survival now has gone on to more than 5 years. The delivery of, apart from the delivery of targeted treatments and novel treatments, chemotherapy holds its place, that is for sure. It's not that chemotherapy has left the armamentarium of cancer care, but the use of chemotherapy, we have now very good and large data how to use the chemotherapy, how to optimize the supportive care while we are using that chemotherapy, so that the chemotherapy is tolerated very well. The usual and the routine fears in the minds of patients of MSS, of hypersensitivity, of having infections, and of having pain, they are all can be addressed with properly risk stratified antiemetic treatments. We can risk stratify and use growth factors to avoid febrile neutropenias in cancer care. We now have various good agents like bisphosphonates to improve the bone health of the patients in various malignancies, like in breast and prostate. Occurrence of bone metastasis is extremely common. Similarly, we can give a better pain relief with palliative care. And according to the standard definitions of chemotherapy toxicities, the adverse events, they are criteria defined, and we can titrate the dose of these chemotherapies and reduce the future adverse effects in next cycles. So for example, we have a CARC-BC score. CARC-BC score is for elderly female patients of breast cancers. So we use various parameters like the performance status of the patient, like anemia, like if he liver function tests, whether the patient can herself take medications, whether there was falls previously in last 6 months. All of these, they have created a data and defined the various levels, and we can predict the chemotherapy toxicity. So whether we are using 2 drugs or 3 drugs, and tailor the treatment accordingly. Incorporation of early palliative care has not only improved the quality of life, but also survival of the patients. So all said and done, all these things, whether they are applicable to our setting and cost constraint settings. So these are unique challenges in India. There is lack of awareness of the disease, lack of awareness of the available modalities of diagnosis, lack of awareness of the treatments. Absolutely, when we have lack of awareness, there's no point of the screening is almost non-existent in rural parts of India. It is very less, and increasing efforts are being done, like Tata Memorial Hospital recently has the largest drive of cervical cancer screening at Dharavi population, and it was almost the largest in screening drive in all over the world that was conducted in a particular time. So delay in diagnosis is another problem, and with all this, we have advanced disease at presentation. So what we obviously the early detection and treatment is the key to better outcomes. So what we can caution ourselves against all these things when we come across like change in mole or skin lesions, abnormal discharge from orifices, unilateral swellings, tumors or bulge or lumps anywhere, increasing lymph glands, or We have obstinate fatigue that is not explainable, and unexpected neurological deficits. We should be aware at various places, like recurrent effusions, new lumps, or lower urinary tract symptoms in a particular age group. We should have a high index of suspicion to diagnose cancer earlier. Screening, this is just to show that screening really saves lives, and we try to make spread a word about screening and prevention, which is not that difficult. Another important aspect of Indian cancer care is we have misconceptions about treatment outcomes, even in curative settings. So we don't want to further the treatment, don't want to advance the treatment, and many a times it happens that patients or relatives, they want to let it be. So which should not be the case. Like if you see a breast cancer patient, the 5-year survival rates in stage 1 are almost approaching 100%. Even in stage 2, there are more than 95%. The advanced disease definitely decreases the chances of survival, but we can diagnose it earlier, and there are quite a few cases which are diagnosed in all these stages, and we can provide a cure to these patients. Similarly, Hodgkin lymphoma is such a disease. So with time and with improving and advances in therapy, the survival and cure of these patients is possible. Another and most important factor, probably after having discussed all these new therapies and advances, is cost of care in Indian settings. What we consider is, apart from, we are always already explained and told, and all the meetings, international meetings, they say about evidence-based medicine. So apart from evidence, we should also practice, and we do also practice value-based medicine. We all do so in our own disciplines. So including the value based upon the patient's perceived values. So what the patient thinks of a disease and what are the goals of care should be decided upon the beginning of the treatment, and care should be delivered accordingly. So what we do is, for example, we have for our patient who was EGFR mutation positive that we initially discussed, the category, there are various category 1 treatments. This treatment is around, which costs around 1.5 lakh a month, and another treatment which is also category 1 treatment which costs 4,000 a month. The reason is we have a generic available for this, and various Indian pharma companies, they are making a very good quality drugs for these patients. So in Indian setting, we can always offer this drug first, and we can then sequence the patient onto the next line of therapy and then on chemotherapy. Similarly, there are situations where we need to decide whether to give or not to decide give adjuvant therapies based on the histopath report and based on the staging, pathological staging of the disease. So usually what is done abroad is we have this oncotype DX test, which costs around 2.5 lakh rupees. We can easily use a Ki67, which is a proliferation marker, and still provide a good way or a biomarker to decide upon whether or not to give therapy. Similarly, there are various trials which we can take help of, like in breast cancer adjuvant treatment. You want to deliver treatment for 12 months, but 6 months is a better treatment than no treatment. So there is evidence to give 6 months treatment, and there is also generic chemotherapy drugs available for the HER2 treatment, so which is going to increase the survival by 50%. So for a younger patient, or for that matter, for any patient which is not a metastatic patient, we should offer, and we try to offer this test with generic drugs, and with the value-based medicine, we can cut down the cost from 11 lakhs to anywhere around 2.5 lakhs for the whole adjuvant treatment. We can use oral metronomic treatment where in a palliative setting where there are no further options available, and can increase the quality of life. The oral metronomic treatment means a treatment at a frequent intervals and regular oral dosage, and which can provide patient a palliative care. Multidisciplinary team involvement.
Please conclude in 5 minutes.
So multidisciplinary team involvement and initial should be given, and ideal recommendations should be given initially, so that patient knows which treatments he or she is going to undergo and can plan about the cost. We utilize various government schemes which are there and patient assistance programs by pharma companies and can provide good care. When no other options or options are available, best options are available for treatment, enrollment in clinical trials can also be done. So these are the factors that are changing, and precision medicine in resource constraint setting can also be practiced, and the best possible care can be provided to the patient. Obviously, compassionate care and empathy is necessary for all the patients, and especially for cancer patients. So cancer care should be a compassionate care that remains standard in any era. So I would conclude with this, that there is ever increasing disease burden, and it is there in our own area. Early detection and treatment is the cornerstone in management. There is hope in precision oncology and pouring in new and innovative therapies and inflowing data. Optimization of treatment can be done, and we can minimize the toxicity of cancer treatments with this. Precision in cancer care, even with constrained resources, is an art. So oncology now is not only advanced and exciting, we can practice personalized medicine and personalized oncology now. Thank you.
Thank you, Dr. Sripad, for enlightening. Precision in all branches is required, but in oncology, we were not knowing since last 2020 to 2022. In last 2 years, we were hardly talking about any oncology. In changing trends, you have enlightened from surgery, large surgery to FNSC to molecular levels management. Also, you have enlightened us on evidence-based medicine to value-based medicine. That means you are thinking about cost of a medicine also. Thank you. Topic is open for discussion.
Thank you.
Is there any difference in the treatment regimen for the breast cancer, that so-called invasive duct carcinoma or invasive lobular carcinoma? And in cases, do you expect e-cadherin to be done in each and every case which is suspected to be lobular carcinoma? Any main difference in the treatment?
Right. So usually invasive lobular carcinoma, you expect almost all of them to be hormone receptor positive and HER2 negative, and you expect them to have a good prognosis. So the treatment would depend on the staging only, either clinical staging or pathological staging, and treatment probably would not change upon the type of the cancer, but you do expect that invasive lobular carcinomas are usually hormone receptor positive and HER2 negative. In all those cases who are reported by you as invasive lobular carcinomas, I would prefer using e-cadherin. That's a good marker with good sensitivity and specificity to say that this is an invasive lobular carcinoma. But I do agree that I would do e-cadherin, but I would just have a talk with pathologist, and if he's sure enough, confident enough that this is invasive lobular carcinoma, my treatment anyways is not probably going to change upon that part. It will only depend on the pathological stage. Right.
Is it like that invasive lobular carcinoma generally hormone positive?
Yes.
So generally,
yes.
Chemotherapy option is not there most of the time. It is just a hormonal therapy.
Right. That's probably that probably is not the case. When we are talking of an adjuvant intent, that the patient has a local or loco-regional disease and doesn't have a metastatic disease, at that time the treatment would depend on the pathological staging. So a hormone receptor positive T2 or any more disease, if the patient is fit to receive therapy, would receive adjuvant therapy. But what I mean, whether I can escalate or de-escalate is not dependent on lobular type. It will definitely be dependent on the pathological stage itself. So T2 and above, we do, especially in younger patients of less than 60 years of the patients, we do provide and try to give adjuvant therapy. There are various AI tools, or sort of you can say online tools which are available to predict the outcome of various therapies. So predict.breast is one of such tool where we can put in the pathological staging, and we do know, but we can show to the patient that this is the difference that is going to occur with if you take chemotherapy followed by hormone therapy And for example, for that matter, zoledronic acid, for each treatment, this is the benefit that you may receive. And accordingly, we can choose.
Hello. This is my personal question actually. Sir, what are newer trends in treating retinoblastoma as far as medical line of treatment is concerned?
Right.
Because in my days, survival rate of a baby was less than 5 years.
Right.
Nowadays, patient can survive up to almost
Yes, so
50,
most
60
of the
years.
patients, most of the retinoblastoma patients, if they are detected, if they're not stage 4, like there are no brain mets or no CSF involvement, these patients, retinoblastoma is extremely chemosensitive disease. So we have seen such huge masses, and with one chemotherapy going on to get into these exophytic masses, gone on to become this thing. And the systemic treatment followed by surgery, followed by adjuvant treatment is current standard of care. We usually give 12 cycles of adjuvant treatment either before or after. And the survival rates have and cure rates have improved to so much that RB patients later on have go on to develop osteosarcomas because this is the RB gene, and later on that's going to. So you get patients at 30 years and 40 years to have osteosarcomas. Definitely stage 4 cancer. If in case of retinoblastoma, the usual spread is CSF or in brain. In such cases, the survival rate is low, but 5-year survival rate is, I think, anywhere around 10 to 15% for such patients. But local disease up to stage 3 disease, there is a trend that we should not only save the life initially, like in later stage disease, what we do is we try to save this life, and earlier stages we even try to save the vision. So organ and life both are systemically considered.
Sir, last question from online delegate. In Maharashtra, next generation sequencing for malignancy is presently available at which location? And what is the approximate price of the test?
Right. So next generation sequencing is available. Usually it is outsourced. It is available in Pune and it is available in Mumbai. What we do is it is also available at Hyderabad. So various centers like MedGenome and Core, they do it. Next generation, I just skipped that slide because of time constraint. What we do is there are two types of tests. We do hotspot genes and we do next generation sequencing complete. So currently next generation sequencing panels have anywhere from 150 to 250 genes. But what we can do is we can also do a hotspot. We can decide upon these 10 genes or these 7 genes. Various companies have available hotspot tests available. Like in lung, I would like to definitely have EGFR, ALK, ROS, and MET, few of these genes. So there is a hotspot panel for it, and we go for it. The complete 250 gene would cost anywhere around 40 to 50,000, and the hotspot genes would cost around anywhere from 6 to 10,000.
Oh, thank you, sir. Thank you so much.
Thank you.
Thank you, sir, for imparting knowledge about the lesser known facts. Now we can. Now I request Dr. Kane sir and Bhosle sir to felicitate our speaker. Can I please call upon Dr. Vivek Kulkarni sir to present a token of appreciation to our moderator?
Our next speaker is not only an eloquent speaker, but also a devoted teacher. I accord a warm welcome to Dr. Sunil Bhamre sir. To moderate this session, I invite Dr. Lakamvar sir and Dr. Venkatesh Dubevar sir.
Dr. Sunil Bhamre has pursued his MBBS and MD Microbiology from BJ Medical College, Pune. He is currently the Associate Professor of Microbiology at BJ Medical College, Pune. He is editor and chief for Indian Journal of Basic and Applied Medical Research and Copernicus Index Journal, and also associate editor for the International Journal of Healthcare and Biomedical Research and International Journal of Applied Physiology and Anatomy. Sir, the mic is yours.
So thank you and good afternoon to all of you. Thank you, Dr. Snail. Now this is the topic given to me was microbiology laboratory, new approach and new advances in microbiological tests, and also fluid culture methods, newer advances. So whenever we think about the microbiology lab, only three things come in our mind, that is urine culture, stool culture and pus culture. संपलं बाबा. आणि एकदा का सॅम्पल दिलं का पेशंटचा रिपोर्ट येणारच नाही जोपर्यंत तो डिस्चार्ज होत नाही. असं मायक्रोबायोलॉजी लॅब होतं कोविडच्या आधीपर्यंत. म्हणजे डॉक्टर आणि पेशंट दोघं विसरायचे की आपण कोणतं सॅम्पल दिलं होतं आणि काय रिपोर्ट येणार आहे. अशी ही लॅब फक्त कोविड नंतर लोकांना कळायला लागलं की देर आर अदर aspects also in microbiology, that is RT-PCR for COVID-19. And then everybody was searching for MD microperson for accreditation, MD microperson for RT-PCR reporting, and also at that time they came to know that microbiology is also one of the important diagnostic tool for the management of patient. Microbiology people were doing their job but never recognized. After COVID, somewhat little they are now getting recognized. So coming to the facts of microbiology lab, any laboratory which is able to means subdivided into bacteriology, serology, immunology, mycology like kala fungus mucormycosis, and parasitology, and also molecular microbiology, as sir said, sequencing, diagnosis of all infectious diseases. Nowadays, bacteriology is a main part of microbiology that will give culture from here to the nail, means everything from congenital swab, throat swab, ball culture, CSF culture, tissue culture, pus culture, different type of fluid, pleural fluid, like peritoneal fluid, even knee joint fluid, any type of pus. In the serology also, not only antigen antibody, but there are different types of tests like CRP, which we were come across in also COVID period, when CRP range was also very important, one of the criteria for the classification of seriousness of COVID-19 positive patients. Coming to immunology, there are different types of immunology, like sir said, in the histopathology also, immunological part is there, which are the part of microbiology laboratories. Mycology, now it is a need of the time to set up microbiology labs all over the country, in the state also. Molecular microbiology and sequencing. Coming to the molecular microbiology, RT-PCR is one part of molecular microbiology. There are n number of molecular microbiologies, like microarray methods, or in the case of sequencing, is NGS, means new generation sequencing is there, in which nanopore technology is the most advanced sequencing technologies, and whole the microbiology lab is important in the diagnosis of all infectious diseases. Nowadays, there is one approach of diagnosis in the infectious syndromic approach, syndrome detection methods, Means suppose patient is having upper respiratory tract infection or lower respiratory tract infection, that infection is not only caused by bacteria. There are chances of viral etiology, there are chances of parasitic etiology or mycological etiology. Nowadays, there are panels which is consist of most common agents of everything, means bacteria, virus, and parasite also. This is known as biofire machines, which is detecting panel wise. Means if a patient is having meningitis, there is a panel of all the common organisms. Same for the respiratory tract infections. What is the future of microbiology? In the future of microbiology, we will be going towards the automation of microbiology. Automation is not only means what I am doing or what I am plating, one robot will come and plate on the plate. But automation is that we want to decrease the time, turnaround time for each and every test. We want to decrease from culture, we want to decrease to give the antibiogram and related reports. Means nowadays we are recording 3 days. First day will plate it, second day will get the organism, second day will again test that for antibiotics, and third day we will be able to give the reports. Now there are machines or there are techniques which directly plating antibiotics on the samples. Means suppose we are suspecting UTI from the patient, we will plate that urine sample on the media, specialized media, and on that media we will put antibiotics, so that next day morning, if there is a growth and there is inhibition zone around the antibiotic, we will be able to report it sensitive, register, or intermediate sensitive. But this is not aggregated till date by FDA or any ISO accreditation. This is only in. Secondly, this antibiogram in every physician or every surgeon, antibiogram is the important part of microbiology, and it turns into the antibiotic stewardship. What is antibiogram? Suppose E. coli is isolated most commonly from the urine culture samples. Now out of the 100 E. coli, how much number or what maximum number of E. coli are sensitive to which antibiotic? Suppose out of 100, 60 or more than 60 are sensitive to amic acid and gentamicin. Then for the UTI, before waiting or before in between the waiting for culture report, you can presumably start the amic acid and gentamicin. This is antibiogram for one hospital, for one ICU, and for one lab. Means it is antibiogram is always to the specific ICU and specific hospitals. You cannot generalize it. For Parbhani also only one hospital, one ICU, one have antibiogram of itself, and that physician can give antibiotic accordingly. Then for the after studying 1 year of all the samples and all the organism, that hospital can be able to prepare hospitals on antibiotic stewardship. Mean for all the OPD patients, all the ICU, non-critical, critical patients, we can able to give the antibiotics to the physician. Now these are the automatic machines, only Vitek and Bactek. This is the automatic blood culture, and this is a Vitek machine which is able to give identification and ABST pattern within 18 hours. But it is also time consuming machine, but its precision is very good, and it is providing report with MIC and MBC. Now in the serology and immunology, virus detection with viral load is the advancements. What is viral load? In case of RT-PCR positive COVID-19 patient also, in the second wave, in Delta wave, every physician was like what is the CT value. According to that, we can predict the progress of that patient or prognosis of the patient. And if that patient is having any comorbid factors, we can start isolating, we can start giving more attention to the patients. So viral detection is not only important, but the viral load is also important. If you guys are knowing about the NACO guidelines, recent NACO guidelines, they are also now turned to the viral load. Not only HIV positive and negative, but also in HIV positive, according to viral load of that patient, we are trying to give the category of antiviral treatment to the patient, ART treatment to the patient. Now this is the allergy. Nowadays, Patients are coming with food allergies or respiratory tract allergies, skin rashes. In the serology or in the immunological detection methods, you can predict if these are the immunoglobulins, these are the proteins are present in the child, that patient may have this kind of allergies in future. After exposing that antigen for repeated 20 to 30 years, that patient may turn around to the allergic. Now, serological investigation also required paired sera. Means what? We have to repeat testing after 2 weeks. And if there is a double fold increase in the titer, then we have to consider that serum as a Salmonella typhi. This is typically for the salmonella infection. Nowadays, nobody is thinking about that. But irrelevantly, we are labeling non-typhoid patient as a typhoid patients and unnecessarily giving antibiotic to them. Nowadays, what is the future challenges will be in the medical field is that antibiotic resistance, AMR. AMR is antimicrobial resistance. Means like COVID-19, we will be facing pandemic of pan-resistant organisms. Means patient will give the sample, that sample will grow E. coli or clade pneumoniae, and that organism will be resistant to all the available drugs. Then question will be what you will give to them, that patients. So this is the time we have to diagnose and then only give according to the MS value antibiotic to the patients. This is the picture of mucormycosis. Typically in the COVID-19 period, mycology laboratories, we have to establish not only diagnosis, but also antifungal reagent testing methods. You have to implement and you have to start in all microbiological laboratories. Now this is a genotype sequencing. Nowadays, we know first virus was alpha virus, then second was delta virus, then it converted into Omicron. Now there is Omicron, Delta Omicron. Then X4, X2, these are the mutation. How scientists or how laboratory are detecting? By detecting the genotype sequencing. What is genotype sequencing? It is just mapping of every segment of that RNA or DNA of that virus and knowing which mutation is there. In BJ Medical College, under the very efficient leadership of Dr. Rajesh Karyakarte sir, he is a professor head from Aurangabad, very eminent personality. We have able to now starting genotype sequencing, not only for COVID, but for all the bacteria and all the parasites. Also, in the next, we will be trying to, we are going for the metagenome sequencing. Now, what is the metagenome sequencing? Means like bone marrow banks. There is a metagenome sequencing that after the birth of the individual, we will be analyzing, we will be doing all the genotypic mapping of that individual, and that time only, at the time of birth only, we will come to know what are the problems or what are the infections or what are the probability of cancer that individual will be having. So this is the future of microbiology. Early prediction of the host immunity, because in every infection there are three parts. One is the host, environment, and bacteria. Now we are only consulting about the bacteria. Nobody is talking about the host. Is that host? There is one funda of microbiome. Microbiome is the normal microbiological flora of the individual. We are also now trying to set up one international level laboratory for the microbiome studies. In that, we will be following one individual for 1 to 10 years, and we will be seeing the changes in that individual's microbiological flora. Like sir said, one speaker said, when we lost our hair, we also lost our GI tract normal flora. And that is the reason we are getting more common infection through the GI tracts. Also in the cancer, same blood group individuals, same lifestyle, same everything. Most of the people are smoking, but only few people get CA lungs. There is something related to microbiological flora, and that we have to diagnose. This is also one of the most recent advances of the microbiology. And now it will be available in BJ Medical College, Sassoon General Hospital. These are the machines. This one is Illumina. This is the genotype sequencing machine. And this pen drive size, lesser, thinner than my mobile, only 10 centimeter. This is the most recent genotype sequencing machine, that is a nanopore technology. Nanopore technology. You can carry, after loading that machine, you can carry in your pocket and you can go for the movie. After 3 hours, you will have the report. This is the technology developed by Sweden, nanopore technology. Now, what is the future of microbiology? Syndromic approach for the diagnosis and prediction of the infections. These will be the future of microbiology. Syndrome, not only bacteria, viruses, but the one panel which will detect all infectious agent. Then disease can be caused by any agent like this. Then machine panel like BioFire, Multitop. Multitop is in very recent machine which is able to go to the most species level for all bacteria and mostly for the mycological agents, funguses. This is the machine, Multitop. Now coming to the basics, for microbiological report also we required patient history. In the patient history, we require two major important things. One is the age of the patient and second is on which antibiotic that patient is. Because it may happen the pus will be sent for the culture and that will show no growth because that patient is already taking imipenem and meropenem. So there is no chance, though there is a bacteria, but it will be in a dead stage. Appropriate specimen in appropriate container. Sterile container is important, quantity is important, and also appropriate container is important because you cannot send CSF sample in the normal unsterile bulb. You have to send in the sterile containers. As there was one topic, how to interpret the microbiological reports. So this is the typical report showing antibiotics, name of the antibiotic. And second is, I don't know, this got cut, but this is the MIC value. And third is the interpretation of that results, resistant, sensitive or intermediate sensitive. Now it is but obvious we have to use all the antibiotic for every hospital. We have to divide antibiotic into the three groups. One is primary, first line, second line, and reserve line or higher antibiotics. First line are the mostly oral and less cost effective or cost effective antibiotics. Second line are injectable when we have to admit the patient and we have to give the antibiotic. And thirds are the higher level which are having higher cost also and higher side effects also. So this is how every hospital must have their own antibiotic policy. And in also MIC, there is a two basic principle, MIC, MBC. MIC is minimum inhibitory concentration. This is the minimum concentration of the drug which is able to inhibit the growth of the organism. And MBC is the minimum bactericidal concentration. Now these two can be different. Means what? Suppose for imipenem, 8 is the MIC and after MIC, there is no visible turbidity in the tube. We will label it as a MIC value. Okay, then that liquid we have to plate on the blood agar and nutrient agar. And after 24 hours, if there is more than 2 colonies on that plate, it means that it is the MIC value, but not the MBC value. It is inhibiting, but it is not the sidal to the organism. So we have to shift for the one higher level. Means it will be 16 now for the imipenem. Like this. Antibiotic stewardship is the most important part of microbiology. Now most of the hospital may be getting it, or in future every hospital more than 25 bedded, government will be going to compile on NABH, National Accreditation Board for Hospital. So infection control will be the major part. बऱ्याचशा senior most surgeons आणि physicians ला माहिती नव्हतं how to wear the PPE. Me आणि आमच्या बऱ्याचशा microbiologists, we have to take classes for nurses, doctors and every faculty for how to wear, what should be the sequence, how to undo, how to throw, in which bag what to throw. Okay. Then insurance companies will be combined on the NABH and NABL. All HI indicator, hospital acquired infections. All hospital acquired infection. This is a part of infection control. And then now most important is the biomedical waste. Everybody must be taking precautions for this biomedical waste, because this biomedical waste is very dangerous. If you are not taking precaution, you may get the jail for this. Our dean sir was technically arrested for 1 day because one placenta was found on the street, on the bus stop. त्या मुलाने लाल बॅग मध्ये प्लॅसेंटा घेतला आणि जाताना कुत्र्याने झटका मारला, कुत्र घेऊन पळालं, बस स्टॉपवरती सापडला. डीन सरांना एसपी ने अटक केलं होतं टेक्निकली फॉर 1 डे. सो इट इज व्हेरी डेंजरस. बायोमेडिकल वेस्ट इज व्हेरी डेंजरस. सपोज निडल सुया किंवा एकदा लेबल असेल हॉस्पिटल सापडला ना, तर लोकल कलेक्टर विल गिव्ह फाईन ऑफ 1 लाख रुपीज अँड 3 days जेल फॉर द ओनर. मी इथं ठरतं की ओनर कोण आहे, ज्याच्या नावावर हॉस्पिटल आहे तो ओनर. आणि नंतर लास्ट पार्ट इज everyone will be talking about the quality. There will be internal and external quality, not only for the reports but everything from the sample collection, transportation, everything. For NABH and NABL आम्ही दोघं आहोत. ससून जनरल हॉस्पिटल आता NABH साठी चाललंय. NABL आहोत आम्ही, होल मायक्रोबायोलॉजी लॅबोरेटरी, आर्टिफिशियल लॅब सगळं. आम्ही एकच गोष्ट केलेली आहे, व्हॉट वी आर डुईंग, वी हॅव रिटन इट, and what we are written we are doing it. म्हणजे आम्ही जे करत आहोत ते लिहिलं आहे आणि जे लिहिलं आहे ते करत आहोत. दिस इज NABH आणि NABL. तुम्ही जे लिहिलं तेच करा आणि जे करणार आहे तेच लिहा. ओके, थँक्यू. आय एम ए प्रभन. थँक्यू फॉर दॅट.
Thank you very much, sir.
Thank you.
Such a complicated topic you have elaborated very nicely. So I have 1-2 questions.
Please, sir.
Amongst that, the many times sterile pyuria is a terminology, and we used to give assuming that chlamydia trachomatis, which is often it's facing. So how should it be approached?
Yes, sir. Now, sterile pyuria, there is a for urine culture, we have to give the significant bacteria urea value, means 10⁻³ and more bacteria should be there for considering it as a pathogenic. This is the typical case. I am as a bacteriology in charge. Day to day also, patient is having all the symptoms of UTI, fever, dysuria, pain during micturition or burning micturations, and urine is slightly turbid. First cell 8 to 10 per high power field. And on the culture, though we are using clear media, not only blood agar and macon agar, we are trying to use clear media, but also after using clear media also there will be no growth. So this is the typical case that urine sample is collected after first or second dose of antibiotic. Our patient is doing medical shopping, means what? Patient कुठे जनरल प्रॅक्टिशनर कडे गेलाय, 2-3 ड्रग खाल्लेत, नंतर टर्शरी केअर इन्स्टिट्यूटला आलेला आहे. So here we required appropriate history from that patient, and if patient is giving history of consuming antibiotic, in that case any growth we have to take as a significant. I mean even 3 to 4 colonies we have to follow. कारण त्याने antibiotic घेतलेला आहे, significant आपण धरू शकतो.
Thank you, sir.
Thank you.
There is like same question in connection. Asymptomatic bacteriuria, that patient has got that bacteriuria but asymptomatic.
But there is a bacteriuria.
Yeah.
Then
they don't need treatment. It is like that.
Yes, sir.
So how to decide that?
Yes, sir. If patient is not having any symptom and showing bacteria in the urine, it means genital toileting, means genital region is not kept very sterile, means hygiene practices are not good, because while avoiding that urine, common bacteria is coming. If that or E. coli is coming in the urine sample, then we can just give the hygiene to that genital area. But if other than E. coli is there, then we have to start the treatment. If Kleb pneumoniae is there, Proteus is there, Pseudomonas is there, we have to start the treatment.
One more point I would like to add for the Chandak sir. It's ASB, asymptomatic bacteriuria, and ASB it is recommended in pregnancy to start the antibiotics, nitrofurantoin or for that. But apart from pregnancy population, as sir said, we have to go like that.
As a part of precaution in.
Yes, but in pregnancy we have to put for the like nitrofurantoin or that.
Okay, okay. And why this antibiogram changes from hospital to hospital? What is the
Yes,
reason?
sir. Actually, reason is that suppose critical and non-critical. If I am an ophthalmologist, my OPD is for ophthalm, and all the surgeries are as good as sterile surgeries. And second, my colleague is general surgeon, who is operating every day laparotomy, infectious region, GOT surgeries, infectious. His OT and my OT microorganisms will be different. Same for the ICU and non-ICU, microorganism will be different. So it is ideal. It will be plus minus 19-20. Like it is ideal to have your most common organisms for urinary tract infection, for VAP, for central line associated bloodstream infections, and also antibiotic which are sensitive. Even day to day also means after 6 months. Ideally, every 6 months you have to review your antibiogram, and after 1 year you have to revise it. It is ideal. After for same hospital also it will going to change.
No, that is clear.
Yes, sir.
But suppose 2 ICUs have got E. coli.
Yes, sir.
So there also treatment differs.
No.
It's not like
Treatment will be the same.
Okay.
But now recently I am in pipeline for publication of my paper post-COVID UTI patients. And in Sassoon General Hospital, most common UTI organism was E. coli. But now it is converted to clade pneumonia.
Okay.
असं होतं सर.
Right.
Treatment will not change.
Yeah.
Thank you, sir.
Thank you.
What a brain-wrecking session, sir. Thank you for explaining choosing of antibiotics so rationally. And when you told us about the future of microbiology, all of us were realized सितारों के आगे आसमां और भी है. I request Dr. Lakamva sir and Venkatesh Dubewar sir to felicitate our speaker. Dr. Carly sir, will you please present the moderators with token of appreciation? It gives me immense pleasure to invite our budding pathologist, Dr. Chaitanya Khilare sir, who is going to present a very unconventional topic of artificial intelligence in pathology. To moderate this session, I invite Dr. Ravi Kulkarni sir and Dr. Vivek Kulkarni sir. Bonde sir, please moderate this session.
Dr. Chaitanya Khilare sir has done his MBBS from MGM Aurangabad and his MD Pathology from SKNMC Pune. He has recently started his venture as consultant pathologist at Udditi Pathology Lab and Super Specialty Center, Parbhani. He has 10 publications in various journals. His special area of interest, besides in immunohistopathology and liquid-based cytology, are artificial intelligence and digital pathology. This techno-savvy pathologist also runs a YouTube channel for UG and PG students. The mic is all yours, sir.
First of all, I would like to thank the Pathology Association to giving me opportunity to talk over this unconventional topic. After so much, definitely, this conference is because of IMA only. जेव्हा फर्स्ट मीटिंग मध्ये आम्ही डिसाइड करत होतो की टॉपिक कुठले ठेवायचे, त्यावेळेस हा टॉपिक लिस्ट मध्ये नव्हता.
Actually, I am a wildcard entry for this CME because I just shifted from Pune on 26 November 2021 to the Parbhani. And to become an accredited speaker actually was a dream for me. I was trying since 3 years for this same thing. And because of Sagar only, I come to know how to become accreditation. So thank you, Sagar sir, and giving me a chance to put up my topic by my choice. So I would, without wasting my time, because I know this is the last topic, and after so much speakers has been was on a dais, all were DM Endo, DM Heman. I'm a very little bit scared about my topic to talk with this chat. So coming to the So I'm not going in detail for the artificial intelligence. I'm just going through the only 4 points. One, what is meant by artificial intelligence? Second is the what is actually AI means, and what is the use of AI in pathology, because AI is so much in a depth. It is everywhere now in the medicine also. So I'm not going in detail for the medicine or clinical field or everything. I'm just going through the few examples of the AI in pathology and what will be the future of pathology. So basically, whenever the patient come with some signs and symptoms, he will come to the doctor. Doctor will see about the symptoms and will advise the some test to diagnose the case. So what will next happen is he will go either path lab or radiology lab, and then report will come to the doctor. So depend on these reports only, doctor will decide whether this is surgical case or like treatment will be given on the physician basis, or there should be no treatment. So basically, why I'm explaining this, this is called as a workflow in our medicine. This is a basic workflow in a medicine, that patient without symptom will not come to the hospital. He will come always with some symptoms. Then we'll go to the patho for the radio or a diagnostic way. And finally, the clinician will decide whether we have to give us some treatment, we have to the leave patient, or we have to give some aggressive treatment. So this is a basic workflow. I will tell you why I am telling this basic workflow, because basically all these things like clinician decision is based on the pathology or radiological diagnosis. Then only we can give some treatment to the patient. And the journey of pathology in last 100 years, there is nothing has been changed. The microscope is old, same microscope, same slide we are using, but there are some changes which are going to help us in the future, or now they are going to help us for the diagnostic approach. The one thing is ISC immunohistochemistry. Rupesh Gundavar sir has given a very conclusive thing. He has talked so much on ISC. Now second one is the digital slide scanner or digital pathology. Now next revolution was like next generation sequencing, and next to this is AI. So again, for next generation sequencing, Bamre sir and the Kosidikar sir already talk about this. So what basically AI is, just open your mobile and you can see everyone has this screen when we are going to search for the Google anything. There is a one lens. Okay, when we, like for example, I keep searching through the lens. I scan my own spect, and I search with the camera of the lens. What I got is, like, it will ask you to tap the shutter button, and after that you will get the scanning. After that images, you will get the suggestions, like if you want to buy something. So this is very simple. Everybody knows this. In every day we are doing this thing. But to make this happen in the Google, it takes more than the 70 years journey. It's not an easy if you are scanning through your camera a spec and you are getting suggestions that where you will get this spec or similar items on your search list. So this was not an easy journey for anyone, and especially for the technology. So it started around in 1950, when one person thought that machine should have an intelligence and I should check it how much intelligent machine is. So that person was name was the Alan Turing. And in 1956, this term was coined first time. That is the McCarthy who coined this term as artificial intelligence. Now, afterwards, that thing was going on. In 1965, first chatbot was developed. Now everybody has the chatbot in their WhatsApp business account, that if you give a message to someone through the business account, you will get the reply that thank you for contacting yes XYZ, and we will be contact you soon. This is the chatbot, but this chatbot was developed in 1965 first time, and the name was Eliza. So after that, this journey started in 1997, 2002, and 2006. There were so many things happen, but the most important and interesting thing happened in 2002, that the AI-based room cleaner was created. And IBM is the only company, I will say that, who is investing so much since 1997. Actually, IBM started to invest in the AI when nobody was ready to invest in the artificial intelligence, when nobody was thinking that artificial intelligence will be the future. And after 2006, now Netflix, FB, whichever app we are using, that apps are now using this artificial intelligence. I will tell you later on that how they are using it. Now from 2011 to 2014, once we got this box in our hand, we called it as Android phone or Apple phone, that AI is booming. So in 2011, Google now has started, then the Siri, like you ask to Siri to do something, it will do for you. Now everybody knows that touchless, contactless things are coming, like Alexa from the Amazon. So all these things are basically AI-based technology things which are in the market. And lastly, in 2018, the most important revolution come into the market, which is FDA-approved AI-based scope, which can detect the retinopathy in the diabetic patient. So that name is the DXDR. And now we are now using colposcopy also on the same basis. We are getting so many number of instruments in the market which can detect the lesions through only scope or through only photographs or images. So in 2020, the next thing happened that FDA approved, in case of pathology, they approved that the slide scanner use or digital images are acceptable and you can diagnose through the digital images. So that Philips machine got first FDA approved, then the Aperio CS2 and other Leica companies also in the market. So this is a brief history of AI, and these are the persons who actually first termed this coin. That was the Dartmouth conference, and the person who is on the topmost of the left right side, that is the John McCarthy, who coined this term, that is the artificial intelligence. So what is actually artificial intelligence? It is a basically person or machine. So artificial means human made, and the intelligence means wisdom. That is the human made intelligence, which is like just a baby. Like if you see a small kid of one day, how he develop and he become a 21-year adult who is thinking rationally. So this is like artificial intelligence. How the baby is developing, we are developing a machine, we are feeding him some data, to that machine, and ask him to behave like a human. So that means mimic him a human brain. जो हमारी thinking है उसी तरह से machine को think करने के लिए बोल रहे हैं हम. So that is the simple artificial intelligence. So how we see, for example, this is the puppy. That's what we are seeing in our eyes. But when it comes to the machine, machine will not see puppy as a puppy. So machine will process that image by different ways. So this is the one process which is called as a thermal image processing. By that, this is the so many ways image will be captured, so many things will happen in the machines, and then after thousands and lakhs of photographs has been shown to the machine, then machine will able to recognize that when you show the picture of puppy, it will say, okay, it is a puppy. So this is the simple process to learn that how AI is. And if we are using the same, everybody knows that we are using face recognition for opening our mobile. So what they do is they use the same thing in the endocrinology. They provided the photographs of acromegaly, non-acromegaly, or endocrine processes photographs, and they developed a machine. So they develop algorithmic graph with this help of these photographs. And if you show a photograph, machine will detect whether patient is having acromegaly or not. This is the straight away photograph from the article, which is based on the only AI based article for endocrinology. So what is the use of AI in pathology? Basically, so again, for the pipeline, everybody know that we get a biopsy, we cut it, we put it on the slide, fix it, stain it with the HNE, and now we can scan it also and give to the computer, and we can see digital pathology, we can diagnose the case. So this is the basic process. Why this process is very important? Because whenever we want to train something, we should know the process. Machine need a process. मशीन को सीक्वेंस चाहिए, ए के बाद बी आता है, बी के बाद सी आता है, सी के बाद डी आता है, and only after that it will try to learn that 1, 2, 3, 4, 5, 6. So this is the basic process machine should know. And by this process only we can know the where we can use a AI. We cannot use AI in all processes. सारे steps को हम AI use नहीं कर सकते. So why this is importance of AI in pathology right now in this process? Because suppose for example I am counting Ki67 or I am counting mitotic count under my microscope. My microscope is Lynx microscope. If I am giving the same slide to someone or to the Rupesh sir in the Latur, I don't know which microscope he is using, what is the area of field, and again he has to open the book again to see that maybe there are chances that my mitotic index is less than 10, their mitotic index is more than 10. And I think oncologists and oncosurgeons know the importance of mitotic count, because on that basis only newer criteria are coming up. On that basis only you are going to decide the patient is which stage, and on that basis only you are going to give a precise medicine or treatment. So this much important of mitotic count, and we have individual perceptions, because when it is a 20 we don't have a problem, but when it is on the borderline, when we have to decide whether it is less than 10 or more than 10. Because I work in Navle College, there we always say that Lekawale sir will call and tell us ki sir count 10 च्या खाली आहे की 10 च्या वरती आहे. They will not ask 8 to 10. If we are telling sir 8 to 10, no, that is not important for me, whether it is more than 10 or whether it is less than 10. So accordingly same for the immunohistochemistry also, because in the nucleus we cannot count 1,000 cells by our normal eyes. So this is the main issue in the pathology, and this is acceptable. That's why there may be a chances that we are going to miss many cases, or we are going to miss the cases strategy. Like we cannot diagnose the case whether it is in mild form, severe form, or very severe form, because criteria are evolving day by day. Like in 2015 there was some WHO criteria, 2020 there was some another criteria, now 21 and 22 WHO released so many criteria again newly in the CNS, in soft tissue tumors. This is the one gray zone in the pathology where AI is very, very useful. Second thing is that for example, we are in the Marathwada, sir told that we are not able to do a next generation sequence in Marathwada, but we have a cancer patient, sir. So what we will do, because the same thing is for pathologists also, we don't have so much skilled pathologists in each and every area. So this one is the area which is solved by the AI. I will tell you a simple example. AI Shravana 1000 is a machine developed by the Bangalore startup. So you can visit their website and you can see how easily they told that what they can do. Just simply make a smear, scan that PBS smear in the Healy area. For example, one patient is coming with the high grade fever. You just simply, technician will make the smear, he will scan the smear, and that image will be sent it to the pathologist, and he can easily from a far away from 300 kilometers he can see that whether there is a thrombocytopenia or whether there is anything in the PBS. So this is the simplest way technology can be used where pathology is not available, because technicians cannot give the diagnosis of thrombocytopenia on the PBS. He can give thrombocytopenia only by the running sample to the machine. There is a difference between seeing a PBS under the microscope, and there is a difference between giving the thrombocytopenia only by machine parameters. So this is the one example I can tell that. The next one is the workload. For example, you can take an example of Tata Memorial in the Corona 3, like for 3 months in the first wave we were having 3 months lockdown. No pathologist was able to diagnose the biopsies. So many cancer patients were on the street. We know what the havoc was there. So what they did, they brought the Roche scanner. They scanned the slides. They recently published even paper for the same. 600 biopsies were diagnosed from home, including Gujral sir. Everybody was at their home. They were seeing the digitalized slides and they were giving a diagnosis. So that was the one use of digital pathology, which is under roof of the AI again. So now coming to the next is, so whether all these problems been solved by the AI or not. So yes, definitely AI can solve these problems, but how? To learn this how, again, we should know what is exactly AI. Okay, so AI is basically a machine which is doing a task for you. Like a human, that machine is going to do a task for you, and it is a simulation of human brain. There is no such a definition of AI in any literature, whatever I read. So everybody is taking the definition by their own, but the basic is it will be a humanoid brain. So artificial intelligence is actually umbrella of three things. everybody knows now that when we are everybody using YouTube, if we are using a YouTube, we know that there are the thousands of ad before our own video that learn deep learning from machine gun, learn artificial intelligence from this university, learn machine learning from this university. So these are the actually three terms which are interchangeably used nowadays. One is a deep learning, one is a machine learning, and one is a artificial intelligence. So deep learning is something like that. If you are teaching to the machine that 1 + 1 is a 2, 1 + 2 is a 3. Okay. But when machine started to learn that 1 + 1 + 1 is also 3, that is the machine learning. So in deep learning, you give data. In machine learning, machine will learn herself or himself. And then together with this, we are developing one algorithm and we are using it, that is called as the AI. So this is the simplest way to understand these three terms, and these three terms are connected with each other. So in AI, basically currently we are using digital image analysis, next generation sequencing, and natural language program, that is called as the NLP. Out of this, I am going to cover only digital image analysis because due to time constraint, I am not able to cover the NGS and natural language program or NLP. So this is a one thing, the basic thing, that if we are given some data and we want to analyze, for example, for this conference, 400 registrations are there, and I want to analyze this data, I will do it myself on the Excel sheet. So if I am analyzing this data by my human brain, then it is called as the classic computing. So this is a one term, that if human brain is analyzing some data, it is called as the classic computing. If the same thing is done by the computer, it is called as the machine learning. Now next one is if machine is learning, then there are the three things should be done. One is the learning, second is the whether we have taught something to the student, then we have to take an exam, that is called as the validation. So we have to take a test of machine, that is called as the validation. And lastly, the testing. So I will tell you exactly one by one, that is in learning, we will give known cases. For example, I have a set of 100 cases of carcinoma, 100 cases of melanoma, and 100 cases of the sarcoma. I will scan that whole slide. I will label that. I will describe that this is a carcinoma. I will tell to the machine this is a carcinoma. Then machine will learn itself by different processes. And then again, I will give a set of unknown cases. Actually, these unknown cases of set is same in the validation and testing. But the difference in the validation and testing is that in case of the validation, these slides have been pre-scanned. For example, the 300 slides, whichever I have given to the machine already, the known cases, and through which machine learn that these are the carcinoma, these are the melanomas, and these are the sarcomas. But the next time I will give the unknown cases, which is already diagnosed by a pathologist. And then I will ask to the machine whether you are able to differentiate carcinoma, sarcoma, melanoma. If machine is agreed and machine is ready to diagnose, like machine is 99.9% accuracy or AUC curve, that able to diagnose the carcinoma, sarcoma, and melanoma by unknown cases, then I will took the machine in the market and I will give it the slide which is totally unknown, and then machine will able to diagnose that whether it is a carcinoma, sarcoma or not. So big difference between the validation and testing is, in validation, unknown case of set is for the machine but not for the pathologist. It is given by the pathologist to it to check that whether my algorithm is working or not. So this machine learning is actually of three parts or three types. One is the supervised. Supervised means I am giving a label data. Just now I told you that if I am giving a carcinoma, machine will be trained with that data and model will be ready. Now I will test the machine with the model. Again, I will give the next case, which is again carcinoma, but not in the database of the machine. Then it will give output. The output is a super output, and again the correlation is very good in this case of the supervised learning. In case of the unsupervised learning, we give both data, that is the labeled data and unlabeled data. That means if I am giving a carcinoma, sarcoma, which is diagnosed by me and which is in the data set, I will mix the slides of others also, which I will try to tell the machine to learn yourself. So it is a mixed type of the data, which is called as the unsupervised data, and output is actually not that, as compared to the supervised, it is not that much good. The third one is the reinforcement. This is not part of the AI at all right now. But the reinforcement in a small, in one line, I will tell you this reinforcement thing is used in the video games. The developing video games, we are using this. So this reinforcement machine learning is used in the video games. I am not going in detail for this now. So for example, in the medical field, in hematology, if suppose for our aim is to predict outcome based on the label training set, or the example is the predicting survival following the allogenic hematopoietic stem cell transplantation. So if we have a data of 100 cases to whom we did the hematopoietic stem cell transplantation, we take the parameters like age, sex, whatever the diagnosis of the case, MDS or AML, what are the indications to do the stem cell transplantation, and if we give or we feed this all label data to the machine, and next time for the 101st case we put that data to the machine, then machine is able to predict according to parameters and previous knowledge that whether this patient is going to survive or not, if going to survive, how much. So this is called as a supervised learning. The next one is the unsupervised learning. Same thing, but we can use it for B-cell lymphoma, because in the with that we are giving it a gene expressions also. So with that unsupervised learning, output is not that much great, I already explained. And in case of the reinforcement learning, which I am not going in detail for this is based on actually a feedback from the product. So that is a more complicated thing. So under the AI, there are the two things. One is a digital image analysis, which I was talking about. In digital image analysis, there are again two things. One is the featured engineering base and deep learning. So what is actually a featured engineering base means, if we give a figure, I was talking since starting of the lecture that we are showing a photograph to the machine, we are showing the photograph to the machine. What machine will do, machine will segment this thing into the different parts, and then machine will try to read these segments and again join it. So that is called as the segmentation and extraction. For example, if you are showing a tumor cell slide to the machine, first machine will try to break the slide images into small pixels. Then we have to train the machine that this is a nucleus, this is the cytoplasm, this is the stromal cell, this is the lymphocyte, this is a neutrophil. So machine will try to segment first these images, then try to gain the knowledge through these images, and then when next slide will come, it will try to differentiate ki ye stromal cell hai, this is the nucleus and this is the cytoplasm. Now again we have to train that ki nucleus ka contour jo hai wo jo alag galat ho gaya, ya fir you are increasing the nucleolus in the nucleus, or if there is a anterior so is increase or decrease, then it will be a malignant. So that's how you are training the baby machine, and that's how machine will be done. That's why it's very tedious job to develop algorithm, because I just told you one example, 1 plus 2 is also 3, 1 plus 1 plus 1 is also 3. So that 1 plus 1 plus 3 will be learned by machine itself. When you are giving a 1000 photographs of tumor cell, machine will learn that whether NC ratio is matching with the previous or not. Machine will try to get out that ki ye stromal cell hai nahi, because when it is a stromal cell, it will try to get a comparison between the stromal cell data itself in the machine. Then only it will decide ki ye stromal cell hai ya nahi. So that's how machine will learn, and this is called as the feature extraction. This process is called as the feature extraction. So next one is this feature extraction ke baad aata hai deep learning in pathology. So what is deep learning in pathology is just like a convolutional network in our brain. That is, one neuron is connected with the another neuron. For example, machine is breaking down this nucleus. Now machine will try to differentiate to apply different features. For example, color, depth of that image, and n number of filters will be applied for that 1 lakh photographs, and machine will develop himself a network which is exactly like one neuron is connected with the other neuron. That is called as the convolutional neural network, and this is actually a deep learning in the pathology. So the name convolutional network is with our brain, so that is called as the deep learning. So this is the figure where we can see that if you are giving image data, it will be filtered by different things, different filters, and then output will be the more powerful. So this is how we give a figure of, for example, this is we are giving a metastasis lymph node. Machine will see this lymph node like this. Machine will calculate the different morphometry like nucleus size, nucleolus size, contour, cytoplasm like this, and then it will develop a algorithm. And the next thing is when we are using this algorithm, the machine will give us a results. So this is called as the deep learning and machine learning. So now this is the same concept we can use anywhere in the pathology, anywhere from cytology, histopathology, ISC, same thing we can use. Here I am giving an example of one from article that where they use the urine cytology for developing an algorithm, and where they use the both model, machine learning and deep learning. In that they proved that the deep learning model is more precise than the machine learning model. So we can use the same thing for the zinc smear also, where if suppose for example we train the machine that there is a acantholytic cell and multinucleated giant cell, then it is herpes infection. If it is there only acantholytic cell and if there are only neutrophils, then machine will tell it is a pemphigus vulgaris. So like that, this is a ZancNet is a newer startup from the Netherlands, and they are using this now to diagnose the zinc smear. Same thing has been used in the Paris system for the urine also. So there are so many examples of deep learning used in pathology. I am not going in detail for the any examples because there are around more than 150 startups only in India to use the AI in pathology. So this is in class that the machine learning is divided into supervised, unsupervised, and reinforcement. And again, supervised learning will be used and divided into so many different things. So these all are technical terms. Again, I am not going in detail. So what basically types of AI are? There are two types of AI. One is a narrow and one is a general. So general is always a weak, narrow is very precise, so it is a strong. For example, if we are concentrating on playing a cricket only, then it is a narrow. But if we are concentrating on the whole sport, that is including football, cricket, and everything, then it is a generalized. I don't know whether you are aware of this or not. They are trying to use this AI based face recognition system in the newly built up airports. They are trying to give the drones cameras, and they are trying to integrate everything to their Aadhaar links and passports, and they are trying to do that. Once you are entering the airport, there is no need to show your passport to anybody. Just with your face recognition, the machine is going to recognize and give the results with your Aadhaar link numbers and passport links. So this is the AI in general is of two types. One is a general and one is a narrow. The narrow AI, which is stronger, is now developing more than the general, because nobody is interested in generalized things. Everybody is interested in precise. For example, in pharmacology, we want to develop a specific molecule for the specific marker. Then it comes to the narrow AI. But if we want to develop only molecule to covering the all breast cancer, then it will come into the general AI. And it's very difficult to develop this general because it will take so much time to train a machine brain to work like an adult human. So now coming to the last part of this talk, that is the what is the use of AI in different parts. The first one is the diagnostic, second one is the prognostic, and third one is the theranostic. So in diagnostic, we can calculate the tumor burden or invasion of tumor or micrometastasis. This is a newer concept where like less than 2 centimeter or 2 mm, we get the metastasis around or away from the main tumor. Then that will also differentiate the tumor treatment or the patient treatment. So this micrometastasis is the one thing which can be missed by a normal human eyes. So now coming to the prognosis, so sir already talked so much about this because precise medicine is a part of pattern analysis. If you correlate these things, so therapeutics and the prognostic both are important for oncology, because pattern analysis of the patient will give a chance to develop a molecule for precise medicine. I will tell you one simple example, but previously there was no ERPR HER2 markers. Now after that come to the ERPR HER2 markers. If all are negative, then we labeled it as a triple negative. In 2008, we started to develop a vimentin, and we started to develop a drug on the vimentin expression. But what happened next is in 2012, every company in the pharma has give up that thing, because we come to know that again in triple negative also there are the 5 types. So it's not possible now to wait for next 20 years to diagnose this precise medicine thing. Now what we can do is we can use the AI, we can try to correlate our previous year's data which we are already having with us, and we are trying to compare that key ER-PR HER2/neu का अगर हमारे पास पुराना स्पेसिमन है तो निकालो, उसका जेनेटिक स्टडी करो, NGS करो, and then we can see. This is called as the actually biobanking, where AI is too much important. And we are started with the biobanking also in the CNS. In the Madras Medical College, they have developed so much great biobanking that now 20 years data has been preserved. For example, the same example I will take, that they are taking a previous data कि पेशेंट को डेवलप हुआ था, पहले उसको ट्रिपल नेगेटिव बोला था, उसको लिया कोर बायोप्सी को, नाउ नेक्स्ट जनरेशन सीक्वेंसिंग किया, एंड दे कम टू नो कि इतने 16 उसके जीन उसमें म्यूटेट हुए थे. नाउ नेक्स्ट न्यूअर पेशेंट इज कमिंग, वी विल डू दिस 16 जीन्स म्यूटेशन स्टडी ओनली, दैट वी यू आर टॉकिंग अबाउट द हॉटस्पॉट. सो हॉटस्पॉट को कंपेयर करके वो 16 जीन्स हमने उसको लिए, तो नए केस में अगर वो पॉजिटिव आ गए तो इट्स वेरी सिंपल, एआई विल गिव अस अ थिंग कि इसको ये मॉलिक्यूल दे दो. So this is what that much useful now AI is, because this is not, human brain is not able to do this much task. This will be done only by automotive mode only. And the last one is the teaching and assessment. So for teaching purpose, for example, there are the rare cases, and if the rare case is only one in whole area, then how can other pathologists learn this thing, or how he will approach? So here AI can help you all. So next one is the, what is the basic difference between human and AI? So human can speak,
Sir,
human can,
last 5 minutes.
yeah, human can read and write, human can see and recognize the things, see the patterns, and can use his brain. So whereas in the AI, you can see that AI will develop a speech recognition, AI will do the natural language processing, that is the can read and write, then AI can see that, that is the computed vision. Then the next one is the data processing, which is called as the recognitions, and the last one is the pattern analysis done by itself or by neural network. So human can have a fatigue, human can have errors. AI don't have a fatigueness, so that is the one important thing. But errors can be there in the AI also, because if your algorithm is wrong, your diagnosis is wrong, your total thing is on the wrong track. So what is the future of AI basically? Now, until now, we know that pathologists will get a grossing specimen. It will be gross. It will be see under the digital microscope or your own microscope. But now you can use 2 AI tools, either for NGS or next generation sequencer or molecular pathology, or you can give it to the ISC or something. So that DD will be given by the machines, and then again the algorithm is developed basically by the pathologist. Why I'm putting this slide is because there is so much confusion that AI will replace the pathologist. No, not at all. No one will going to replace the pathologist. No one is going to replace the any clinician or any doctor in the world, because this AI is developed by human brain. AI is not creating us. We are creating the AI. So it is our duty to check the whether AI is working or not. But use of AI is that it will give us a time to enjoy in our life. The simple example I will put, last example, that in a COVID-19, everybody knows that कि इसको ऑक्सीजन लगेगा या नहीं लगेगा. After 3 days or 4 days, we will trying to calculate this thing. But after doing that, there are so many now algorithms has been developed after second wave, not by first wave. After the second wave data, they developed a thing that they took the parameters, 16 parameters. Someone took 18 parameters. कि on the day 1, on the day 2, on the day 3, on the day 4. CRP क्या था, ferritin क्या था, hemoglobin क्या था, urine में क्या क्या आया था, biochemistry में क्या क्या आया था. And then they tried to predict by AI कि on the day 1 are we able to predict कि इसको oxygen 5th day लगेगा या नहीं. So if that AI algorithm was developed in first wave also, like it is a bad thing that in second wave we got so much mortality. So this is a one example where AI can save the life also. And the lastly, this is the same lab I am telling you. This right side is showing the old lab which we are using, but with the AI, we can use a cloud server that I can take a second opinion from machine also and from other pathologists also, and I can save my time and patient's time to give the treatment. So lastly, present and future. At present, we are using the phone with the Face ID, filters, smart devices. Grammarly, like everybody knows, we are writing on the Facebook now. If suppose there is a birthday of someone, or if someone is got engaged and we are trying to congratulate him, just go to the comment box. It will already show 2 or 3 sentences. You want to congratulate him, because that Facebook is reading that all posts are regarding congratulations. So you also want to congratulate them. Simple thing. So that is actually AI. Now next, what will be the future? Future, it will be useful for the enhanced homes. There is a very small video on the YouTube. You can see yourself, because again, it will take a 20 minutes to show that video. But there is an enhanced home concept in the artificial intelligence. Autonomous transport. Everybody know Google and Apple are developing the driverless cars. So Tesla already developed that thing. Now next one is the healthcare. I told already there are the image based, so many things are there. The last one is the virtual reality and the enjoyable education. Enjoyable education just now launched by the LG, that the Flex. So we can enjoy the learning also by this AI. Next one is the virtual reality in the pathology. This is the newest topic after the AI in the pathology, where we can see our slides in the 3D form in the virtual reality. So last question is whether it will be useful at the centers where PGs are there, or whether when we are teaching to the fellowships. Yes, definitely it is useful. We are not cheating to the fellows. It will enhance and it will helpful to learn, because first give the slide, ask them to diagnose, and then again check with the AI. It is homework for them. So that will be the helpful for them. There are so many companies which are working already in the AI. So these are the companies, but India is not behind this. These are the topmost 10 innovative companies in India only. And 3,000 crores has been invested in AI in India only. So there are so many machines coming up, even in academic also. American Journal of Pathology already started a scholarship. If you want to develop some projects with the pathology, then they are giving this things. So my take home message is the computational pathology and the artificial intelligence in clinical histopathology service is going to extend in the near future. The second one is the underestimating the understanding the current limitations and challenges are very important, because we are not able to get the infrastructure for AI at every setup. It's not possible right now because of the money constraint. But the newer technology is always going to complement the human resources rather than the replacing them. That's what I was talking, that key. The person who knows AI previously, for example, a pathologist is there and a pathologist who knows AI. So who is going to survive in the next future is the pathologist who knows the AI. That is the simple thing is going to happen in the medical field. So there is a only one reference I am going to quote. This is the very simple article if someone want to read. Rest all, if you want to read, you can ask me. There are more than 150 articles with me. So I am not quoting all articles. Thank you.
Really, wildcard entry was really good. Thank you, Dr. Chaitanya, for enlightening us this highly technical and complicated topic for us. Actually, persons like us who have studied 20-30 years back in the medical colleges, for them, we know the journey of pathology, how it has evolved. And in a lucid and fantastic manner, you have put forward the evolution of artificial intelligence. You have nicely explained the ideas of deep learning as well as other learning, machine learning. You have enlightened us with the interpretation of slides, IHC slides, other slides also, with the different methodologies. Definitely, we can keep hope for diagnostic dilemmas along with the this artificial intelligence therapy. Now, I think the topic is open for discussion.
Nice talk. I think we don't know much about this topic, but grossly what I feel, success may depend on the person who is creating this. Okay.
Yes, sir. Sure.
The person, there has to be combination of a extremely intelligent technical person, but should be supported by equally intelligent pathologist or whichever field. That feeding will ultimately decide.
So absolutely correct that you're talking about this. Those algorithms
How that
already
is
developed
prepared
in
is
the
like
India is been in collaboration with the technical person only.
So there can be limitation if it's so. Suppose it's a field of pathologist, unless he guides in that matter, only technicians cannot prepare. There will be limitations.
Yes, sir.
So
This is the limitation, and that's why IIT
No,
is taking one step ahead for this. They are developing a biotechnology course for especially for the medical students.
Whatever biotechnology they right means the while preparing, apart from highly skilled person, that highly intelligent pathologist also has to be involved.
Yes, sir.
Then only
There is
correct AI can
currently
be-
there is only one PhD from IIT Delhi and AIMS Jodhpur for the especially for the doctors. And the requirement is you should complete at least MD in any out of 18 MD degrees, you should have at least one MD degree to apply for that PhD. So government is in, even central government is also investing on this thing.
Actually, I think Chandak sir is saying that the man behind the machine is more important.
Definitely, sir.
How
It's
you
always
prepare
Yes,
data?
man
How you
behind the
because
machine
if
is
there is
important.
error from man side, AI cannot decide whether it is
and
a
it's-
error from the man side or not.
Only highly skilled technical persons cannot prepare it unless it is supported by extremely intelligent pathologist also. And as you said, it's a human brain, it's a real brain. Ultimately, this is AI. So that is only for support.
But he has mentioned that pathologists with AI will only survive. So we have to know.
Like that I'm saying, but if someone is in having confusion that the pathologist will be replaced by AI, it is not possible at all.
Any
No,
question?
no. That is good thing. I think everybody will take up.
Yeah, definitely. That will take home message from us.
Yeah.
Sir. Actually, I was about to ask the same question. Sir said the man behind machine is important. Listening the lecture, I thought that machine is going to replace the man. I mean, in Indian scenario, in the day-to-day practice, what we came
Sir, it's
across
like
is
like
what we came across is point of care is more preferred than a pathologist.
but sir, this is
So
frankly speaking.
I feel is artificial. What do you feel? I mean, artificial
No, sir,
intelligence, is it curse or a blessing for a pathologist?
See, it will be a topic of debate.
I think Vivek, don't worry, it will never happen because our brain is created by God and where humans are creating that. So don't worry.
Those humans are preferring machines than man. That's why I'm concerned.
No, but basically, sir, I would like to clear one small point that there is a difference between.
We were in a young medical oncologist meet pan India last year before just COVID, and there was a wonderful question put to us. So you are supposed to enact it. So there is a robot that is doing this, just like an AI. There is a robot that is doing it, and there is some mishap has occurred. So how would you encounter a press? How would you encounter the patient? And just tell us how is it going to go? So the medical legal point of view also is going to be
Sir,
extremely important. They're trying it. So how we
Sir,
use
already
that
there
press-
are the see, AI is in very small baby in India, but AI is a very adult baby, or you can call now the boy who is ready to get married in the European countries. So, so already, and there is already a regulatory things. They are already like there are. That's why I asked. There are 150 articles which I read already for this AI from the medical legal perspective. And even medical legal perspective, there are 5 articles. Now there is an association who already formed the norms for this. So for medical legal things from the AI, if you want to do something now, new project in the USA or in the European countries, you need to take a ethical permission. Without that, you cannot do now. So that regulatory is there already. No, sir, like see, even if I am going to lose my job, it's okay, but it is going to beneficial for patients because day before yesterday, there was the AI-based algorithm was developed in India only. I forget the name. And that algorithm was easily able to pick up the sickle cells in the PBS. So that is very beautiful thing and good thing for from the patient perspective. And I would like to clear one point for the Vivek sir that point of care test definitely is curse for us. For as a pathologist, I will agree with that. But AI will not, because AI is something different and point of care test is something different. Because in AI, I told you of an algorithm in the slide that where pathologist in the center, whether you are working with your regular lab or whether you are working with AI lab, The pathologist is the person finally going to give the answer for this. So point of care is something machine has been kept beside the patient. You are running a sample and you are getting a result. AI will never like this. AI will do through algorithm only. And that algorithm will be developed and read by only pathologists. It's like a ISC for us कि immunohistochemistry का अगर ट्रेनिंग लिया है तो वही जिसको रीड करना आता है उसको रीड करना आता है. We cannot give this to oncologist or oncosurgeon कि सर ISC का स्लाइड रीड करो. So that is the same thing कि AI is not going to be a point of care test. What we can do maximum is, for example कि कार्ले सर के पास एक बेबी है और AI का एक माइक्रोस्कोप हमने उसके पास दिया है सर के पास, तो सर उसको स्लाइड दे के स्कैन करवा सकते हैं. बट अल्टीमेटली दैट whatever that machine is doing or taking a figures, it will be on my mobile and only I am going to decide कि whether machine is saying sickle cell है या नहीं. It will give us a DDs कि hemolytic anemia, sickle cell, target cells, this much percentage, because it's very difficult to count more than 20% target cells in the PBS. अगर मेरे पास 50 PBS रोज है और मैं 50 PBS में टारगेट सेल काउंट करूंगा, it's very difficult to find a single sickle cell on the PBS. Very difficult, but it's very easy if you are scanning it, machine is picking it up and giving a photograph to you कि ये sickle cell है. Then we are going to decide कि machine ने बोला ये sickle cell है, machine ने बोला है कि इसके more than 25% target cell है and it is hemolytic anemia. Then it's though, even though we are using at point of care test, it is not going to replace the pathologist. Right. So definitely, sir, cost is important thing when we are doing investment of 20 lakh rupees. But the other part is that if someone is taking a scanner, okay, for example, we brought a scanner and we are asking to the Rupesh sir ki sir हमारा slide scan आप diagnose करके दे दो. But the thing is we can increase our turnover. That the thing is ki if you in the like in terms of business, if you want to save a money, you have to either work with 2-3 people, save the money, get an investment and increase the turnover. कि sample size बढ़ाओ तो आपके पैसे बढ़ जाएंगे.
We will conclude this discussion now. Definitely, sir. Definitely. Thank you, sir. Thank you so much for your wonderful talk on AI and pathology.
Thank you, sir, for being a guiding light on the lesser traveled road. I now request Dr. Bonde sir and I now request Dr. Bonde sir and Dr. Kulkarni sir to felicitate the speakers. May I call upon the stage Dr. G.M. Chandak sir to give a token of appreciation to our moderators. Can we please have Dr. Sanjay Khillare sir to give vote of thanks?
Hello. At the outset, I would like to thank our esteemed speakers who have traveled from Aurangabad, Latur, Pune to give a talk in a city of Parbhani. I'm really Dr. Manoj Tochwal sir on a one call, Dr. Rupesh sir, Dr. Bhamre sir, Dr. Kausarikar sir, Dr. Bhukan sir, they agreed, yes, Vijay, we are going to come definitely. You just let us know the date of the CME and timing for us. So, Dr. A big thank from IMA Parbhani and Pathology Association Parbhani to Dr. Manoj Tochwal sir, Dr. Amal Bhukan sir, Dr. Sandeep More sir, Dr. Rupesh Gundawar sir, Dr. Sripath Kausarikar sir, Dr. Chaitanya Killare sir, and Dr. Sunil Bhamre sir. I'm really thankful to all the delegates from IIM Parbhani and all the delegates who are registered for the CME online, and I'm very happy that we got a huge response from online also. More than 400 registrations have been done for online CME, and for offline also from IIM Parbhani itself, more than 150 registration have been done. So big thank because of all these registrations, and I think it increases the enthusiasm in the organizers to arrange more programs of academic feast. And on this note, I thank all the electricians, all the visual audio staff, all the support staff, catering staff, everyone who have made this program successful. Thank you so much. I ask everyone, please come on the dais for a photograph.
With this, I, Dr. Snehal Kade,
And I, Dr. Shreya Chandak,
sign off for the day. We hope this CME has evoked everyone to apply the information gained today in our day-to-day practice. See you all until next time.
We should appreciate these two anchors. They have done nice anchoring.
Yeah.